Good morning, everyone. APPS and TPPCC Joint Congress 2021 is going to start 30 minutes later. Please don't go away. Come and join us pleasantly.
Colleagues, today I am Professor Zhengong Dai. On behalf of the Faculty Committee of APPS 2020, it gives me the great pleasure to invite you to attend the 6th Annual Scientific Congress of Asian Pediatric Ophthalmology Society to be held in Kaohsiung Medical University, Kaohsiung, Taiwan. The meeting includes plenary lectures, satellite symposium, hero presentation, and exhibition. Experts from different domains will be invited to share their expertise and experience in the field of pediatric ophthalmology that features a world-class scientific program. I would encourage you to attend the APPS 2020 and look forward to seeing you soon. Thank you.
Hello everyone. Have a good day. My name is Ko Hwan Lu. I'm the president of Zhongshan Medical University, Taichung, Taiwan. Also the president of Taiwan Pediatric Ophthalmology and Critical Care Medicine. Welcome to join the international meeting of APPS. Kaohsiung is a very beautiful city in South Taiwan. Welcome to Kaohsiung and welcome to Formosa, Taiwan.
Children are our hearts, our lungs. In Taiwan, we take very good medical care for children, and we are very happy to share and learn experience from friends all over the world. Come on, get ready to be here in Kaohsiung, Taiwan. Trust me, you will have a fantastic journey here. Welcome!
Hello, this is from everybody.
Ladies and
APPS 在高雄 Welcome 台湾高雄。
Good morning, everyone. APPS and TPPCC Joint Congress 2021 is going to start 15 minutes later. Please don't go away. Come and join us pleasantly.
Dear colleagues, today I am Professor Zhengong Dai. On behalf of the Faculty Committee of APPS 2020, it gives me the great pleasure to invite you to attend the 6th Annual Scientific Congress of Asian Pediatric Pathology Society to be held in Kaohsiung Medical University, Kaohsiung, Taiwan. The meeting includes plenary lectures, satellite symposium, parallel presentation, and exhibition. Experts from different domains will be invited to share their expertise and experience in the field of pediatric pathology, the futures of world-class scientific program. I would encourage you to attend the APPS 2020 and look forward to seeing you soon. Thank you.
Hello everyone, have a good day. My name is Ko Lu. I'm the president of Dongshan Medical University, Taichung, Taiwan. Also the president of Taiwan Pediatric Pulmonology and Critical Care Medicine. Welcome to join the international meeting of APPS. Kaohsiung is a very beautiful city in South Taiwan. Welcome to Kaohsiung and welcome to Formosa, Taiwan.
Children are our hearts, our lungs. In Taiwan, we take very good medical care for children, and we are very happy to share and learn experience from friends all over the world. Come on, get ready to be here in Kaohsiung, Taiwan. Trust me, you will have a fantastic journey here. Welcome!
Hello, this is Frank.
Everybody, ladies and gentlemen,
2020年 APPS 在高雄，Welcome台湾高雄。
morning, I'm Professor Mei Zhizhen from Taipei, Taiwan, and the chairman of the Scientific Program Committee of the Congress. It's my great honor and pleasure to announce that the 6th Annual Scientific Congress of Asia Pediatric Pulmonology Society, APPA's 2021 Congress, starts now. This two-day scientific congress is a joint conference including APPA's 2021 and the 23rd Annual Conference of the Taiwan Society of Pediatric Pulmonology and Critical Care Medicine, TPPCC, and the 12th Annual Scientific Congress in Pediatric Pulmonology for 3 places across the strait. The Organizing Committee and Scientific Program Committee sincerely welcome everyone to join us and enjoy the very rich two-day program. Also, please remember to go to our APPA's 2021 websites to watch for the online symposium and our e-posters. Welcome. Our Honorable President of the Taiwan Society of Pediatric Pulmonology and Critical Care Medicine, Professor Chun Ye from Taipei, Taiwan, to give us an opening speech. Welcome, Professor Ye.
Thank you, Professor Zheng and Professor Gary Wang for the introduction. Professor Dai Ren Gong, the chairman of the organizing committee, Professor Lu Guofang, the current president of the Taiwan Pediatric Pulmonary and Critical Care Society, and Professor Zheng Meizi, the secretary of the society, Professor Xie Kaisang, and conscious member of the TPPCC. Ladies and gentlemen, it is indeed a great honor and a great pleasure for me to have a few words at the opening of this Congress. First of all, I'd like to welcome all the participants, particularly those from other parts of the Asia and from the United States. Pediatric pulmonology and critical care is an important and indispensable field in the pediatric world. This is the first time, I believe, to have a joint Congress meeting between Asia Pediatric Pulmonary and Critical Care Society and Taiwan Pediatric Pulmonary and Critical Care Society. The title of the Congress meeting is Smart Pediatric Pulmonology from Asia to the World, which is pointed out clearly the goal of this meeting. The meeting was originally planned 2 years ago as a regular style meeting. However, because of the COVID-19 pandemic, we had to change the virtual meeting. In between, Professor Dai Ren Gong and Professor Lu and all the council members of the TPPCC had to spend hours and hours through many meetings to accommodate to this virtual meeting. Thank very much of their country's effort. Also, I particularly like to thank those from outside speakers, from United States and from other parts of Asia. They are a blend of scholars, experts, and scientists of various disciplines. Finally, Dr. Dai and Dr. Lu, I congratulate and expect the success of this meeting. I wish everyone happy and stay well. Thank you so much.
Thanks for Professor Ye's speech. Now, let's welcome our president of APPS 2021, Professor Zeng Gong Dai from Kaohsiung, Taiwan, to give us an opening speech. Professor Dai, please.
On behalf of the organizing committee of the Asian Pediatric Pulmonology Society Congress in 2021, we are pleased to invite you to attend the APPS 2021 held in Kaohsiung, Taiwan on September 18 to 19, 2021, with the highly skilled technical and advanced researchers in pediatric pulmonology. Many respiratory disorders in children can be managed with better results nowadays than before. Very importantly, as one of the country members of APPS, the Taiwan Society of Pediatric Pulmonology and Critical Care Medicine is honored to take over and host the APPS Congress 2021. The meeting includes friendly lectures, satellite symposia, parallel presentation, and exhibition. Experts from different domains will be invited to share their expertise and experience in the field of the pediatric pulmonology. They feature world-class scientific programs. Due to the pandemic of the COVID-19 all over the world, it's our regret that the attendees are unable to come in person and explore the charming island Formosa. Instead of the physical meeting, we cannot help changing to a virtual congress. We have also decided that each resident can join the congress at no cost. We would believe that this alternative way to make more and more participants to attend the congress and share their expertise. We are very sure that you will have a wonderful experience in APPS Congress 2021. Thank you in advance for your participation. We look forward to seeing you in Kaohsiung, Taiwan in September 2021.
Thanks for Professor Dai's opening speech. Now let's welcome our co-president of APPS 2021 and the president of Taiwan Society of Pediatric Pulmonology and Critical Care Medicine, Professor Ke Huan Lü from Taichung, Taiwan, to give us an opening welcome speech. Professor Lü, please.
Good morning, Professor Chen Puye, the honor president of APPS and TPPCC Joint Congress. Professor Zheng Gongdai, the president of APPS and TPPCC Joint Congress. Professor Vander Singh, the president of APPS. The Professor Angel Engineer, vice president of APPS. The Professor Daniel Kain, the founding president of APPS. Professor Hong Chang Li, the president of Taiwan Pediatric Association, and all our distinguished guests, all the ladies and gentlemen. On behalf of co-presidents of the APPS and TPPCC Joint Congress, welcome to attend the 6th APPS and 23rd TPPCC Joint Congress. Today, we are here for the 6th APPS and 23rd TPPCC Joint Congress in the Kaohsiung, Taiwan, 2021. This joint congress is virtual because of COVID-19 pandemic. The joint congress entirely devoted to pediatric respiratory medicine and critical medicine. At the same time, the conference also holds pediatric pulmonology for 3 places across the street. We invite a lot of famous experts and academic scholars in pediatric pulmonology and critical care medicine from the worldwide to give us a fantastic talk. About 100 papers will be presented in this joint congress. The conference will select outstanding young investigators in related field to give award and will send the hospital that contribute more papers. I wish a great success from this virtual joint congress, and everyone here will have a good harvest. Finally, I wish everyone good health and all the best. Thank you.
Thank you. Thank you, everybody. Good morning, ladies and gentlemen. The beginning of the day starts so wonderful and beautiful. Next session is the guest speeches for APPS 2021 Congress. Let's welcome Professor Zheng Gong Dai to introduce our honorable speakers. Professor Dai, please.
Ladies and gentlemen, good morning. It's my honor to introduce President APPS, Professor Bellinger Singh from India, who is currently Director Professor of the Pediatrics, Lady Hardinge Medical College, and Associated Kalavati Serena Children's Hospital, New Delhi, India. He will give us the important guest speech. Professor Singh, please start.
Good morning. I bring greetings to you from India. On this inaugural session of the joint meeting of Asian Pediatric Pulmonology Society and the Taiwanese Society for Pediatric Pulmonology and Critical Care, I'm indeed very glad to join all of you. I must start by saying that never did we realize that we would be living up to the caption of this Congress, which is smart pulmonology from Asia to the world. COVID had made sure that we have to do it in a smart way or in an e-way rather than meeting physically. That is a different kind of challenge. We were supported by a very able team led by Professor Dai and Professor Lu, who along with Dr. Lai and Sun has organized this conference pretty well. And I am very impressed by the scientific program which has been devised by Professor Meijin on this occasion. This covers almost all the relevant topics. It has a good window of opportunity for young investigators to present their work on a very important and international conference where we have speakers from all over the country, all over the world. And they are going to not only listen to them, but go back with impressions which you will create on their minds and perhaps open opportunities for further collaborations. And that's the ultimate meaning of these meetings, that they should offer us opportunities for further training, learning, to improve the care of children in our nations, and do that very smartly. The world has shrunken. COVID has told us that diseases know no boundaries. They respect no administrative boundaries. They spread all over to all humankind. And therefore, it is imperative on those who are looking after the health care of human beings to interact, forget the administrative boundaries, share the knowledge, and ensure that children, whether in Asia or any other part of the world, get the best care possible. There are learnings which are relevant to maybe only the Asian countries because these are the diseases which are common here. There are learnings from the Western world which are far more progressed, which can be used in a way that we don't have to reinvent the wheel. So I personally feel that this meeting is going to provide us that platform to interact, to learn from each other. I am definitely going to miss meeting all my friends personally and seeing the beautiful country that Taiwan is. I always wanted to be in Taiwan. Never mind, maybe some other time. With these words, I once again thank the local organizing committee and welcome you all the delegates to this Congress. May we all learn together and improve the healthcare of children under us. Thank you very much.
Thank you for the excellent speech from the Professor Singh. Again, it's my honor to introduce Professor Ngo from Singapore, who is the senior consultant at KK Women's and Children's Hospital. Also is the past president of the Singapore Pediatric Society and the president-elect of the APPS. Also will give us the excellent guest speech. And please, again.
For that very kind introduction. First and foremost, I really like to congratulate Professor Dai, Professor Ye, and Professor Lu, and their team for putting together such a comprehensive program amidst such difficult times as we are experiencing with the coronavirus pandemic. Um, as you have already heard, we were supposed to have this meeting last year in Taiwan, and it was postponed because of the coronavirus pandemic. And we were hoping that this year things would settle down and we can finally meet face to face again. But obviously, it was not to be. And we are now meeting virtually instead of being able to see each other in person, um, instead of being in the beautiful country of Taiwan. Um, we've had a glimpse of how beautiful it is from the introductory video. I'm sure it has made many people want to go visit it at some point in time when travel restrictions are relaxed, and so that we can then go on to visit Taiwan in person. But I nevertheless would like to echo what Professor Singh has said. I'd like to really thank Professor Tai and his team for putting together such a comprehensive program for this weekend. I'm sure that we will have a very fruitful and beneficial weekend uh, with excellent speakers planned for today and tomorrow. Uh, and what I would like to also welcome you to and set aside the date for is for next year's APPS Congress, which will be planned by our Filipino colleagues in the Philippines, and it will be in the month of May. So please set those dates aside, the 2nd to the 4th of May. It's likely we are going to have to meet virtually as well, because unfortunately it doesn't look like the pandemic is going to get better very quickly soon. So, but to still set that time aside, so at least we can still meet virtually, if not in person. So thank you again, Professor Tai and his wonderful team, and I'm sure we will have a wonderful weekend. Thank you.
Thank you. Next session is also guest speeches. Let's welcome Professor Ke Huan Lui to introduce our inviting speakers. Professor Lui, please.
Good morning, ladies and gentlemen. It's my pleasure and my honor to introduce our next honorary speaker, Professor Daniel K. Ng. Professor Daniel K. Ng is the founding president of Asian Pediatric Pulmonology Society, as well as the honorary consultant, Hong Kong Sanatorium and Hospital. Let's welcome our distinguished guest, Professor Daniel, to give us a speech. Professor Daniel, can please start?
So good morning, everyone. Welcome to the annual scientific meeting of APPS in conjunction with Taiwan Pediatric Pulmonary and Critical Care Society. My name is Daniel Ng. I am the founding president of APPS, which is actually a lot of you may know. It was founded in the year 2015. Actually, this is historical because right now the world will be divided into pre-COVID-19 and post-COVID-19. So we are in a new norm of the SARS-CoV-2, and we're in the midst of it. So I must thank the organizing committee, especially Professor Dai San Kong, for his tireless efforts to put this virtual congress together, despite the fact that Taiwan has a big workload of SARS-CoV in Taiwan, and you are fighting a war with the vaccines and so on. So my greatest thanks to all my colleagues here in Taiwan. The fact that we are in the middle of a pandemic of the century, it's important for us to remember the founding the guidance of our society is to foster exchange of idea and information between pediatric pulmonologists within Asia. It's indeed important to note that SARS-CoV-2 appear was notified to this world in China. The origin is always debatable, but the first cases were reported from China. And here in Asia, we have been doing a good job to contain the pandemics. I think it's very important for us now in this time of the century to work together to fight this war on SARS-CoV. And I'm sure we'll triumph over this dreaded virus within a reasonable time frame. We may not be able to eradicate this virus, but we are going to find a way to contain it so that it will not be any different from the seasonal flu. So in the next 2 days, you will enjoy a host of very enriched programs from the critical care to pulmonary to sleep medicines. Okay? And I'm sure you will make more connection to the speakers. So for all my audience out there, remember, we are a small family of pediatric pulmonologists in Asia. And if you have any problems, any question you would like to ask to the speakers, you can forward the questions to the secretary after the Congress, and we'll try to connect you with all the speakers and your colleagues. So I hope you all enjoy the meeting. I'm looking forward to welcome you again in the next year. The meeting will be held in Philippines. I hope that we can meet there physically, actually. So with this, I wish you all a safe and fruitful year in this 2021 and the following year. Thank you very much.
Thank you, Professor Daniel, and give us a so wonderful speech. It's my honor to introduce our next honored speaker, Professor Hong Chang-Li. Professor Hong Chang-Li is the president of Taiwan Pediatric Association, as well as the dean of Mackay Children's Hospital, Taiwan. Let's welcome our distinguished guest, Professor Hong Chang-Li, give us a speech. Professor Hong Chang-Li, please start.
Good morning, doctors. I'm Dr. Li, the president of Taiwan Pediatrics Association. I hope all of you are well during the COVID-19 pandemic. As we know, the mortality and the morbidity of COVID-19 was so serious, and you, the experts of pulmonology, should be very easy in the past 2 years. In such a busy day, it is my best honor here this morning to welcome all of you to attend the Joint Congress of ASEAN, Pediatric Pulmonology Society and the Taiwan Society of Pediatric Pulmonology and Critical Care Medicine. In this difficult time of COVID-19 pandemic, the Congress Committee is especially exceptional and praiseworthy to hold this virtual conference of us. Allow me this time to thank the organizers of the important conference. The conference theme this year is From Asia to the World. The Congress has assembled many international experts in the field of pulmonology and critical care to present and exchange their experiences. I'm sure that each of you will identify subjects of interest and will benefit from many inspiring talks and enriched discussions. I sincerely hope you have a succeed Congress and may all of you are healthy and happy. Hope someday in the future you can come to Taiwan and have a beautiful sightseeing. Thanks again and welcome all of you. Thank you.
Thank you, Hong Chang-Li. Give us a so wonderful talk. Thank you.
Thank you for all the speakers and moderators. Now it's time to start the first plenary lecture now. Let's welcome our moderators, Professor B. Tao Huang and Dr. N. Go, to introduce our speaker. Professor Huang, please.
Good morning, my dear co-chair, Professor Ko, and my dear colleague. Welcome to join the fourth plenary section of the APPS TPPS Joint Congress 2021. It is my great honor to chair this fourth plenary section and introduce the most important plenary speaker, Professor Chen-Pu Ye, to you. Professor Ye is the founder of Taiwan Society of Pediatric Pulmonology and Critical Care Medicine. He was born in Taiwan. Following his medical education in Taipei Medical University, Taiwan, he received a complete training on pediatrics and neonatology in Cook County Children's Hospital and the University of Illinois, United States. After that, he joined the faculty of the same hospital, and then he became the professor of pediatrics at the same hospital and the university in 1991. Professor Ye moved back to Taiwan and took the position as the chairman of the Department of Pediatrics and the vice president of the National Cheng Kung University, Thailand, Taiwan. In 1992, Professor Ye granted a PhD degree from the National Nagasaki Medical University in Japan. In 1998, Professor Ye became the president of the National Cheng Kung University, Thailand. During that period, Professor Ye has been elected as the president of the Taiwan Society of Pediatrics, and he is also organized and set up the Taiwan Society of Neonatologists in 1991, and the Taiwan Society of Pediatric Pulmonology in 1998. In 2003, Professor Ye retired from the government service and was appointed as the president of the China Medical University, Taichung, Taiwan. Until 2006, he retired from the presidency, and currently he is an indoor chair professor of pediatrics at both China Medical University and the Taipei Medical University. Today, we are so glad to have him to give us the first primary speech. So, please, Professor Ye, please start your talk.
Thank you for Dr. Huang's introduction. And the president of this meeting, Dr. Dai, and the president of the society, ladies and gentlemen, it's an honor for me to present this study here. You know that bronchopulmonary dysplasia, or BPD, continues to be the most important pulmonary complication in preterm infant following O2 therapy or ventilator therapy. Although the pathogenesis is not completely clear, inflammation may play the central role for the pathogenesis of BPD. Glucocorticoids, particularly systemic dexamethasone therapy, has been shown to be very effective in prevention of BPD. However, because of the long-term side effect, systemic steroid therapy cannot be routinely recommended. Inhaled steroid therapy is technically difficult and the effects are limited. The long-term use of inhaled steroid may associate with infection and with higher mortality. Therefore, it is important to find a therapeutic method that can reduce the systemic side effect of glucocorticoids while at the same time maintain low-carb anti-inflammatory effect of the lung. Thank you. This study is fully supported by KC Pharmaceutical from Italy. Following intratracheal administration of surfactant, there are a couple of factors that may affect the migration of surfactant to the lung periphery. The volume of the surfactant, the injection rate, the gravity and orientation, the ventilatory strategies, the status of alveolar recruitment, and of course, viscosity that may affect the migration of surfactant in the airway. However, the most important factor that affects the peripheral migration or dispersion of surfactant is probably dependent on the surface tension of the surfactant and the surface tension in the fluid in the terminal airway and alveoli. The reason for this migration to the peripheral airway or dispersion to the peripheral airway of surfactant is based on a very physical phenomenon called the Malagonic effect. Malagonic effect implies that in the junction between the low and high surface tension interface, a convection force is created by the surface tension gradient. This convection force will facilitate the movement of the interface to the high surface tension side. The effect can be explained this slide. In the junction between water, which has a higher surface tension, and the soap, which has a lower surface tension, a nice force difference gradient will be created. And this gradient force will go to the higher surface tension side. This convection force can therefore be used as a vehicle for delivery, such as delivery of steroids to the lung periphery. This effect can be demonstrated in animal rats. In the upper panel, we inject 0.25 ml per kilo of isotope labeled F18 budesonide into the trachea. The second panel, we inject the same amount of F18 labeled budesonide supplemented with surfactant, BS. The horizontal line indicates the time after injection, 50 minutes, 20, 30 minutes, 45 minutes, and 60 minutes. As you can see, injection of budesonide alone, majority of the budesonide will remain in the upper airway. On the other hand, if we inject budesonide supplemented with surfactant, substantial amount of budesonide will identify the lung periphery. Using a PET scan to measure the radioactivity as shown in the lower panel, a significantly higher radioactivity among the budesonide was identified throughout the study as compared with when you inject with budesonide alone. Using a different method, if you put a drop of salt over the tail of a paper sailing boat. There's a rapid movement of the sailing boat to the higher surface tension side. We can measure the speed of movement using a digital camera, which can take 100 photos per second. The result of migration speed using different factors are shown in this slide. Apparently, Curacao, perhaps due to its higher concentration of surfactant, migrate much faster than Sabanda. Here, the SDS is industry use surfactant. The migrate speed is 8.5 centimeter per second. Peterson, of course, it didn't affect the surfactant itself, therefore the speed is very low. When you use a Savanta, the speed of migration is 2.755. But when you use Curacao, the speed is very far, 11.277. Therefore, when you choose a surfactant to use as a vehicle, it appears that Curacao is the best choice. Next question is meant to be asked is that if we ate budesonide on the surfactant, would it affect the biophysical stability or chemical stability? Here we measure the surface tension properly using a surfactometer. And we use different concentration of mixture between surfactant and budesonide to run in the surfactometer. And we also measure the chemical stability of the surfactant and budesonide mixture using the HPLC to identify a new compound generated. This is a surfactometer to run. As you know, as you can see that one side we use a surfactant alone, one is using surfactant plus budesonide with a different concentration. But in this case, actually we use more than 50 to 1 ratio of the concentration. Apparently there's no difference between these two, between the surfactant and surfactant plus budesonide. Now, this slide, we directly measured the mean surface tension, minimum surface tension, maximum surface tension. You look this if we use, this is a Sabanda suspension, 25 milligram per ml. The mean surface tension is 19. And when you use budesonide alone, of course, it's very high. But when you use a mixture between surfactant and budesonide, surfactant we use 12.50 and budesonide 0.25 milligram per ml. Run the average surface tension is 20. It's almost similar to just using the surfactant to run the surface tension. Here's 20, here's 19. When we use HPLC with various concentration of surfactant mixture for 96 hours, apparently there was no new compound detected. Therefore, we come to a conclusion that when you use this is Savanda and there is a concentration ratio more than 50, it's not going to affect the physical property, biophysical property of surface. In other words, it will not affect the surface tensions, reducing surface tension power. When we use a Curacao and budesonide more than 160 ratio to 1, it's not going to affect the biophysical and chemical stability of the mixture. So we have a hypothesis at the beginning of the study earlier, about a couple of years ago. We hypothesized that based on the in vitro and vivo study, we thought that surfactant could be used as an effective vehicle for topical steroid budesonide derivative lung periphery. There were two previous study conducted in our group and published in Pediatric 2008. The other one that published in the Blue Journal 2016. In these two studies, the entry criteria are those infants. One is less than 1,500 grams with severe RDS, require intubation and ventilation shortly after birth, usually within 4 hours after birth, and require FiO2 of 0.5. All the infants were randomized into control and intervention group. In the control group, we used Sabanda alone. In the intervention group, we use Sabanda because with a concentration as I mentioned earlier. Well, the results are shown in this slide. With the addition of budesonide to Sabanda, the incidence of BPD or ATLAS was significantly lower in the intervention group, 42%, as compared to the control group, 60%. This p-value less than 0.001. Similarly, when you look at BPD incidence in the intervention group, that's Sabanda and budesonide, 29% have a BPD, as compared to just using Sabanda alone, it's a 50%. This p-value less than 0.001. Now, if you look during this study, as in the dashed line indicate the intervention group, the solid line into the control. In the lower panel is the weaning from excessive oxygen. 20%, 30%, 40%. Now, in the intervention group, the chance of weaning to room air is much, much higher as compared with the control. In the upper panel, the chance to be extubated apparently not much different, but the chance to be weaning to room air is much, much higher in the intervention group by 28 days. Also, we have a chance to look the intratracheal aspirate fluid for some of the inflammatory cytokines IL-1, IL-6, and IL-8. Very interesting is that during the first 12 to 24 hours, most of them they show a lower level of IL-1, IL-6, and IL-8. However, after about 1 week, you see only lower IL-8 in the intervention. In other words, that even just give 1 or 2 doses of budesonide intratracheal to the lung, that suppress the lung inflammation can last for about 1 week. As you can see here, in 70 days after installation of budesonide and surfactant, the IL level is much lower than the control group, suggests that just simply give 1 or 2 doses of budesonide intratracheal with surfactant. The tracheal aspirate suppression of the inflammatory agent can last for about 1 week or even longer. So a summary of this previous study, one is that Sabanda was an effective vehicle for steroid delivery into the lung in very low with severe RDS. Second, 2, intratracheal administration of Sabanda budesonide significantly suppressed lung inflammation and improved the immediate pulmonary status and the subsequent outcome of BPD and BPD or death. There was no apparent immediate adverse effect associated with this study. Pharmacokinetics, we also have a chance to look at the pharmacokinetics study, measure the blood level of budesonide. The pharmacokinetics study demonstrated that this surfactant is a smart biomaterial for the drug delivery. Now, the current double-blind study, we as I say, we have a hypothesis that this new therapeutic regimen perhaps can be used, this therapy can be applied to very low person who had RDS but failed to current therapeutic modality of CPAP and high nasal flow shortly after birth. 2. This therapy could be routinely applied to pregnant infants who require intubation and surfactant therapy. Based on this hypothesis, we will conduct a study. The purpose of the study are 1. Early intratracheal administration of curosal budesonide within 4 to 8 hours after birth would improve the pulmonary status and the subsequent long-term outcome of BPD or BPD of death. 2. What are the associated side effects? Number 3. Is this therapeutic regimen cost-effective and cost-benefit? Now, this time of study, we change the inclusion criteria. We include all infants less than 1,500 grams, and all these infants, or infants who require intubation and resuscitation immediate after birth. And number 3, those very low version who have respiratory distress shortly after birth and fail to another CPAP or high nasal flow within 4 to 8 hours after birth. Now, failure to CPAP and high nasal flow was defined as any one of the following. One is if the FiO2 requirement more than 0.3, or if they require CPAP pressure more than 5 cm water, or in spite of CPAP or another higher flow, the infant show very severe retraction, or have apnea, or the blood gas PCO2 more than 60 mmHg. The exclusion criteria include if the infant have a severe Lisa cardiopulmonary condition at birth or have severe congenital anomaly. Now, in Taiwan, in the last 5 years, we have data showing that the instance based on the instance of BPD or death in the selective group, the control in the study is over 60%. And we expected that following the intratracheal administration of budesonide and curosal, the instance would decrease to 40%. In other words, there's a 30% improvement. If we allow a type 1 error of 0.05 and type 2 error of 0.10, that's a power, 90% power. We estimate that in each group, about 139 infants required in each group. The safe target number in each group will be about 190. The total sample size to be studied is 300. All the infants met the criteria of entry into study were randomized into intervention group, which give curosal and budesonide, or control group, curosal and placebo. The statistician divide this group strictly based on weight, participating hospital, and whether the presence or not of the polioamnitis. We give every 8 to 12 hours for a maximum of 3 doses, unless the infant requires FiO2 less than 0.3 or the infant is extubated. The doses for the first dose, second dose, and third dose and the volume between the control and budesonide showing is stable. In the first dose, in the control group, we give 200 milligram or 2.5 per kilogram of budesonide plus normal saline 1 ml per kilo per dose. This was the first dose. For the second dose intervention group, in the second dose, and this, in other words, this table, I don't have to go to very detailed, but I think this will tell you most of these doses was based on our earlier study in vitro, that is, between curers and budesonide concentration ratio is more than 160/1. Okay, so as you can see here, in the intervention group, we get 200 milligram or 2.5 ml per kilo of dose of curacil and budesonide 0.25 milligram. And if in the control group, we get 200 milligram per kilo of curacil plus placebo is not using the normal setting as a placebo. As you know, normal setting is not going to affect the surface tension at all. Okay, we give maximum 3 doses. Now this slide shows you 2 bottles. Budesonide has to protect from the light. Therefore, we use violet color, and these 2 bottles actually imported from outside. And thank you for Jisen Pharmaceutical Company in Taiwan who make all this for us. And statistician put a label the number on it, so nobody can identify which one is which, what's the content inside. Now, I'd like to, in the next 3 slides, I'd like to briefly present the internal result. And this time we have 200 baby enrolled into the study, but only about 173 discharged from the hospital or die. Therefore, in the control group, we have 76. In the intervention group, 96. Most likely, a lot of babies in the control group still remain in the hospital. Okay. Now, there's no difference between these 2 groups in gender, and this is at the hospital, name of the night hospital, and their birth weight in the control group, 948, in the therapeutic group, intervention group, 937, and gestational age is 27, and this side also 27. There's apparently no difference between these 2 groups at the beginning of the study in terms of gender, in terms of the body weight, gestational age. And here the red color indicates a significant difference between the 2 groups. There's no difference in the mortality. Okay, in the intervention group is 10.31%. In the control group, 11%. But BPD significant difference in the lower instance in the BPD in the intervention group, 41.46%, as compared to in the control group, BPD 63.24. This difference is statistically significant at the p-value of 0.01. Again, when we look BPD or deaths, in the intervention group, 44.33% as compared to control group, 65.79%. This difference is statistically significant. The p-value less than 0.008. There was no difference between the group from this preliminary report in terms of their PTA, IVH, hyperglycemia, high blood pressure. So I like to, although this study is not complete yet, but based on this interim result, I'll give some of the summary here. The instant BPD, 40% versus 63%, and BPD or deaths, 44.3%, 65%, was significantly lower in the intervention group as compared to the control group. The intervention group also needs less doses of surfactant than the control group. The two groups were comparable in instance of IVH, ROP, PDA, and EC, hypertension, and mortality rate. The duration of the initial hospitalization was much shorter in the intervention group than control group, and the medical costs based on payment from National Health Institute, National Health Insurance Company. In Taiwan, almost 100% of the baby covered by National Health Insurance. So the cost paid for the National Health Insurance for the two groups was different. In the intervention group, I counted US dollar about 39,603 as compared to the control group, 5,589 dollars. So for each patient, we save approximately $15,689. Therefore, this therapy appeared to be very cost-effective and cost-benefit. Thank you for your attention. Thank you.
We would like to thank Professor Ye for his very interesting talk about the use of a combination of surfactant with inhaled budesonide for the early management of premature babies with respiratory distress syndrome. I'm sure you would have lots of questions for him. Unfortunately, Professor Ye will not be able to take questions because I was just informed that due to his wife being unwell, he will not be able to join us this morning. However, if you do have questions, please do write it down and put it in to the email that will be provided for you, and he will be very happy to answer those questions with regards to his talk. And I'm sure that many of you will want to ask him several questions with regards to this therapy, because we do know that bronchopulmonary dysplasia has very long-term serious consequences on many of our premature babies. And if we can reduce the incidence of bronchopulmonary dysplasia, this would be a very, very good thing indeed for many of premature babies who are now surviving because of the advancement in therapy and ventilation. So I'd just like to thank again Professor Ye for his very interesting talk. And we will close this session. Professor Huang, do you have anything further to say?
Thank you for the wonderful comments, and thank you, Professor Ye, for wonderful studies.
Thank you for our speaker and moderators. Next session is also a plenary lecture. Since time is limited, please write down your questions and comments into the chat box for the QA after the speech. The moderators will have to ask the speaker after the talk. Let's welcome Professor Zeng Gong Dai to introduce the moderators and speaker. Professor Dai, please.
Ladies and gentlemen, I am Professor Zeng Gong Dai. My dear co-moderator is Danny Wu from Hong Kong and Professor Frank Lu from National Taiwan University Hospital. It's my honor, especially in my home country, to introduce my advisor, Professor Andrew Collins, who is my professor where I study in Children's Hospital. In addition, Professor Frank Lu also learned from him. He's a founder and past president of CIPP, past chief medical director of the Respiratory Division, Children's Hospital Boston, and currently chief of Pulmonary Division of Miami University Hospital. Accordingly, He always our old friend in Taiwan since he had been invited to visit Taiwan several times. Now he will give us the excellent talk. Is pediatric pulmonology where we start and where are we going? Please start a recording a video, please. Please start.
Glad to participate in the meeting of the Taiwan Society of Pediatric Pulmonology and the Asian Pediatric Pulmonology. I was asked to give an overview on pediatric pulmonology in the United States and now at this meeting. I did take the liberty to change the title a little bit to Pediatric Pulmonology, Where Did You Start and Where We Are Going? The good news is that with the pandemic, the glories of the lung were rediscovered in this excellent ode to the lung, an article in the New Yorker, which I hope everybody will have an opportunity to look at to be proud of what we do. The task is, of course, an impossible one since one cannot address it all, and surely you will identify holes in the topic that I will share with you today. But I thought I would try to give you a perspective of what happened in the field, where we are today, and importantly, while presenting the challenges, keep a positive to make attractive the field for a younger generation of pediatricians who will want to join us. So what I ended up doing is use my own personal professional history as the scaffolding, and given my age, the result is a history of the profession since its inception. And because of my numerous transitions between 3 continents, I happened to be there when things occurred, and therefore the presentation has a flavor of a Forrest Gumpian tale. My first day as an intern was to take care of horribly damaged young soldiers who survived the largest armed battle since World War II. You may have seen the series on HBO. It became known as the Battle of the Valley of Tears. It was 1973, and I was in the burn unit, which occupied the entire floor of this large hospital. I was unattracted by the grueling plastic surgery, but was fascinated by the brand new concept of the intensive care unit at the end of the corridor. As I progressed in my residency some 4 years later, I joined the same adult unit, ICU, for a 6-month elective and learned all there was to know on ventilation and lung physiology related to it. And being the only pediatrician in the group, I started the pediatric corner of the ICU, a first attempt to use the concept of intensive care in pediatrics. Realizing the connections to lung disease as a broader concept, I decided to start a fellowship in the field that was not formalized as a subspecialty at the time. And serendipitously, Professor Simon Godfrey moved from London to Jerusalem, and I joined him for a 6-month fellowship that set the course of my career. This is Professor Simon Godfrey, and this is the Hadassah Medical Center where he was functioning. He was a brilliant physiologist, and we started routinely implementing spirometry that was by then largely used in the adult practice to the pediatric lung. And with that, monitor changes in disease and response to therapies. All of you are familiar with the flow volume loop that we now use routinely in our specialty. And here is the example of a flow volume loop that we started to read those days. And it was during those days that the first book on PFT with reference values was published. And here is the book by Pogar and Promadat. And I'm still studying and teaching the complex physiology underpinning the flow volume study. Yet I'm perplexed by how little it is used in general practice despite the availability and simplicity to obtain it. The year was 1980, the decade of the turnaround for pediatric asthma. The impact of the revolution cannot be overstated. The world changed from subcutaneous epinephrine to MDIs and later nebulizers or albuterol for acute asthma, and to MDIs with beclometasone for the chronic condition. Our asthma clinic prescribing these novel interventions while monitoring PFTs changed the face of treatment, and with it dramatically reduced morbidity, admissions, and mortality with this syndrome. Godfrey was also the pediatrician who realized that the notion of Arateus of Cappadocia in the 1st century BCE, that is, from running, gymnastic exercise, or any other work, the breathing becomes difficult, and that is called asthma, could actually be turned into a diagnostic tool. He studied in minute detail the formalized in his book, Exercise-Induced Asthma in Children. It was not only one of the key features to characterize the disease, a notion that is hopefully now understood by every pediatrician, but also was the first to conceive the bronchial challenge by setting the formal parameters for the exercise on the treadmill. And here is the treadmill, and here are the examples of a study that is a positive bronchial challenge. We're also experimenting with more sensitive testing to characterize asthma by exposing the airway to a low concentration of allergens termed specific bronchial challenge, which worked well but was stopped because of anaphylaxis responses. Other safer and highly sensitive modalities of non-specific direct stimulation of the bronchial tree by chemicals were developed elsewhere and led to the methacholine challenge that gained its way into wide use to this very day. And here is an example of how the methacholine challenge is administered. This way was born the pediatric laboratory, the pulmonary lab. We used it for our many asthmatics, but also for cystic fibrosis in my first formal ICF clinic, my earliest rub with a disease that subsequently became a hinge of my future career. With the advent of PFTs in children emerged the question of how we carry the physiology studies to the very young, and particularly how we characterize the nature and morbidity in infantile lung disease such as BPD, that became important with the advent of the newborn ICU and infant ventilation, or the occasional early diagnosis of cystic fibrosis. Here also, Simon Godfrey was a pioneer and developed the baby box, an infant plethysmograph designed to measure lung volumes and their compartmentalization. The instrument was smart, but so complex that each study took hours and could therefore only be used as a research tool, and it was eventually integrated into routine studies after many years, as I will show you later. In the same year, 3 of the brightest minds in the field came together to develop the spirometry equivalent in infants, a concept that was developed by Mary Ellen Wall in Boston that was rapidly increasing the pressure around the very compliant chest wall of infants, and to generate rapid exhalation that could be measured and characterized with markers of obstruction. This was harnessed by Drs. Godfrey, Tausig, and Landau to develop the rapid chest compression test, and here is the schematic of it. The pressure is increased rapidly around the chest, and it was optimal to study them. However, in comparison to the loop that one would get, which is the adult loop, this one is the black one here, these were tiny little loops, and they were called the partial loop, but they created a tool for precise and reproducible studies in sedated infants. An entire literature of infant physiology was created in the years subsequently to use this technology. This 1980 fellowship in pediatric pulmonology also included a formalized first PICU with the early ventilators, but was also emerged with the notion of home ventilation. Our first cases were siblings with Nemelin myopathy who were stable and in school during the day, but went into respiratory failure at night, requiring a tracheostomy and ventilation at night in our ICU. It took a few months to import a small enough ventilator that could be based in and allow home ventilation. Over the years, the chronic ventilator is in specialized unit, and increasing at home has become standard practice in most advanced medical systems, though it remains challenging in poorly resourced country. My early fellowship in the 1980 also saw the introduction of pediatric bronchoscopy, and here is an example of a rigid bronchoscope. It had been used for a century but not very much in pediatric, and essentially all by surgeons. But a movement to make it part of the newly emerging and yet informal pediatric pulmonology was shaping up, led by the Bronchoscopy Institute in Budapest, Hungary, that was spreading the gospel. My fellowship included a number of such procedures, predominantly consisting removal of foreign body. During those years, the recognition of the need for the subspecialty in the field matured during the time in America, and the American Academy of Pediatrics Task Force in 1978 highlighted three issues that probably still reflect what we are and what we should be to date. And these included the rapid development of information concerning pediatric lung disease, encouragement of collaborations between individuals working in different disciplines, primarily in the setting of research, and they pointed out the shortage of pediatric chest physicians. I started then my second formal fellowship at Boston Children's Hospital in 1984 and joined the early giants in the field. The years in fellowship at Boston Children's were largely governed by exposure to the horrors of cystic fibrosis, with some 250 patients at all ages of the center, severe morbidity and common mortality at early ages, including many children. Yet it was mitigated by inspiring mentorship of Mary Ellen Wall, who is shown here, and the awesome Mr. C.F. Harry Schwackman, one of the pioneers of the field. They are unfortunately deceased by now, and this is Children's Hospital. We had an excellent PFT lab in Boston that by then included also plethysmography and bronchial challenge, with the unique technique of cold air instead of exercise as the challenging agents. The lab of the 80s remains essentially the paradigm that still prevails, with the difference that the equipment has migrated from analog to digital system, and obtaining these studies now is simple with the examples of the spirometers, office spirometers that are available to all. By that time in the United States, critical care medicine became its own specialty and frustrated my fascination with ventilators, yet respiratory physiology was much of the focus, with mentors such as Mary Ellen Wall, and also the giants, a couple of giants researchers, Jerry Mead, one of the leading physiology luminaries of the century, and Mary Ellen Avery, who was with us as well, and who together discovered the surfactant and its role in prematurity and forever change the world. This is the quadrangle of Harvard Medical School. The era preceded the genetic revolution, and all the buzz was still on physiology. And I had the opportunity to engage in research on infant mechanics, including using a homemade version of the previously mentioned infant pulmonary function system using rapid chest compression. Little did I know that this skill will impact the coming decades of my life. I also picked up an ambitious research project and spent scores of nights recording infants and children breathing in their homes, lugging around cumbersome equipment. And here is an example. This is the equipment that I was schlepping around, and this is a sleeping child. The digitization of the equipment of the data and complex analysis of the collected data on this analog tape recorder here was my first exposure to the power of computers. We applied the novel methodology using respiratory inductance plethysmography that detect motion of the chest and abdomen with respiration. Here is an example of such a study. The equipment, and non-invasively were able to create from it flow volume loops. And here are some examples of flow volume loops that we study. This was eventually analyzed and published in the Journal of Applied Physiology, and answered the question, at what age does the transition from infantile to the adult breathing pattern occur? This was a good publication, and the answer to this question sounds esoteric to anyone but a pediatric pulmonologist, but it gained acclaim when published in JAP and contributed significantly to the understanding and future studies of developmental physiology in childhood, with the respiratory inductance plethysmography now used as a standard tool to sleep studies around the globe. Upon graduation, I returned to practice in Israel, implemented the knowledge from the fellowship, yet the weakness of the US program in the 80s was inadequate recognition of and training of bronchoscopy, and I therefore spent a further month as a fellow at the magnificent city of Budapest, training at the Bronchology Center headed by Edgar Székely, a master bronchoscopist who claimed 35,000 procedures at the point that I was with him. This is the institute, and this is the typical presentation of Edgar Székely at the bronchoscope. While training was still on rigid bronchoscopy, it instilled in me the confidence to purchase my own flexible bronchoscope. This is a slide of Shigeto Ikeda, the inventor of the flexible bronchoscope, a magic instrument that has dramatically salvaged many children, advanced our diagnostic and procedural ability. And here are images of the flexible bronchoscopy. These are variations of the bronchoscopy image in a healthy child. And here are bronchoscopy images from a child with cystic fibrosis. Here are the multiple secretions. And here is an image of a post-transplantation bronchus. As industry was miniaturizing the scopes, it was hesitantly adopted in pediatrics, largely by the efforts of Bob Wood, who eventually started a US course that I now make sure all my fellows attend to acquire the early skills. And nowadays, all fellows in pediatric bronchoscopy train to become skilled bronchoscopists by the time they graduate from their fellowship training. The 80s saw a surge of interest in sudden infant death syndrome, or SIDS, with a significant body of literature developing around specialized labs that studied sleeping infant and came up with parameters predictive of apnea and presumably subsequent death. This was acted on by home apnea monitoring, and here is an example of a home apnea monitor with literally an industry of thousands of home monitors emerging from it. Much of this work was done at the reputable Mass General Hospital in Boston, and while I was there, the fruitful communication between the training programs in the city gave me a lot of exposure to the work of the center. Therefore, when I went back to Israel, I started the first infant apnea center in the country, and we did full night studies for infants perceived to be at risk for SIDS. The notion of predictability of SIDS, and with that the monitoring industry, came crashing down when revelations of serious breaches in the research underpinning its putative predictive value for death and questionable practices for the United States centers emerged. However, the labs that were created, including our own, became the infrastructure for the emerging new science of sleep medicine in adults and its early application in pediatrics. My companion in the closet-based tiny lab that we had was the young Dr. David Guzal, who is today arguably the world leader in the field of pediatric sleep and recently served as the president of the ATS. In 1990, I returned to faculty at Harvard, made a key part of my job educating fellows, including many fellows from around the world, quite a few from Asia, and some who may be with us today. Some 15 years later, transitioned to the University of Miami, and these were exciting and productive, provocative years, and I will touch on the highlights of my activities over those 30 years as reflective of the evolution of the field and where we are today and where we're heading. I will start with HIV, both because of the hierarchy in my US career, but also because it's being a paradigmatic example of what has been happening in our field. And this is the leitmotif that may be derived from the talk. And it, if you will, also the take-home message of this talk. We are victims of our own triumphs. Collaborations are the key to all our scientific futures. And the magic of science is that it repeatedly comes up with new tomorrows. I rejoined my alma mater in Boston Children's to participate in a huge multidisciplinary, ambitious NIH longitudinal study of infants born to mothers with HIV. It was a collaborative of 9 US centers, including many disciplines, and I was the primary co-PI for our center, with the PI being Dr. Steve Lipschultz, who became one of the world's leading cardiologists. The study afforded us to characterize the early disease as exemplified by this paper by Dr. Meyer Katan and the complex causes of mortality in the paper led by Claire Langston, the Doyen of Pediatric Pulmonology at this era. It also deepened our understanding of lung physiology of infants in general and disease in particular. And here are two examples of papers that emerged from there, led by Dr. Tassos Koumoulis and Dr. Platzker. And to perfect infant PFTs techniques in a multi-center context, which became the backbone for the networks of other centers in the future that were studying diseases such as cystic fibrosis. As clinicians, we also saw the devastations of HIV in children, saw the babies presenting with PCP as a first statement of the immune deficiency, and then with lymphocytic interstitial pneumonia, or LIP, with significant morbidity and mortality, as shown in this slide here. Within a few years, as treatments for the pregnant mothers became more effective, the patient population has essentially vanished from the pediatric pulmonologist radars. However, that HIV may have left its signature and may still require our involvement emerges from recent studies. Our findings in 2001 in this paper show decreased infant pulmonary functions in babies born to HIV moms without themselves being infected. And in this latest study from 2017 on long-term pulmonary functions in adolescents exposed to HIV in utero but not symptomatic, this serves as a reminder that such patients may still have lower lung function as they grow, and we concluded that these functional abnormalities need to be followed into adulthood, and they may constitute some of the future early COPD patients that we'll see in coming years. Another more recent study from 2012 indicated that sleep patterns in young people with HIV may be abnormal and related to detectable inflammatory markers. Much of what we did in pediatric pulmonology had to do with taking care of the large population patients with cystic fibrosis who are becoming older and often sicker. Yet there were positive signs. Early when I came to Boston, we were celebrating the 1989 discovery of the CFTR gene, then helped develop DNase or pulmozyme, the first drug for cystic fibrosis. The intense research of cystic fibrosis with precise genetic and molecular definitions around huge strides in drug development as well as early diagnosis. To summarize the trajectory and history of CF, I will just take a few minutes here to start the review of the revolutions that happened in the history of CF. First was in 1938 when Dorothy Anderson in Columbia described the nature of the disease. Then the 1960s saw the evolution of antibiotics and longevity increasing, and also that adult populations have been increasing, catching up with the pediatric numbers. And in 1989, the description of the gene CFTR. In 2004, the adoption of genetic testing and other testing for newborn screening that changed the face of diagnosis and treatment. And then in 2011, the first CFTR modulator, ivacaftor, that started the revolution. What you see here is the result of the sweat test at baseline or with placebo and the correction thereof with the medication. 2019, the new generation Trikafta, Alexacaftor plus Tezacaftor plus ivacaftor provide clinically robust benefit with a favorable safety profile and shows the potential to lead to transformative improvement in the lives of people with cystic fibrosis who are homozygous, and now we know also heterozygous for the Delta F mutation. This was a publication in Lancet. As in HIV, we have become victims of our success. The revolution of Trikafta that we are seeing now has indeed altered the world of cystic fibrosis. The use of miracle has become cliche, but is the only term to describe the transformation of our sickest patients. While CF may be of little interest to Asian clinicians, the trailblazing science created for cystic fibrosis is the paradigm of how the marriage of clinical science and cutting-edge science will change the face of many diseases. Their breathtaking advances will, I hope, will draw to pediatric pulmonology an increasing number of residents with diverse and varying interests and backgrounds, and will underpin the inevitable future collaborative enterprises. Much like in CF, the implication of these technologies will translate to personalized diagnostics and therapeutics that will extend to other conditions with molecules that alter protein production, as will be exemplified below with nusinersen and gene therapy for spinal muscular atrophy. Among such pathologies where pediatric pulmonologists play a key role is primary ciliary dyskinesia. This slide depicts the complex structure of the cilia and the electron microscopy of it at the backdrop of this motion of coordinated movement by the wind in this cornfield that exemplified what would be happening in the lung with the cilia. The diagnosis has been extremely challenging, but at this point, we're able to diagnose some 70% of the cases by genetic mutations, and surely the next step will be developmental therapy. Perhaps the most dramatic example of treating devastating pathologies are neuromuscular disorders exemplified by spinal muscular atrophies. Nusinersen or Spinraza, and more recently, the Zolgensma, restore the function of the missing or unknown survival motor neuron 1 or SMN1 gene. The prospect for the pediatric pulmonologist is that we will go from the currently largely supportive care of these hopelessly sick children, many on ventilators, and with eventual demise from respiratory complications, to monitoring their growth and ability to perform pulmonary functions. BPD is the next mention. The numbers of patients with BPD are increasing as the survival of ever more premature babies improve. Many of the BPD patients are managed by us in pediatric pulmonology, largely to administer palivizumab or Synagis to protect from the devastations of RSV infection, probably soon to be replaced by novel advanced monoclonal antibodies and possibly vaccines. An extensive discussion on the problems facing the field is beyond the scope of this presentation. Ultimately, however, the big tasks in the field are identification of the genetic underpinning and the inflammatory background of BPD that will lead to improved preventions and therapy, and the role of the pediatric pulmonologist in the multidisciplinary challenge should remain unequivocal. And with that also the topic that I am not really covering, which is pulmonary hypertension. Infant pulmonary function testing by the methodology I discussed before has been a major improvement over the years, and still improved beyond that with the development of the so-called raised volume rapid compression technique. The system became commercialized, and you see here the Collins spirometer, and this is where the baby is lying, and here is the measurement instruments that is put at the mouth. And the too complicated baby plethysmograph that I mentioned earlier was integrated into the same box and dramatically simplifies a determination of lung volumes, as shown in the closed Collins box that is now a plethysmograph. These systems are limited because of high cost and restrictions on sedation in infant. Complementary and alternative methods are being developed, such as the lung clearance index and forced oscillation techniques, and will inevitably become key tools in future studies of natural history and effects of interventions in young patients with various pathologies such as CF, BPD, PCD, and post-infectious conditions such as RSV. Few diagnostic tools can match the advanced technologies that has been seen in radiology over the last 3 decades. They span the entire field of pediatric pulmonology, and let me just give you this example. This is an example of how the advent of CT scan redefined our understanding of severe pneumonia by revealing liquefaction of the lung, and with that, coining the entity of necrotizing pneumonia in pediatrics. Combined sessions with radiology have been amongst the most gratifying and creative of my activities in academia. It offers ongoing cross-fertilization between the radiologist and the clinician bronchoscopist, and collaborations can bring about significant academic productivity, exemplified in this publication of Imaging in Pediatric Pulmonology, a book edited by Robert Cleveland, and with me as the clinical associate editor, and with Claire Langston as the pathology associate editor. Very gratifying result. Bronchoscopy has by now become a staple of the pediatric pulmonology training, with formal courses established around the world. Yet the concept and availability of flexible bronchoscopy has not reached many places in low and middle income countries, a likely factor being the high cost of the equipment, its maintenance, and its training. Again, here our detailed discussion is limited, but mention needs to be made of the ability to now obtain tissue samples through this videoscope. So here is a videoscope. Here are the various sizes that are available to us. And here are the forcepses that are available in the needle for biopsy. And here is the example. Here is the example of a biopsy obtained from a sedated baby, a 3-year-old with a very good quality. And here is an example of the most recent introduction, which is the cryobiopsy, which freezes tissue and allows large tissue sampling, removal of granulation tissue and airways, and revolutionary approach to foreign body removal. Bronchoscopy will remain the realm of pediatric pulmonology and will expand with miniaturization. We should expand also our part in research by expanding the scientific value of bronchoalveolar lavage as a source of non-invasively obtained biological materials for studies. In this context, I would like to mention the emerging concept of aerodigestive programs that serve as a one-stop shop for complex multi-organ conditions. A comprehensive discussion on asthma is beyond this hour. It is, however, important to point out that a report in 2006 from the National Centers of Health Statistics concluded the most current data showed that the challenges of childhood asthma remain and that asthma persists as a significant public health problem. This occurred despite the publication of the NHLBI guidelines and is unlikely to have changed now with the publications of these new guidelines that are 2020. It remains a vastly open field in which collaborative research to define the biology and treatments of the asthmas remains the lofty goal. A collaborative asthma center may be a paradigm to test in some institutions. This slide talks about PSG polysomnography. Here I show you the images of polysomnography, an intervention in the sleep lab with masks and CPAP. Sleep medicine is the co-production of pulmonary medicine and neurology, has exploded worldwide and has emerged over the last decades as an independent specialty and boards in the United States. We should strive to keep this special subspecialty that is largely respiratory physiology based within our realm. I hope I showed you much of what we do, how diverse and intellectually stimulating pediatric pulmonology is. It took off in large parts of the world as a formalized subspecialty with societies and associations, and very much so in many countries in Asia, starting in the 1980s. And here are a number of these societies and academics that I have a long-standing relationship with, including being a proud honorary member in some. Here is the Philippines, Taiwan, Thai, Hong Kong, India, etc. We also now have our own annual meeting in the International Congress of Pediatric Pulmonology, or CIPP, the only congress, global congress, fully developed and fully dedicated for pediatric pulmonology. However, to summarize where we really are today, let me present the following slide. This is a paper by Colaco and Abman from 2018. 30 years after administration of the first board certification examination for pediatric pulmonology, challenges in attracting trainees and sustaining and retaining clinician scientists in the fields have grown. And here is a slide of the workforce in the United States. And what you see here is that the white range regions here have a very small number of pediatric pulmonology specialists. Some of them are becoming a little darker and show here is 0 to 2 certified pediatric pulmonologists for 100,000 population. And very, very few places are the dark ones that have 8 or more per 100,000 population. Here are the states of the United States showing the same numbers. And what it shows you is that the number of subspecialists in the country are really, really small. Here are the states as they go down in the numbers, and we are looking for more and more, and it's difficult to get them. Here is the total distribution over the years, 1989, people showing certification in pediatric pulmonology, and these is the male-female distribution. Females are growing in number, and with that, hopefully, the total number is going up. So there is a lot of work of recruitment. I hope that all the people in this room will participate to improve the recruitment, improve our numbers, and with that, bring more success to our field. To summarize, we are few, but we in it shall be remembered. We few, we happy few, we band of brothers. Thank you very much for having me at your meeting, and I hope next year or the years after that, the APPS meetings will be done in person and we'll meet all of you again. Thank you very much.
Thank you, Professor Andrew Collin, for this very inspiring talk, starting from all the past and going downhill that where we are right now and where we have to make more efforts. Before we start in the QA, we will like to invite Daniel from Hong Kong. He will still give us some words, please.
Good morning, ladies and gentlemen. Welcome to the morning sessions of the APPS TPPCC Congress. I'm your host today, Daniel Ng. Give me great pleasure to introduce the next speaker, Professor Andrew Collin. Professor Collin is no stranger to our society nor to our colleagues in Asia. Andrew graduated from the University of Bologna in Italy. He underwent his training in pediatrics in Israel and in the United States. And he finished a fellowship in pediatric pulmonology in Boston Children's Hospital and went on to become staff there in Boston Children. He moved to the University of Miami about 10 plus years ago, and now is now currently the professor of pediatric pulmonology at University of Miami and the division chief of pediatric pulmonology. Professor Collin has established a lot of firsts in pediatric pulmonology, and he has been a pioneer in this field with publication of different areas of pediatric pulmonology, like the nicotizing pneumonias, and he's also the on the editorial board of pediatric pulmonology for more than 25 years, and he has been made the honorary fellow of the Pediatric Pulmonology Society of Philippines, Hong Kong, Thailand, and Guatemala. So with extensive experience in pediatric pulmonology, it's indeed appropriate for him to talk about where we started in pediatric pulmonology, where did we start, and to look in the future of pediatric pulmonology, where are we going. So may I invite Dr. Colin to deliver a talk, pediatric pulmonology, where did we start and where are we going? Dr. Colin, please.
Thank you, Daniel, for adding some words. And I think it's very honored here to be a moderator and to talk about a living history, actually, for pediatric pulmonology, how it went through all the way to open up and go through all the pulmonary function tests, bronchoscopes, and cystic fibrosis, infection, and asthma. I think it's very, very interesting. And I see there's some chat rooms questions right here for Professor Andrew Colleen. And Professor Colleen, can you answer some questions right now?
Sure. Before I fall asleep, we have a 12-hour difference between the two of us, so it's getting a little late. But anyway, let me just say that can you hear me?
Yes, very clearly. Thank you.
Let me just say again how pleased I am to be able to participate in this meeting, and particularly to see you yourself and Professor Zheng Kong Dai, who probably started your careers in pediatric pulmonology in my division. I'm so incredibly proud to see where you are today. So thank you for inviting me.
Okay, thank you so much. There's a couple of questions. The first is about in the infantile pulmonary function test, how do you think the sedation will interfere or maybe involve or change the pattern of the baby sleeping condition and pulmonary function?
So this was a question that came up a long time ago, whether the sedation itself may affect the parameters that you are studying. And in fact, there were studies in Australia that showed that various types of sedation actually have changed the results of the mechanics of the lung. Eventually, chloral hydrate has been used as the standard sedation and was, I think, widely shown to be benign from that perspective. However, side effects, more perceived, I think, than real, of chlorohydrate have given it a bad name. And so there is a lot of hesitation around the world to use chlorohydrate. And in the United States, there are only a few centers that are able to do these studies nowadays. I think the situation is a bit more relaxed in Europe. Unfortunately, chlorohydrate does have some paradoxic effect. So these studies that require the baby sleep for 20 minutes or 30 minutes sometimes end up with a baby who is screaming for 30, 40 minutes, and the families are obviously very unhappy. So the combination of the difficulty of getting sedation for these babies and the cost of these instrumentations and the need to train people who are expensive to train and expensive to pay salaries for, basically, I think, has brought about a limitation of these studies. I think there are very few people in the world who use them clinically, although I still hope that there will continue to be centers that do them for research, because some of the studies that we do with this type of infant pulmonary function testing cannot be done by any other techniques. So actual flow studies, the same type that we do in adults, and the comparison of evolution of the pulmonary functions flows from babies to adults really require these studies. And one example of how important this is are the studies that came from Tucson and from Padua in Italy that did pediatric pulmonary function testing and followed the patients for a lifetime. And that's why we actually understand what are the trends of pulmonary function testing and how stable they are over time. So that other technologies that are coming up that are simpler will answer some other physiological perspective of the airway, but they will never be able to replicate exactly the questions that we've been answering with the pulmonary functions. I don't know whether you did them in Taiwan. I know that the last time that I was in Hong Kong, actually in Dr. Ning's lab, which I am honored to have visited a number of times and worked together with him and his fellows. The last time that I was there, they actually did do those studies, and I don't know whether they still continue to do them despite all the limitations, but I think it is important.
Thank you, Andrew, for the answering. Because of the time, I just want to ask another short question. You mentioned briefly in your talk about aerodigestive center. When I was in Boston, I also see the center. I think it's very helpful and informative and really keeps the therapy in many, many different aspects can be more comprehensive. What's your opinion about aerodigestive center with pediatric pulmonology and how does it go in the future?
Very important question, and let me just mention, apropos your being in Boston, I think that it is very important to recognize that my research on necrotizing pneumonia that in a way made our center famous. You are the second author on the paper, and you shared the first authorship with Greg Sawicki. So this was an important contribution of yours at the time. And I think that development of fellowships that engage people from around the world have contributed a lot to my own fellows in Boston to give them a perspective about what's happening in the world. The Aerodigestive Center was actually developed originally in Cincinnati by Bob Wood and Dr. Cotton, who was, I think, retired now, an ENT surgeon, with the idea that many diseases have commonality between the pulmonologist, the ENT person, and the gastroenterologist. And the investigation of these children can actually be done instead of a partial investigation by one specialty and then the next day or next month by another and then by another, can actually be collapsed in a single day where everybody sees the child, and at the end of the day they meet and they decide about the conclusions of what they have seen, and then decide which of the specialties need to participate in an intervention such as bronchoscopy. So do we need a bronchoscopy, and should we do a bronchoscopy, an ENT, and a laryngoscopy an endoscopy and a laryngoscopy by an ENT under the same sedation? So I think it has huge advantages. Historically, the center in Cincinnati has absolutely exploded. I think they are seeing something in the range of 5,000 patients per year. When you were there were the time that we started to develop our own center in Boston, which is exploding nowadays as well. And I have to say, not proudly, that it took me 15 years to start to develop it in Miami, but we are now in the fledgling phases of an aerodigestive center. But as a concept, I think it has matured in many, many places. And once you do it, both you and the families discover how important it is and how simple actually it is to collapse it into a single entity. And I think also academic centers love you because I think everybody loves now collaborative studies. Incidentally, we can involve in that, as is the case in Cincinnati, also sleep medicine. And we had radiologists and surgeons who were very active in our center in Boston. So it becomes a much more global and collaborative effort that is benefiting everybody.
Okay, thank you, Andrew, for sharing us with so much things. Because of the time, I have to close this section right now, and we'll go into further. Thank you,
Thank
Andrew.
you very
Thank
much.
you.
I'll see you tomorrow. Bye
Okay.
bye.
Thank you all.
Bye.
Thank you so much. Thank you so much for all the professional speakers and moderators, and especially all of you, the participants.
The Scientific Program Committee sincerely thank you for all of your attendance. Please keep here and enjoy the program with us. Please start the video.
It's morning break time now. Please come back 10 minutes later.
In the meeting room, we have a main room, which is room A, where all the plenary lectures are. We also have a room B that will show the exciting online symposium, e-posters, and nice video shows. For going to room B, go to the participants breakout section that you can find room B in the virtual meeting conference room.
Hello everyone, this is Lexa Ran, the General Manager of Transcore Taiwan. We would first like to welcome you to join with us in the 6th APPS Congress in 2021. Here, we'd like to tell you a little bit about ourselves. Our company was founded in 1986 and it has been in the market for over 35 years. We focus in the fields of thoracic medicine, respiratory therapy, and critical care. Our main products are ventilators of all sorts, from neonatal to adult, MRI ventilator, strong piston-driven high-frequency oscillatory ventilator, mesh nebulizer, single tubing vest system, tissue-friendly PU material feeding tubes. Our mentalities are team-spirited, friendly yet professional, progressive, and we seek all sorts of research cooperation opportunities with hospitals or academia. Here, we'd like to share a little bit more about our products. The first one is our ventilator, Bella Vista Neo. It covers premature to big kids. It is a full-function ventilator, covers invasive and non-invasive modes. It has smart controls, includes auto-synchronize, auto-rise as our unique features. Next is our strong piston-powered high-frequency oscillatory ventilator. Here, you have your dream combination, the strong piston plus conventional mechanical ventilation modes. We guarantee our qualities are powerful, precise, and durable. It covers from premature to big kids up to 20 kilogram guaranteed. It also has patient trigger ventilations via either flow or pressure trigger. Here we have our Aero Mini, the MRI ventilator. This is the one and only MRI ventilator for kids in our market. It's pneumatic driven. It covers from premature to big kids. It protects your MRI just like it protects your little patients. And it's switched from interface to interface without any effort. Next is our vest system, the Smart Vest Therapy, the single tubing vest system. With this therapy, it can greatly reduce hospitalizations, the use of antibiotics, and it can greatly increase the life quality of your patients, and therefore increase the life quality of you, the caregivers. Next is Aerogen, our mesh nebulizer. As you can see in the pictures, it can be connected to different interfaces. It's user-friendly. During this COVID pandemic, this nebulizer is the only nebulizer that can be integrated into closed circuit while used with the ventilators. It has a small size of aerosol that can deliver deep lung penetration treatment. It's quiet and soft, perfect for the kids. Last but not least, our feeding tubes. It's PU material. It has a thin wall. When it connected to the water, it lubricates by itself, so it's smoother to be put into the patient. And you have different sizes that you can choose from. You can also put this tube into your patients for up to 3 months. Style it or not style it, your pick. And it can be easily traceable under x-rays. Thank you for your time. Please give us a chance to introduce our products, and we'll see you around. Have a good day.
Thank you. Welcome back to the main meeting room. Let's continue our plenary lectures. Please remember to write down your questions and comments into the chat box for the Q&A after the speech. The moderators will help to ask the speaker after the talk. Let's welcome Professor Jiayu Chen to introduce the moderators and speaker. Professor Chen, please.
Good morning, ladies and gentlemen. I'm Dr. Jiayu Chen, and my dear co-chair is Dr. Wuyuan Chen. It's a great honor for me to introduce the speaker, Professor An Zhang. She is Professor of Child Health and the head of Child Health Division, Menzies School of Health Research in Darwin, and the adjunct professor, Queensland University of Technology in Brisbane, Australia. She has published over 500 articles. Her major interests are in undertaking clinical research that improve the management of indigenous health, cough, and suppurative lung disease in children. The topic of her special lecture today is Understanding of Bronchiectasis in Pediatric Patients. Professor An Zhang, please start your talk.
Hello, everyone. Thank you for inviting me to present this talk on pediatric bronchiectasis. I do wish I was in Taiwan, as it would have been a lot nicer to see you face to face and enjoying the food and the company. The key message in this slide is that in adults with bronchiectasis, a substantial proportion have bronchiectasis from childhood. As you can see on your left, 60% of adults diagnosed in Melbourne had bronchiectasis from childhood, whereas the one on the right is a study from the UK, where again about 60% had bronchiectasis symptoms aged below 20. Hence, diagnosing bronchiectasis in children and optimal management is actually really important. So over the next 40 minutes, I'll address several things. Firstly, I'll talk about the paradigm, the pre-bronchiectasis state and its reversibility. Secondly, I'll highlight the differences between children and adults. And lastly, I'll talk about the management with respect to traits, targets, and options. So let us first look at the. So we all know that bronchiectasis consists of a process that includes chronic infection, persistent biofilms, inflammation, and a degree of immune dysregulation. This leads to or is associated with mucociliary dysfunction, mucus hypersecretion, and ongoing airway wall damage. The process is not truly a circular process, but it interacts with one another. And with increasing infection and the below processes, you lead to airway remodeling and ongoing disease progression. These can be summarized with the box here, which is the closed vicious cycle. However, what precedes it, and in pediatrics, is it reversible? The answer is yes, And before Cole's vicious cycle begins, there must be a degree of epithelial and endobronchial injury with mucous fluid disruption, and preceding that, a degree of infection, inflammation, atelectasis, and acute respiratory infections, or possibly also problems related to environmental toxicants. So these three preceding processes then leads to Cole's vicious cycle. If you look at it in a clinical manifestation, early persistent infection is like protracted bacterial bronchitis. With increasing clinical manifestation, the next box leads to chronic suppurative lung disease, and lastly, radiological bronchiectasis, which is reversible in the first component, and then later it becomes irreversible. There are, however, intervention points with modifiable factors, and there are also preceding or predisposing factors, and there are also treatable traits. I will talk about these later on in the talk. So the key thing for us as pediatricians is to try and prevent this process of treating PBB effectively is one of the possible preventive factors. So what is PBB? PBB, when it was initially described in 2006 by our group, consisted of a condition where three criteria had to be fulfilled. Firstly, a history of chronic wet productive cough. Secondly, positive bacterial culture in a bronchoalveolar lavage. And thirdly, a response of the cough to antibiotics within 2 weeks of treatment. Clearly, we do not advocate that all children receive a bronchoscopy now. So the second criteria is substituted for the absence of other causes of wet or productive cough. And the original description is now called PBB micro. There is also a diagnostic entity called recurrent PBB, where it consists of more than 3 episodes of PBB over a year. So is there an association between PBB and bronchiectasis? This is a study by Alice Chen, who's actually originally from Taiwan. And she looked at the airway cells from children with PBB and bronchiectasis. And what she found was that children with PBB were in between children who were well and that of children with bronchiectasis. As you can see here, the brown reddish lines are bronchiectasis, and the well kids are the green lines, whereas children with PBB are the blue ones. There is other evidence that we have found, but I'm only presenting the same slide. So if you look at the development of bronchiectasis, at least in pediatrics, we know that it is sometimes reversible. So in the early phases of bronchiectasis, the first airway dilatation that we see is generally just follicular or cylindrical. And with increasing severity, it becomes varicose. And with increasing severity, it then becomes cystic. But in pediatrics, the first stage is actually reversible, and I'll show you some data. So this is one of the key differences between children and adults, but what are the other key relevance? The biological plausibility is that lung growth in children do not stop when they are born. We know that the process of secondary alveolization occurs substantially after birth. And these are the things that we can do as pediatricians to alter their future development of lung growth, i.e. nutrition, tobacco exposure, pollution, treating recurrent or acute respiratory infections, and inflammation. And with PBB, there's ongoing inflammation. So let us look at the key differences with respect to diagnosis, microbiology, prognosis, and psychosocial. I'll start now with the diagnosis. And in the clinical recognition, we know that cough is the most common symptom. However, we have to recognize that the reporting may be an issue in some settings, such as in some of the Aboriginal and indigenous work that I do. We also know that in children as opposed to adults, the cough can resolve with treatment even in children with bronchiectasis. Other symptoms and signs can be present, but they are variable. And generally in children, hemoptysis is not that common, and indeed things like crepitations are also not that common depending on the severity of bronchiectasis. So if you look at a systematic review published several years ago now, you can see that the symptoms of the signs and things like chest wall deformity do vary according to the cohort that's been studied. What about spirometry? If you look at adult publication, they often tell you that a spirometry is abnormal. If you look at this systematic review, it actually does vary, and you can definitely find normal spirometry in children with bronchiectasis. Indeed, the first person to show this was Julie Marchand way back in the early 2000s, when as an early respiratory physician in my training, I was taught that if the lung function is normal, you don't have bronchiectasis. So in Julie's work, where she took children with cystic fibrosis, you can see that in this box, in the circle here, these are children with normal lung function, but they actually do have bronchiectasis as shown in the BALA score, that you can actually have normal spirometry even in CF with a radiological bronchiectasis. And indeed, this is an example of a child with a 3-month history of a chronic red cough. You can see that the child has airway neutrophilia of 23%, and the bronchoalveolar lavage showed H influenza, and you can clearly see bronchiectasis here in the left lower lobe. Now look at this child's FOD results, and you can see that the numbers are entirely normal. Indeed, in the child spirometry, the FEV1 was also entirely normal together with its FVC. So when we looked at data correlating lung function with CT scans in our study, you can see that there was no significant correlation whatsoever, irrespective of the 3 types of CT scan gradings that we examined. But if you look at another study in New Zealand, they found a pretty strong correlation. The key difference between these 2 studies is that our scores were much lower in the Australian study compared to the New Zealand study. As you can see there, our median was 5, whereas in the New Zealand study it was 29. Hence, with spirometry in children with mild bronchiectasis, the values are well within population norms, and there's no correlation whatsoever to CT scans, whereas when bronchiectasis become more severe, it then correlates to CT scans, and generally you would see an obstructive pattern, and later on you may see a mixed pattern, although restrictive patterns has also been found. In contrast, in adults, spirometry is a prognostic factor for both hospitalization and mortality, and indeed is used in the severity and prognosis scores in adults, such as the FACIT score and the BSI score. So this study in New Zealand way back in 2006 showed that with bronchiectasis, spirometry reduces, and indeed this is also adult findings. However, later on, Andy Bush's group showed that with treatment, the spirometry actually improves, as you can see there, a significant improvement after 2 years of treatment, and indeed over 4 years, there was no significant change in the spirometry. However, the older the child was at referral, the poorer the lung function was. At the same time, we also did the study in Brisbane, and indeed we found that there was no decline, and the only predictor of lung decline was actually severe exacerbations. But if they were diagnosed later, their lung function was lower at diagnosis. So what about CT scans? So we all know that bronchiectasis can be diagnosed in several ways. The oldest way was histopathology, followed by bronchograms. X-rays are very insensitive, and bronchoscopy only provides supportive diagnosis. So the current gold standard is the use of HRCT scans. However, the question is, when do HRCT changes occur? This is an example of a child who presented to me with chronic cough, and indeed you can see that in this child's CT scan, it does not quite fulfill the criteria for bronchiectasis. On investigation, this child actually had the primary immunodeficiency, which was CVID. So CT scans do actually have limitations because we know that it's less sensitive than bronchography. In mild bronchiectasis, there is false negative results when the disease is mild. Further, I will show you why the bronchoarterial ratio, which is the key diagnostic criteria used radiologically, is influenced by age. This changes because lung morphology changes, just as our skin and the rest of our body does with increasing age. And the third limitation is that not all CTs are the same. Multi-detector CT scans are indeed much better than just conventional HRCT scans. And your state of wellness as to when the CT scan gets done also influences what you find on the CT scan. So I'll just talk about this in the next couple of slides. So this is a slide from a Japanese group where they looked at the relationship between age on the x-axis and bronchial arterial ratio on the y-axis. And these are adults who do not have any cardiopulmonary disease. And as you can see here, the older you are, the larger your bronchial arterial ratio. And remember, these are normal adults. And the correlation is indeed very strong with an R value of 0.77. If you actually extrapolate this line, where you remember that adults take a ratio of 1 to 1.5 as having bronchiectasis, you can see that if you take the same ratio at a 20-year-old versus a 90-year-old, it's actually really quite different. And extrapolating this line to a 10-year-old and taking the upper limit, you can see here that it should be at 0.7. So taking a single ratio cutoff throughout the long lifespan of an individual seems to be relatively ridiculous. So in this study, Dr. Kapoor, who did his PhD, asked the question, what cutoff should be used in children? And this is a prospective study where we use multi-detector CT scan with HRCT reconstruct in 42 children at that median age there. 2 people independently measured the bronchial arterial ratio, and indeed what we found was pretty close to what was extrapolated in the previous slide, where if you take the mean plus 2 standard deviation, the upper limit is around 0.76, and then we thus suggest that a new cutoff in children should be 0.8 in the appropriate scenario, i.e. a child with chronic wet cough or recurrent respiratory infections. And the next slide shows that not all CTs are the same. Indeed, this is an adult study that showed that there are false negative using just HRCT as opposed to a multi-detector CT scan with HRCT. And in this particular study, the false positive rate was relatively high, where 40 extra lobes were found to have bronchiectasis that were not detected in the 53 adults. So the European Respiratory Guidelines actually do suggest that we use multi-detector CT scan instead of just conventional CT scan, and they also suggest that we should use the pediatric cutoff of 0.8 and not the adult cutoff of 1 to 1.5, and this has just been published earlier this year. I'll now give you an example of why HRCT alone is insufficient. So this is an example of a CT scan of a child who had MDCT plus HRCT reconstruct, where you can clearly see bronchiectasis in those marked areas. So if you take the closest HRCT slide, it's really not that clear here. And if you take the slide above, you will miss the bronchiectasis, and similarly the slide below. So what should you do in clinical practice? We would advocate that in the clinical context of a child with chronic bad cough or recurrent infections, you should take a lower bronchoalveolar cutoff because if you diagnose and treat it earlier, you will reduce the ongoing morbidity and also prevent future irreversible bronchiectasis. We know that the quality of life improves with treatment, and the parents will definitely thank you when the cough actually can disappear with treatment. I have insufficient time, but there is clear-cut evidence that delayed treatment is associated with lung function decline. We also know that children who are at risk of developing bronchiectasis can indeed have normal lung function if they are diagnosed early and appropriately treated. Let us move on to the microbiological differences between children and adults, and again, I'll just highlight the key differences. I will talk about cultural bacteria, microbiota, and others. So what are the cultured bacteria in children with bronchiectasis? In our Australian bronchoalveolar lavage studies, as you can see here, there are varying types of bacteria, and similarly in sputum studies, there are also this is very similar types but different proportions. The key thing is that in children, non-tuberculous mycobacteria are indeed very rare, but it's not that rare in adults. If you look at microbiota and you look at species richness, those children with bronchiectasis are very similar to those with protracted bacterial bronchitis, but there is significant difference from children with cystic fibrosis. However, if you compare adults to children, as you can see here on the left panel, in the whole microbiota as opposed to core and satellite microbiota, again, pediatric bronchiectasis is similar to PBB, slightly different from children with cystic fibrosis, but they are markedly different from adults with either CF or bronchiectasis. So there is a key difference there between. So people used to think that biofilms only occur in the presence of Pseudomonas aeruginosa, but this is a relatively small study, but the first to show that biofilms are also found in children without Pseudomonas, and the small study in 8 children with bronchiectasis and 3 in controls found that none of the controls had biofilms, but in the children with bronchiectasis, 7 of the children had biofilms, and indeed in some children they actually had no high density of bacteria but still had biofilm. These are just a couple of pictures from Robin Marsh's study showing the biofilms in the arrows there. So what about the differences between adults and children with respect to etiology and prognosis? And these are indeed really quite different. You can see in this particular slide divided by high and low income countries in children, whereas in adults it's just divided by places where the studies were undertaken. The key difference is that in adults there is a high incidence compared to children of COPD, asthma, and connective tissue disease, whereas in the children, post-infectious and idiopathic seem to be more common. And I've shown you the differences with respect to spirometry in children, where in the bronchiectasis, the latest study shows that they can improve, whereas that in adults is one subsequent. So I've mentioned a few times that radiological bronchiectasis is totally reversible if treated properly. I'll just show you key things from Galad's study published many years ago now. So he took 22 children and they had 2 CT scans post-medical treatment. Median interval was 21 months. What the study found was that there was total resolution of the bronchodilation in the CT scan 6 and 8 improved substantially. These are a couple of examples from my own patients. As you can see here, there's clear-cut bronchiectasis, whereas 2 years later, the child was totally asymptomatic after aggressive treatment. And there's a little bit of changes here, but the bronchiectasis have totally resolved. This is another child who had bronchiectasis. It's a 3-year-old, and on the repeat CT scan 7 years later, it is totally resolved. Mind, I don't usually repeat the CT scans, but sometimes it is necessary to either reassure the parents or when the symptoms do not match what you clinically think is happening. This is yet another picture showing really severe bronchiectasis in a child who's a migrant, and DCT was done when the child first presented to clinic. It's thought to be related to tuberculosis, but have a look 3 years later, although the bronchiectasis is still present, it is substantially better on a similar cut. So it brings us back to what I mentioned before, that with radiological bronchiectasis, it is initially reversible, but it can then become irreversible, especially in adults, when it is not treated and picked up early. So what I've shown you is really not that new, surprisingly. If you dig up literature from back to the 1940s to the 1950s, people like Walter Finke had clearly stated that bronchiectasis can indeed be prevented. And this is what he said. The belief that not much can be done to avoid bronchiectasis still seems to be deep-rooted. A prophylactic approach has for many years been considered by far-sighted physicians. They realized that the rational therapy should be based upon knowledge of all etiological factors involved and upon proper therapy of the infectious process in its early stages. So what I'm saying is really not that new, as you can see, but it is now only being brought up to the forefront with increasing studies with CT scans. Let us now move on to the psychosocial aspects. Pediatricians know that children are not just little adults. But if you look at what's available with data on bronchiectasis, the research priorities published 5 years ago now by the adult group showed that sputum production exacerbations are the key factors where the adults consider symptoms that affect their quality of life. Children, this is a study that's now in press, and Jeanette Bolt here is the European Lung Foundation person that undertook this survey, and you can see the things that affect the child's quality of life are predominantly physiotherapy, airway clearance techniques, medications, cough, and disease symptom management. If you ask the parents what are the things that affect their own quality of life, the key things is dedicated time for disease management, obtaining medical assistance, and prevention of infection. As you can see, these items are clearly very different from that of the adults. Let us now move on to the last component of my talk. And I obviously cannot go through everything, but just highlight key management points, and I'll talk about traits, targets, and options. Moving now to the management goals, there are a few key things that we aim for. We aim to improve the quality of life of the children and reduce their morbidity and that of their parents as well. The second goal is to reduce and manage exacerbations. Thirdly, to prevent the development of complications of bronchiectasis, such as sleep disturbance, to preserve the lung function, in fact, that can be improved in children. And lastly, at least in a subset, to achieve cure. So these are really quite different with respect to goal number 4 and number 5 in the children as opposed to adults. Given the importance of exacerbations, I'll show several slides on the treatment and the prevention of exacerbations in bronchiectasis. So exacerbations in bronchiectasis are really important for 3 major reasons. One, it is a high priority of patients and parents of children with bronchiectasis. It does pose a huge burden, not just in the quality of life and stress, but in Australia, it costs about $30,000 per admission for each hospitalized exacerbation. Thirdly, exacerbations also have an effect on future outcomes. So adult data have shown that the number of exacerbations predict future mortality, and the high frequency phenotype, i.e. more than 3 per year versus low frequency, is a risk factor for mortality, as you can see with the figures of 2. Also, exacerbations are associated with cardiac events and vice versa. In children, at least in those with PCD, the return to baseline in FEV1 in 3 months is associated with exacerbations, and also with hospitalized exacerbations, there's associated loss in lung function. In defining exacerbations, the European Respiratory Society guidelines have come up with a criteria, and note that these are different from adults. So for clinical purposes, they recommend that the presence of dyspnea, increased work of breathing, and or hypoxia is considered a severe exacerbation irrespective of duration. In adults, they normally take a duration of 2 days. For the other part of the definition, it suggests that the respiratory exacerbation is considered present when the child or adolescent has increased respiratory symptoms, which is predominantly increased cough and or sputum, and or purulence for more than 3 days. Note that the presence of fever, fatigue, malaise, etc. is not necessarily present in children with exacerbation, but of course, if it's present, it's certainly important. So I will go through a couple of studies on the treatment of exacerbations, as there are very few randomized controlled trials in children, and I'd just like to highlight a few, and these relate to exacerbations. These 2 studies have been published in the last couple of years. So the 2 studies have 2 different primary questions, and both relate to the treatment of non-severe respiratory exacerbations of bronchiectasis in children. They're called the BEST studies. So the first question was, do amoxiclav and azithromycin improve the resolution by day 14 compared to placebo in treating children with non-severe exacerbation? And the second question is daily oral azithromycin non-inferior to amoxiclav in achieving an exacerbation resolution by day 21? And these were done by Dr. Lukas Koyal in his PhD with us. So the multi-center studies undertaken in Australia and New Zealand, they were double-dummy randomized controlled trials using a permuted block randomization with concealed allocation by the pharmacist. In both, the inclusion criteria were children aged 1 to 19. HRCT scanned evidence of bronchiectasis and having had 2 exacerbations in the last 18 months. They were excluded if they have severe exacerbation, CF or liver dysfunction, hypersensitivity or current or recent Pseudomonas or NTM infection, or if they've had cancer. So the outcomes were all a priori defined, and the exacerbation was the change in cough or sputum for 3 days, with a resolution defined by the return to baseline for at least 2 days. The outcomes for the primary outcome was resolution of exacerbation by day 14 in BEST 1 and day 21 in BEST 2, and they were also secondary outcomes. The sample size was estimated to be 63 per group for 84% power in BEST 1, and in BEST 2 we had a non-inferiority margin of 20% with 90% power. So this is the consort diagram, and you can see 63 in the moxiclav arm, 67 in the azithromycin arm, and 67 as well in the placebo arm. With the results, the primary outcome, i.e. proportion of children whose exacerbation resolved by day 14, in the placebo group there were 43, in the moxiclav group it was 65%, as you can see there, significantly favored moxiclav with a number needed to treat of 5. And in the azithromycin arm, the number needed to treat was 6. Even though some in the placebo arm resolved by day 14, you can see that the duration to resolution was substantially faster in the moxiclav arm with a p-value of 0.018. And although that in the azithromycin arm was also faster, it was not clinically significant compared to placebo. This is best 2, and just to show that the groups are evenly matched. And as you can see there, non-inferiority was actually achieved, as you can see with the 2 lines, both in intention to treat and per protocol population. So for preventing exacerbations, this is the European Respiratory Society recommendation. The question was asked as to whether long-term macrolides should be used to reduce exacerbations, and this is the recommendation, i.e. they recommend long-term macrolides in those who have had more than 1 hospitalization or more than 3 or more non-hospitalized exacerbations in the last 12 months. However, they caution that the course should be used for at least 6 months, and the children should be reassessed as to see or not whether they still need continuation of their macrolides. Evidence is shown there. It's actually high evidence, but in the actual recommendation it says low, but that's because the critical outcome is chosen based on the lowest level taken for any critical outcome that's been chosen for the PICO. So clearly, even though there are randomized controlled trials in children, we are far behind that for adults. This study led by James Chalmers was published recently in New England Journal, and there's been substantially more studies and bigger sample size in adults. So we in children have a long way to go with respect to producing more evidence and better studies compared to our adult colleagues. So we have management principles in the treatment of bronchiectasis, and I clearly can't go through everything. The key thing is to diagnose early and look for treatable etiologies. We need to reduce the infection and inflammation cycle, and we can do that by treating exacerbations early and aggressively, including the use of intravenous antibiotics when necessary. We know that airway hygiene and clearance is important, and we also know that vaccinations are important. And the second group is to look for ways to improve contributing factors such as attention to nutrition, to detect complications and look for pollutions that could trigger exacerbations, and to promote exercise. Thirdly, we also need systematic care, i.e. they need regular review and multidisciplinary care. We need education to enhance self-care and management. These are outlined in the European Respiratory Society guidelines, which was published earlier. So to highlight the treatable traits, this is a concept that clinicians have been using for many years, or decades I should say, but this is a recent concept where it's been grouped, and I won't go through everything, but just to say that the concept is around underlying disease, infections, inflammation, comorbidities, and general or generic modifiable factors. So in summary, I hope I've shown you the paradigm of development of bronchiectasis in children, where a substantial proportion can be prevented by looking at the preceding factors of bronchiectasis. I've shown you some similarities, but outlined the key major differences between children and adults, predominantly related to the radiological diagnostic criteria, the prognosis, as well as some of the microbiological factors. And lastly, I've shown you the management principles highlighting traits and new evidence. A lot of this work is done in conjunction with my collaborators. That's very many across the world, the funding bodies from the grants that I've received. And a lot of this work has been done by my postdocs, PhD students, scholars, and my staff. And I'd like to thank my wonderful staff. This is a recent picture, and in COVID times, we've also had mask on. So thank you again very much for inviting me to present this talk, and enjoy the rest of your conference.
Good morning, ladies and gentlemen. Good morning, Professor Jiang. I am Dr. Chen Wuyuan. It is a great honor for me to co-moderate Professor Jiang's speech with Professor Chen Jiayu. Thank you very much, Professor Jiang, for giving us a fantastic lecture on such an important topic. The time is tight. May I have a short question for Professor Jiang? Professor Jiang, on the line,
Yes.
right?
Yes,
Oh,
I am
thank
on
you.
the line. Thank you.
Yes. What is the major problem in diagnosing and treating this disorder, especially for primary pediatrician? Thank you.
I think the main thing is actually recognition, but because for bronchiectasis you need objective um, diagnostics, so you need a CT scan. And I think in primary health, they, at least in children, we don't normally advocate that primary health physicians do a CT scan. I think they really should be referred to a pediatric pulmonologist, because CT scans, at least in Australia, if it's done in the private world, they often use higher radiation doses, and it's really important to try and look for the underlying etiology as well. So I really would advocate that if the child has a phenotype of bronchiectasis and you suspect it, they really should be referred to a center that can evaluate the child fully in terms of looking for an underlying etiology and looking for treatable traits and obtaining an objective diagnosis.
Okay, thank you very much. And we have a question on the board. And the question is, what is the role of azithromycin in bronchiectasis? How long should we use it? Thank you.
So we did a study back in 2013, which was the first one in children. In fact, we started the study before the adults published. We actually found that if you give them prolonged azithromycin, in our study, we used 2 years. You drop the exacerbations by half, and you also drop the hospitalizations. So we do use azithromycin in children who have more than 3 episodes a year, or if they've been hospitalized. If you're going to use azithromycin, we actually recommend that you use for at least 6 months, because if you use it for too short a period, it's hard to determine whether it's efficacious or not. But you also should not use it forever. We would advocate that they get evaluated at least after a year to consider taking them off azithromycin because of the possibility of inducing macrolide resistance in these children. I know the adults use it for much longer. In my clinical practice, depending on their age, sometimes I go for 6 months, just over the winter period. If they are really young, I would go for at least a year. Sometimes I go even for 2 years, and then take them off azithromycin and see what happens. And sometimes you just have to put them back on azithromycin again. It's no doubt that it is efficacious. The question is the when you should use it, and how long you should use it for. But there's no good data as to exactly when, so what the cutoff should be in terms of exacerbations and for how long. But our original study was actually for 2 years. The adult studies are for 6 months and 12 months, and all the studies are actually efficacious.
Thank you very much, Professor Jiang. Our time is up. Thank you all for your participation. Now we shift to the next topic. Professor Wu Junren, please.
Thank you for the moderators and speakers. Let's continue our plenary lecture. Let's welcome Professor Junren Wu to introduce the moderators and speaker. Professor Wu, please.
Invitations for the moderator. I'm Junren Wu from Taiwan, and my co-director is Ethan Chen. The next speaker will be the Rashman Remedies. He is the professor of pediatrics in Southwestern University in Texas, Southwestern Medical Center in Texas. And now we will. I think the Dr. Eng Yi-zhen he works together there for 2 years. So I will invite Dr. Chen Yi-zhen for further introduce of his mentor. Thank you, Dr. Chen.
Hello everyone. I'm Dr. Chen, and you can also call me Jenny. Rashmi is here, and Professor Rashmi Savani was my mentor when I was work in the University of Texas Southwestern Medical Center in Dallas, Texas, from 2018 to 2020. It's a pleasure to work with Rashmi. He is kind, generous, and opened his mind to me, who was just a stranger, and only sent him a CV and the study purpose by email. Dr. Savani is the director of the neonatal perinatal medicine in UT Southwestern Medical Center and the associate director of the Center of Pulmonology and Vascular Biology. Dr. Savani was renowned on many researches, especially focused on lung injury and bronchopulmonary dysplasia, lung vascular biology, and the role of hyaluronic acid in tissue injury. So in Savani's lab, I ever used the transgenic mice to study the mechanism of BPD. I believe he has a novel strategies to prevent bronchopulmonary dysplasia. Now let's welcome Professor Savani Rashmi. Okay, please start.
Hi, my name is Rashman Savani. I'm from University of Texas Southwestern in Dallas, Texas, the United States. It's a real pleasure for me to speak to you at this prestigious conference, the Asian Pediatric Pulmonology Society. And I particularly want to thank JT Xia and Jenny Chen for the invitation to present at this conference. It was a joy for us to have Jenny in our lab for 2 years, and I will be presenting some of the work that she created as well. So I've been tasked to talk to you about novel strategies to prevent bronchopulmonary dysplasia. My disclosure is that I am on the scientific advisory board and have a sponsored research agreement with Mallinckrodt Pharmaceuticals, and I'm the founder and head of the scientific board of Airborne Therapeutics Incorporated. I'm also on the National Scientific Committee for the March of Dimes Innovation Fund. None of these conflict with what I'm about to present to you. So it's not lost on this audience that severe BPD, as described by Northway more than 50 years ago, is still with us, and we do see babies with the kinds of x-rays that you see on the right here, with lungs that are fibrotic and scarred, which results in an enormous amount of mortality and morbidity in preterm infants. Alan Jobe very nicely summarized what happens. Intrauterine lung development, which is a series of 5 overlapping phases of lung development, can be influenced or plastic in nature, and they can be influenced by in utero stress and cytokine exposure, but also by antenatal glucocorticoids, which appear to accelerate intrauterine lung development. We still have not figured out how to get rid of preterm birth. And of course, the neonatologist intervenes and there's initiation of ventilation. And there follows exposure of the lung that now has to develop postnatally outside the uterus. And this lung is now exposed to malnutrition because we cannot match what the placenta can do, glucocorticoid expression, administration, as well as exposure to oxygen ventilation and bouts of infection, which lead to further inflammation and cytokine exposure. And this postnatal barrage that the lung goes through results in an inhibition of alveolar development and vascular development, which is the new BPD. I want to jump to show some work that we did publish earlier, that the NLRP3 inflammasome and interleukin-1 beta production are critical to the development of BPD. So TLR signaling, which is shown in the upper part of this schematic, where extracellular signals, either from germs or from endogenous danger signals, activate the transcription factor NF-kappa B to transcribe pro-IL-1 beta. The NLRP3 inflammasome, consisting of these three molecules, NLRP3, ASC, and pro-caspase-1, are also activated, and pro-caspase-1 is activated to caspase-1, which then clips pro-IL-1 beta into mature IL-1 beta, which is then secreted. IL-1 beta is a master signal for the activation of the innate immune system. And of course, we showed that this system is critical for the development of BPD, and I refer you to our previous paper in Nature Communications. So it's important to know that endogenous danger signals can also activate the system in the absence of any infection. So just some data from that paper that will help sort of set the stage for the rest of the talk. We obtained NLRP3 knockout mice and exposed both either wild type or NLRP3 knockouts to either room air, 21% oxygen, or 85% oxygen for 14 days. And wild type animals exposed to hyperoxia fail to develop alveoli and have this simplified distal architecture to the lung, which is saccular in stage, whereas the NLRP3 knockout mice that are exposed to the same degree of hyperoxia undergo normal alveolarization. And this is quantified by looking at radial alveolar counts, which are decreased in the wild type animals, but are unaffected in the NLRP3 knockouts. And when we look at either neutrophils or macrophage inflammation, the wild type animals do have an early neutrophil accumulation and a later macrophage accumulation, but transgenic animals that do not express NLRP3 do not get any inflammation whatsoever, suggesting that NLRP3 is a key determinant of the inflammation and decreased alveolarization that occurs with neonatal hyperoxia exposure. Hyaluronin is, or hyaluronic acid, or HA, is a disaccharide polymer that's a simple structure of N-acetylglucosamine and glucuronic acid. It's non-sulfated, and it normally does not associate with any proteins. The molecular size of HA determines its biological activity, such that oligomeric or very tiny fragments of HA are pro-inflammatory, whereas high molecular weight is anti-inflammatory. So high molecular weight provides tissue hydration and structure, and low molecular weight acts as an endogenous danger signal and stimulates cell-cell adhesion, cell differentiation, proliferation, and motility, doing this through interaction with specific receptors. So we looked at the role of low molecular weight HA in stimulating IL-1 beta production. And when we expose macrophages in culture to a 6-dimer fragment of HA that is pure and LPS free, we can stimulate the production of IL-1 beta in these cultured macrophages, suggesting that HA, especially the oligomeric form of HA, is fully able to switch on both arms, NF-kappa B as well as the NLRP3 inflammasome, off the inflammasome pathway.
So HA has been associated with lung injury for many years. Many lung diseases, both human and in animal models, show increased HA content in the lung. Inflammatory growth factors actually increase HA synthesis. But herein lies a conundrum where a low molecular HA actually increases the production of pro-inflammatory molecules. So is it that HA is a consequence of inflammation, or does HA cause inflammation? Demonstrate that HA can bind to proteins in three different ways. The link module, which is classically shown by this molecule CD44, is a tertiary structure where folding of the molecule allows a cleft to be formed where HA can sit and cause conformational changes in signaling, whereas receptors such as the receptor for HA-mediated motility do not have the link module, but have a charge-based sequence where there are two basic amino acids flanking 7 non-acidic residues that provide a charge-based interaction with HA. The only known covalent binding of HA to any protein is the heavy chain of inter-alpha inhibitor, which circulates in the blood also as an anti-inflammatory signal. So based on the BX7B motif that I just talked about, we generated peptides that were arginines, 2 arginines that are flanking 7 glycine residues. These are non-acidic residues. And we measured HA binding capacity. What we then did was we added more basic amino acids, more arginines, to get a final peptide that had increased HA binding capacity. And when we put these peptides onto macrophages in the culture dish and looked at their motility, we found that with increasing positive charge, increasing HA binding capacity, there was a progressive decrease in the motility of these cells, suggesting that we were able to competitively inhibit the effect of HA on the motility of these cells. So now we could answer the question of whether HA was contributing to inflammation or was a consequence of inflammation. And we hypothesized that lung injury would increase hyaluronin, that would drive inflammation and growth factors and subsequent respiratory distress and fibrosis. And now we had these RAM-based peptides that we could interfere and answer whether this hypothesis was correct. So when we used a model of intratracheal bleomycin to cause lung injury, bleomycin alone caused a 4-fold increase in the accumulation of macrophages in the lung. A scrambled peptide that had the same amino acids but in a non-HA binding sequence had no effect on this. However, the optimum peptide that I showed you in the previous slide, a single dose given subcutaneously at the time of injury, was able to almost completely abrogate the macrophage accumulation in the lung after intratracheal bleomycin, suggesting that indeed when we use these peptides, we could block inflammation after acute lung injury. When we looked later on at fibrosis, the top left panel shows a normal lung with beautiful complex alveolar architecture in the lung. The lung that is affected by bleomycin has extensive fibrosis with areas of emphysema and other areas of atelectasis. A scrambled peptide given subcutaneously at the time of injury had no effect, and the lung looks exactly like the bleomycin-injured lung. Whereas when we gave the RAM-based peptide as a single dose at the time of injury, we were able to almost completely block the fibrotic changes in the lung. Please note that we did not rescue alveolarization because these distal saccules do not have any alveoli. And so we looked then at what the role of RAM is. And when we looked at bleomycin injury, we wondered which cells were expressing RAM and what their role was. So we first chose immunohistochemistry using an antibody that was made to a peptide within RAM. And when you mix the peptide with the antibody with the peptide, you can abrogate staining, suggesting that the antibody was specific. And then in the uninjured lung, we found that bronchiolar epithelium, bronchiolar smooth muscle, and resident alveolar macrophages were expressing RAM. 4 days after bleomycin injury, we got a view of macrophages that were intensely positive for RAM. And we wondered whether these macrophages were indeed making RAM or whether they were just engulfing RAM as macrophages do. And so we used in situ hybridization, where panel A shows the sense probe to look at the mRNA site of production of RAM. Panel B is an uninjured or saline treated lung, which shows that there is synthesis of RAM in resident alveolar macrophages. However, in the bleomycin-induced injury lung, we saw plenty of macrophages appearing in the lung that now were also making RAM, suggesting that the macrophages were showing increased RAM expression rather than just engulfing it. And when we were able to do bronchoalveolar lavage and we obtained the macrophages from the lung and culture them in a plate and measure their cell motility, we found that saline treatment alone also did increase the mean random velocity of these cells, but the macrophages obtained from bleomycin-induced lung injury were moving much more quickly than the cells from saline controls. And in both cases, when we treated with a blocking antibody that blocked RAM, we were able to block the motility of these cells back to baseline, whereas a normal non-immune IgG had no effect. So we wondered whether we could use this antibody in the same way as we had with the peptide to try and block inflammation. And so when we treated these rodents with intraperitoneal antibody injections, bleomycin alone caused that inflammatory response as we had seen before. The non-immune IgG had no effect, whereas when we gave the blocking antibody to RAM, we were able to block the accumulation of inflammatory cells, in fact, macrophages into the lung, suggesting that RAM-HA interactions are responsible for the accumulation of macrophages into the lung. In order to test this on a genetic basis, we were able to obtain RAM knockout mice, and when we gave bleomycin injury to either wild type or RAM knockout mice, and we looked early on at 7 days, we were able to show that there was increased macrophages in the wild type animals, and this accumulation was abrogated in the knockout mice. Similarly, when we looked at 28 days after injury, the wild type animals given bleomycin had areas of fibrosis, emphysema, and atelectasis, whereas the RAM knockout mouse was protected against the fibrotic changes of acute lung injury. So both in terms of the peptide studies and the RAM antibody blocking studies and the genetic studies, we think that RAM is important for inflammation and fibrosis after lung injury. So in order to optimize these RAM-based peptides, we have studied quite a few peptides. These are the two HA binding domains of RAM that are sitting in the C-terminus of the protein. And we generated linker proteins that would abrogate both binding domains and the linker region in between. We modified these antibodies by acetylation and amide group insertion to increase the serum half-life. And then we developed other peptides that we could staple into this alpha helical conformation to improve carbohydrate-protein interactions. And I'll show you a number of these peptides, including peptide 110, which was this modified linker protein, as well as some of the staple peptides. And so in order to understand whether these peptides were effective in TLR-mediated responses, we first established a model where we could give intraperitoneal lipopolysaccharide as a sepsis model. And we were able to show that there's a time-dependent increase in TNF-alpha at 1 hour and IL-1 beta at 3 hours in the serum after intraperitoneal LPS. And so we looked at these time points to figure out if subcutaneous injection of a single dose of peptides would be able to block this TLR4 mediated response. And so when we looked at the original charge-based peptide, or the 110 peptide that was the linker peptide, we could see that both peptides were able to block the TNF-alpha response in the serum to intraperitoneal LPS, and also abrogated the IL-1 beta response such that the peptides were able to inhibit in a dose-dependent manner the inflammatory response to a septic model. These were pretty encouraging data for us, and so we hypothesized that low molecular weight HA would activate the toll-like receptor system, which cooperated with HA receptors, and would block the activation of inflammasome with decreased NF-kappa B activation and pro-IL-1 beta production, but also would block the second arm of the inflammasome that results in active caspase-1 to generate mature IL-1 beta. And we think that using these RAM-based peptides, we would be able to block the system and actually prevent BPD. And so we looked at models where we would place these animals in hyperoxia from postnatal day 1 to postnatal day 5, which is the saccular stage of lung development, and give a peptide or not on the first day of hyperoxia exposure. And we could also use RAM knockout mice to evaluate this whole system. Following the exposure to oxygen in the saccular stage from postnatal day 1 to postnatal day 5, the mice were then kept in room air until postnatal day 14, when we analyzed all our data. And so we first wanted to look and see if RAM-based peptide was able to prevent inflammasome activation and inflammation. So in order to look at the first arm of the inflammasome pathway, we looked at IL-1 beta mRNA. This is a surrogate for pro-IL-1 beta, and exposure to 95% oxygen for those 5 days increased the expression of pro-IL-1 beta at day 7. And then a single shot of the linker peptide at the time of hyperoxia initiation was able to completely abrogate this pro-IL-1 beta signal due to hyperoxia. And what about the protein, which would now be a surrogate for the second arm of the inflammasome activation? Indeed, exposure to hyperoxia for those 5 days increased IL-1 beta protein in the bronchoalveolar lavage at 7 days after injury, and a single shot of the linker peptide given at the time of initiation of hyperoxia was able to completely abrogate the increase in the second arm of the inflammasome pathway. So these peptides effectively blocked the activation of the inflammasome, and we looked at neutrophil content of the lavage cells, and hyperoxia exposure increased neutrophil accumulation, and this too was abrogated with subcutaneous single shot of this peptide. Exciting data which we thought would result in a prevention of BPD. And we then wanted to look and see what the mechanism of this was. So we looked at in vitro LPS stimulated activation of NF-kappa B. There are cells that are expressing a promoter that is reactive to NF-kappa B, linked to an alkaline phosphatase reporter, such that if you activate these macrophages with LPS, which is a TLR4 agonist, we can switch on the promoter and show that there is increased NF-kappa B activity. Bay compound, which is the strongest blocker of NF-kappa B that is known. When we add blockade of NF-kappa B, we can abrogate the NF-kappa B signal from this promoter. It's interesting that when we treated those cells with the linker peptide, we were able to mimic the strongest NF-kappa B inhibitor, suggesting that the RAM-based peptide was able to block that NF-kappa B activation from toll-like receptor 4 activation. Similarly, when we looked at IL-1 beta mRNA, which is pro-IL-1 beta that is driven by NF-kappa B, the IL-1 beta mRNA increased with toll-like receptor 4 activation, and a single administration of the peptide 110 to these cells was able to completely abrogate this activation. And so next, we wanted to look at what happened in RAM knockout mice. And this is where Jenny Chen's work was highly instrumental and very, very informative for us. And we were excited that Jenny could create these data for us. And I'm pleased to acknowledge her and show you that the data that she generated while she spent time in our lab. In fact, when we looked at wild-type mice given hyperoxia treatment for 5 days and examined at day 7, there's an increase in wild-type mice of IL-1 beta mRNA, whereas the knockout mouse does not increase this at all, suggesting that RAM is involved in that activation part of NF-kappa B activation of pro-IL-1 beta. At day 14, this increase in IL-1 beta mRNA has gone down, but the knockout mice continue to not have any increase in IL-1 beta mRNA. When we look at bronchoalveolar lavage samples, the wild-type mice exposed to hyperoxia increase IL-1 beta mRNA, whereas the knockout mouse fails to increase any IL-1 beta protein in the lung. The increase in wild-type animals is abrogating, but still elevated at day 14, and the knockout mouse continues not to have any elevation of IL-1 beta in the lavage. And then in order to look at activation of caspase-1, we looked at caspase-1 activity, and we showed that an increase in wild-type animals of caspase-1 activity was seen with hyperoxia exposure, but this was not observed in knockout mice. And most of these changes were in the early part, day 7, and not seen later on in day 14. In order to see whether we did get active caspase-1, we looked at the activated caspase-1, which is a 20 kilodalton protein, and this is called cleaved caspase-1. So in wild-type mice exposed to hyperoxia, you get an increase in cleaved caspase-1, whereas in knockout mice, you do not get any increase at all in the cleaved 20 kilodalton caspase-1. And this is quantified in the bar graph, which shows an increase in wild-type animals and no change in the knockout, suggesting that RAM is absolutely required for the second arm of the inflammasome where cleaved caspase 1 is created to create mature IL-1 beta. And so we wanted to look at hyperoxia and what happens to inflammation in these mice. And wild-type mice exposed to hyperoxia do increase neutrophil accumulation in the lung at day 7, and this is abrogated by day 14, whereas the knockout mice have no increase in inflammation either at day 7 or at day 14, suggesting that by not activating the inflammasome, the RAM knockout mice are protected from inflammation. I wanted to look at macrophages as well, and similarly at day 7, we do see an increase in macrophages from hyperoxia in wild-type animals, but no effect on in the knockout mice. And of course, this is all quieted down by 14 days, suggesting that both neutrophil and macrophage accumulation is dependent on inflammasome activation, and that RAM knockout mice, by not being able to activate the inflammasome, completely block the inflammatory response. So in summary, I want to say that the NLRP3 inflammasome is a critical component of the pathogenesis of BPD, that RAM-based peptides block the activation of NF-kappa B, the activation of the inflammasome and the production of IL-1 beta, as well as the inflammatory response to neonatal hyperoxia lung injury. RAM knockout mice fail to activate the NLRP3 inflammasome, and we believe that the RAM-based peptides that we've developed represent a novel approach to block NLRP3 inflammasome activation and actually prevent the development of BPD. I want to acknowledge folks in my lab who did this work, and with a special shout out to Jenny, who spent 2 years in the lab, and JT Xia, who really supported that effort. We wouldn't be able to have done those RAM knockout experiments without Jenny's work. Eva Turley and Len Lloyd are longtime collaborators that generated those peptides, as well as others who have been my mentors and my collaborators over the years. So I want to thank you for your attention, and happy to take questions.
Thank you. Thank you, Professor Rashmin. It's really nice to meet you. We didn't see each other for more than 1.5 years. And I also want to congratulate you for your great success in the RAM-based peptide. I remember when I live in the lab, and you're just start the RAM peptide study, but now I can see the great success. Congratulations again. So would you like to say something to our audience?
Yes, thank you. I hope you can hear me. It is 11 o'clock at night in Dallas, Texas, but it's a thrill for me to be part of this conference that's exceptionally well organized. I hope I convinced you that these RAM-based peptides are important, and I really hope that this is the start of further collaborations between our two nations. I think that's how we build bridges and share intellectual capital with each other. And I look forward to any questions that you have. I did answer some of them on the text in the chat box, but I'm happy to take other questions.
Yeah,
Thank you.
thank you so much.
Again. Thank you again for inviting me. It's been a joy and an honor for me.
Yeah, thank you. And I believe Rashmi is the person you can trust. Even though the many plans were canceled during the COVID-19 pandemic, he still sent the RAM knockout. We still work on the RAM knockout mice, and the mice just arrived Kaohsiung last month. Thank you, Rashmi.
Yeah, that was quite a challenge for us to get the mice to you. Not only do we have to wait for the Texas temperature to go down below 90 degrees Fahrenheit, we had to make sure that COVID was not an issue as well. So I'm glad you got them fine.
Yeah, thank
We
you.
look forward to collaborating with you.
Yeah, thank you. So is there any question from the audience? Okay, you can type in the chat box. And so I have a question about the RAM peptide. So if it's subcutaneous, would it have the like direct to the lung or has the systemic effect to or localized to the lung? I just wonder.
Yeah, so we had a big debate in the lab as to how to give the peptide.
Yeah.
When we read things about intratracheal or inhalation therapies for peptides, the distribution to the lung is very variable. And we were worried that the peptide would not really get into the lung. The second thing was that we really wanted to affect the systemic inflammatory response, so to prevent the recruitment of the cells to the lung. And therefore, we decided to give it subcutaneously. The third reason was there's a lot of HA in the skin. And our thought was that perhaps we would sequester the peptide in the skin and have a slow release of the peptide so as to make it work longer. As it happens, our first data on pharmacokinetics has demonstrated very quick uptake of the peptide into the circulation. So we're still working those pharmacokinetic data out, but that's why we gave it subcutaneously for those three reasons. And thank God it worked.
You. Yeah, eventually it really works. Yeah, I'm glad to see that. So thank you for Professor Savani and his excellent scientific work. So if
okay. It's I don't think that's a question for me in the chat, right?
Oh yeah, there is a question here. Will the peptide be used in? Oh yeah.
Yes. Yeah, will the peptide be used in humans? May give a shot at after birth in preterm infants. So while I'm very enthusiastic about taking this commercially, I think we need to make sure that this is a safe therapy. So we are currently working out dose responses and toxicity studies and pharmacokinetic studies in mice. And then what we hope to do is to partner with a pharmaceutical company and really take it to a non-human primate model. I'm sure you're aware that there is a preterm baboon model that exists in San Antonio, Texas, not very far from us. And we have collaborated with them in the past. And we think that we want to work out all the ways to use the peptide and potential toxicities of the peptide in the non-human primate model before we take it to babies. So, we're worried that we don't want to suppress the immune system too much. Otherwise, they might end up having infection. And we know that macrophages are involved in patent ductus arteriosus closure, and we want to make sure that an inflammatory response isn't blocked so that the ductus stays open. So there's a number of things that we will look out for in the non-human primate models as well.
Yeah, thank you, and yeah, thank you, and I hope one day I go back and I can see the baboon model. Yes, in San Antonio. Yeah.
We would love to have you back, Jenny. It was a real joy, and we are going to keep collaborating with you and invite you back because we had a great time.
Yeah. Okay. Thank you. Because the time is limited, so I have to end this session. So I would like to thank you, Rashmi Savani again, and thank you so much. Let's end this session.
It's my pleasure. Thank you.
Thank you.
Bye-bye, everyone.
Bye-bye.
The morning session of the first day has finished now. It's break time again. Please come back at 12:30. At that time, we have 2 lunch symposiums. In room A, we'll focus on respiratory syncytial virus prophylaxis. In room B, we'll focus on novel pneumonia syndrome testing. Please come back at 12:30 and enjoy our lunch symposium in both room A and room B.
From the beginning of human history, we've been in a fight for our lives. The odds seem insurmountable.
Disease, epidemics.
The danger of introduction of diseases from abroad.
The enemy outnumbers us 1,000,000,000 to 1, and the battlefield is the human body. But we've fought back. Our champions are many. Visionaries, detectives, turners of the tide.
The work of scientists alone cannot eliminate.
But as we've advanced, so too has the enemy. The pathogens have gotten stronger, bolder, deadlier. And that's why BioFire was born. We've created a new way to identify the enemy. We call it syndromic testing. It's faster, more accurate, more precise. With one test, we can identify a patient's infection in about an hour or less. No more losing time with one negative test after another until hours, days, and weeks have passed without optimal treatment. BioFire's syndromic approach is a symptom-driven, broad grouping of probable pathogens into one test that maximizes the chance of getting the right answer in a clinically relevant time frame, which means we can stem the rise of antibiotic-resistant superbugs. And these aren't things we hope to do. They're things we're already doing. Our respiratory panel is increasing survival rates in critically ill patients. Our pneumonia panel may help patients get better with fewer antibiotics. Our ME panel is reducing time to diagnosis. Our GI panel is reducing length of stay. Our BCID panel is cutting down the time patients spend on antibiotics. Costs are being reduced. Care is getting better. Lives are being saved.
I've been around for a certain period of time where I can recall waiting 2, 3, 4 days for cultures and sensitivities on either respiratory or gastrointestinal cultures. And this has just been a paradigm shift with respect to how quickly we can get that data to the clinician in a meaningful and actionable way.
We get an answer within 1 hour. And so if I have a clinical suspicion of an upper respiratory symptom or a lower respiratory symptom, I order the test, I get an answer within an hour. And to me, that's the most important selling point. Another important characteristic of the test is that I get a reliable answer, whether it be a positive test or a negative test.
Patients really want to know what exactly is going on when they come to the emergency department, and oftentimes we can only give them kind of a vague response of, you have a virus, or we think you have pneumonia, and not anything more specific than that. The BioFire testing really helps us be much more specific in our diagnosis. We're able to tell them, exactly which virus or which bacteria they have. They trust that, okay, if we have that result, we're probably able to treat them more precisely as well.
The most useful studies to come through has been from the Inhale group here in the UK, which has put out its initial findings in preprint, looking at approximately 100 patients, where the BioFire film array was used to try and detect and determine the nature of any secondary bacterial infections. And in this critical care cohort, different, of course, to normal secondary care of patients. In this critical care cohort, they found approximately 50% had bacterial infections, and that the rapidity of a syndromic molecular diagnostic to help determine the nature of those bacterial infections allowed clinicians to move on and prescribe appropriately. So we now have a growing guideline base for all aspects of management of COVID-19, coupled with some targeted and syndromic diagnostic. We really should be able to move through 2021 and any further waves of COVID that might happen with confidence.
So I looked at the WHO guidelines, the IDAC guidelines, and more specifically for intensive care practitioners, the European Society of Critical Care and the Surviving Sepsis campaign guidelines. And so the key message that I have kept in mind are the following. No antibiotic or not systematically for non-severe patients, first. A second important point is to try as much as possible to document the diagnosis of acute bacterial co-infections using biomarkers, using imaging, and of course using molecular microbiology assays, PCR-based assays for target identification.
Rapid test, fast microbiology is really useful to have a semi-targeted antibiotic therapy in ICU where the risk to use broad-spectrum antibiotics is really very, very high. Beside the fast microbiology, we have used a lot biomarkers, principally procalcitonin, that we use at the emergency department in all COVID-19 patients, and to be honest, in all patients with diagnosis of infection, because procalcitonin, especially in COVID-19, but also in pneumonia, is very, very useful because we know that procalcitonin is useful to perform a diagnosis of bacterial infection.
Family who asked immediately on admission, you know, you're saying this is bronchiolitis, it's clinical bronchiolitis, but when will we get the result? And usually I said, well, it would take us 3 to 5 days, but today we can do this in 40 minutes. And there was actually tears when I gave the result, and it confirmed that this baby had RSV bronchiolitis. This might seem a little strange to clinicians because we deal with bronchiolitis every winter, and we know what it looks like clinically, and some of the questions again and queries against the point of care test might be, well, what does it add? Well, it adds a great deal to families. Families expect answers quickly, they expect rapid results, and they want to know for sure which bug their child has got. That not, it's probably bronchiolitis, but it is, and it's caused by this bug.
From the beginning of human history, we've been in a fight for our lives. The odds seem insurmountable.
Disease, epidemics.
The danger of introduction of diseases from abroad.
The enemy outnumbers us 1 trillion to 1, and the battlefield is the human body. But we've fought back. Our champions are many. Visionaries, detectives, turners of the tide.
The work of scientists alone cannot eliminate.
But as we've advanced, so too has the enemy. The pathogens have gotten stronger, bolder, deadlier. And that's why BioFire was born. We've created a new way to identify the enemy. We call it syndromic testing. It's faster, more accurate, more precise. With one test, we can identify a patient's infection in about an hour or less. No more losing time with one negative test after another. until hours, days, and weeks have passed without optimal treatment. BioFire's syndromic approach is a symptom-driven, broad grouping of probable pathogens into one test that maximizes the chance of getting the right answer in a clinically relevant time frame, which means we can stem the rise of antibiotic-resistant superbugs. And these aren't things we hope to do. They're things we're already doing. Our respiratory panel is increasing survival rates in critically ill patients. Our pneumonia panel may help patients get better with fewer antibiotics. Our ME panel is reducing time to diagnosis. Our GI panel is reducing length of stay. Our BCID panel is cutting down the time patients spend on antibiotics. Costs are being reduced. Care is getting better. Lives are being saved.
I've been around for a certain period of time where I can recall waiting 2, 3, 4 days for cultures and sensitivities on either respiratory or gastrointestinal cultures. And this has just been a paradigm shift with respect to how quickly we can get that data to the clinician in a meaningful and actionable way.
We get an answer within 1 hour. And so if I have a clinical suspicion of an upper respiratory symptom or a lower respiratory symptom, I order the test, I get an answer within an hour. And to me, that's the most important selling point. Another important characteristic of the test is that I get a reliable answer, whether it be a positive test or a negative test.
Patients really want to know what exactly is going on when they come to the emergency department, and oftentimes we can only give them kind of a vague response of, you have a virus, or we think you have pneumonia, and not anything more specific than that. The BioFire testing really helps us be much more specific in our diagnosis. We're able to tell them, exactly which virus or which bacteria they have. They trust that, okay, if we have that result, we're probably able to treat them more precisely as well.
The most useful studies to come through has been from the Inhale group here in the UK, which has put out its initial findings in preprint, looking at approximately 100 patients where the BioFire film array was used to try and detect and determine the nature of any secondary bacterial infections. And in this critical care cohort, different, of course, to normal secondary care of patients. In this critical care cohort, they found approximately 50% had bacterial infections, and that the rapidity of a syndromic molecular diagnostic to help determine the nature of those bacterial infections allowed clinicians to move on and prescribe appropriately. So we now have a growing guideline base for all aspects of management of COVID-19, coupled with some targeted and syndromic diagnostic. We really should be able to move through 2021 and any further waves of COVID that might happen with confidence.
So I looked at the WHO guidelines, the IDSA guidelines, and more specifically for intensive care practitioners, the European Society of Critical Care and the Surviving Sepsis campaign guidelines. And so the key message that I have kept in mind are the following. No antibiotic, or not systematically, for non-severe patients, first. A second important point is to try as much as possible to document the diagnosis of acute bacterial co-infections using biomarkers, using imaging, and of course using molecular microbiology assays, PCR-based assays for target identification.
Rapid test, fast microbiology is really useful to have a semi-targeted antibiotic therapy in ICU where the risk to use broad-spectrum antibiotics is really very, very high. Beside the fast microbiology, we have used a lot of biomarkers, principally procalcitonin, that we use at the emergency department in all COVID-19 patients, and to be honest, in all patients with diagnosis of infection, because procalcitonin, especially in COVID-19, but also in pneumonia, is very, very useful because we know that procalcitonin is useful to perform a diagnosis of bacterial infection.
Family who asked immediately on a mission, you're saying this is bronchiolitis, it's clinical bronchiolitis, but when will we get the result? And usually I said, well, it would take us 3 to 5 days, but today we can do this in 40 minutes. And there was actually tears when I gave the result, and it confirmed that this baby had RSV bronchiolitis. This might seem a little strange to clinicians because we deal with bronchiolitis every winter, and we know what it looks like clinically, and some of the questions again and queries against the point of care test might be, well, what does it add? Well, it adds a great deal to families. Families expect answers quickly. They expect rapid results, and they want to know for sure which bug their child has got. That not, it's probably bronchiolitis, but it is, and it's caused by this bug.
From the beginning of human history, we've been in a fight for our lives. The odds seem insurmountable.
Disease, epidemics.
The danger of introduction of diseases from abroad.
The enemy outnumbers us 1 trillion to 1, and the battlefield is the human body. But we've fought back. Our champions are many. Visionaries, detectives, turners of the tide.
The work of scientists alone cannot
But
eliminate.
as we've advanced, so too has the enemy. The pathogens have gotten stronger, bolder, deadlier. And that's why BioFire was born. We've created a new way to identify the enemy. We call it syndromic testing. It's faster, more accurate, more precise. With one test, we can identify a patient's infection in about an hour or less. No more losing time with one negative test after another until hours, days, and weeks have passed without optimal treatment. BioFire's syndromic approach is a symptom-driven, broad grouping of probable pathogens into one test that maximizes the chance of getting the right answer in a clinically relevant time frame, which means we can stem the rise of antibiotic-resistant superbugs. And these aren't things we hope to do. They're things we're already doing. Our respiratory panel is increasing survival rates in critically ill patients. Our pneumonia panel may help patients get better with fewer antibiotics. Our ME panel is reducing time to diagnosis. Our GI panel is reducing length of stay. Our BCID panel is cutting down the time patients spend on antibiotics. Costs are being reduced. Care is getting better. Lives are being saved.
I've been around for a certain period of time where I can recall waiting 2, 3, 4 days for cultures and sensitivities on either respiratory or gastrointestinal cultures. And this has just been a paradigm shift with respect to how quickly we can get that data to the clinician in a meaningful and actionable way.
We get an answer within 1 hour. And so if I have a clinical suspicion of an upper respiratory symptom or a lower respiratory symptom, I order the test, I get an answer within an hour. And to me, that's the most important selling point. Another important characteristic of the test is that I get a reliable answer, whether it be a positive test or a negative test.
Patients really want to know what exactly is going on when they come to the emergency department, and oftentimes we can only give them kind of a vague response of, you have a virus or we think you have pneumonia, and not anything more specific than that. The BioFire testing really helps us be much more specific in our diagnosis. We're able to tell them, exactly which virus or which bacteria they have. They trust that, okay, if we have that result, we're probably able to treat them more precisely as well.
One of the most useful studies to come through has been from the Inhale group here in the UK, which has put out its initial findings in preprint, looking at approximately 100 patients, where the BioFire film array was used to try and detect and determine the nature of any secondary bacterial infections. And in this critical care cohort, different, of course, to normal secondary care of patients, in this critical care cohort, they found approximately 50% had bacterial infections, and that the rapidity of a syndromic molecular diagnostic to help determine the nature of those bacterial infections allowed clinicians to move on and prescribe appropriately. So we now have a growing guideline base for all aspects of management of COVID-19, coupled with some targeted and syndromic diagnostic. We really should be able to move through 2021 and any further waves of COVID that might happen with confidence.
So I looked at the WHO guidelines, the IDAC guidelines, and more specifically for intensive care practitioners, the European Society of Critical Care and the Surviving Sepsis campaign guidelines. And so the key message that I have kept in mind are the following. No antibiotic or not systematically for non-severe patients, first. A second important point is to try as much as possible to document the diagnosis of acute bacterial co-infections using biomarkers, using imaging, and of course using molecular microbiology assays, PCR-based assays for target identification.
Rapid.
We have two lunch symposiums. In room A, we'll focus on respiratory syncytial virus prophylaxis. In room B, we'll focus on novel pneumonia syndrome testing. And enjoy our lunch symposium, both room A and room B.
In the meeting room, we have a main room, which is room A, where all the plenary lectures are. We also have a room B that will show the exciting online symposium, posters, and nice video shows. We're going to room B. Participants, breakout sessions, you can find in the virtual meeting conference.
dear audience. I'm the master of the African section, Dr. Su Timu, the Dr. Mu. Welcome back. We are going to start our launch symposium. Right now, we are in the room A to talk about the RSV. If you have interest to take a look about the normal pneumonia syndrome, you can switch to room B. If you have any question or comment, please write down in the chat box or chat room. I would like to thank my detailed teacher, the Dr. Pei Zhen Chao, the Dr. Chao, for her help. Okay, let's go on the launch symposium to talk about the respiratory virus. Welcome the moderator, Professor Xiuling Chen. Professor Chen, please. Thank you.
Okay, thank you. Thank you. Welcome to the lunch symposium for RSV prophylaxis. I have the great honor of introducing Professor Yu Zilin as today's lunch symposium speaker. Professor Lin is a neonatologist at the National Cheng Kung University Hospital in Tainan, Taiwan. He is also the vice president of Taiwan Society of Pediatric Pulmonology and Critical Care Medicine. He earned his MD degree at China Medical University in Taichung, Taiwan. He completed his residency in the neonatology and the pediatric pulmonology fellowship training at University Hospital. He has visited the University of Manitoba Health Science Center in Canada for studying amnion prematurity in 1996. He then became a visitor staff in Stephen Evans' lab for 1 year in 2001. Today, his research interests include maturity, perinatal epidemiology, neonatal network, machine learning, and neonatal respiratory care. Professor Lin has published more than 60 papers so far, so I think he is the perfect speaker for the topic of prophylactic adivizumab for severe RSV infection among prematurely born infants in Taiwan. As we know, RSV is the leading cause of viral lower respiratory tract infections in infants. 10 infants are at increased risk for hospitalization with RSV. So prophylaxis with adivizumab is important for premature infants. We are happy to have this special lecture. Please join me in welcome Professor Lin. Please start. Thank you.
Good afternoon. Thank you for your kind introduction. It's my pleasure to be here to share you our experience regarding prophylactic polymyxin for severe RSV infection among premature infants in Taiwan. And this is the outlines. First, we discuss the clinical significance of RSV infection. Let me give you a brief introduction of RSV virus. RSV has a single-stranded RNA and with two major surface glycoproteins. The G protein or attachment protein assists with viral adherence to the host cells, and fusion or F proteins are essential for viral penetration into the host cells. And this is a typical chest X-ray of RSV lower respiratory tract infection. You can see there are air trapping, segmental analysis, and increased interstitial marking. Two lung biopsy specimens are presented here. Left side is normal lung. Right side is RSV infected lung. It shows bronchocentric infiltrate with slowing of bronchiolar epithelium and exudate in the lumen composed of dead cells and fibrin. RSV is best known for causing bronchiolitis in young children and also play a role in some certain infant death syndrome disease and or apnea. And after RSV infection, it was associated with childhood wheezing. And in the 1960s, administration of formalin inactivated RSV vaccine caused vaccine-enhanced disease. Globally, it is an important public health problem. It is the leading cause of severe respiratory tract infection in infant and young children throughout the world. And 64 million RSV infections worldwide every year. Infects nearly all children by the age of 2 years, and RSV bronchiolitis spread to cause up to 70% of the infant hospitalization. RSV infection occurred in nearly all children by 2 years. 68% of children had their first RSV infection during the first year of life, and the evidence of lower respiratory tract disease was detected in 21.6%. Primary infection after the first year were less severe, but 97% of them had an RSV infection during their second year. And of these, 6% had an lower respiratory tract disease. RSV immunity is not durable, and reinfections are common throughout the life. Between 50% and 75% of children growth each year have been reinfected each year. Reinfection more than once, even within the same season. Antibody response is not sufficient to prevent subsequent RSV reinfection. And this study showed that the risk of reinfection is inversely proportional to the antibody titer seen with the previous infection. And even subjects with the highest titer of F and G antibodies still had a 25% chance of being infected. And mortality data suggests that RSV is an important cause of death in childhood from acute lower respiratory tract infection, and it's after pneumococcal pneumonia and Haemophilus influenza type B. About 55% of hospital admission and in hospital deaths due to RSV acute lower respiratory infection occur in children younger than 6 months. So the younger the patient, the more severe the disease. In summary, RSV infection is common in infancy, and reinfection occurs frequently in all children during the first 2 years of life because of incomplete immunity. Next, we talk about infants with high risk for severe RSV disease. This is the summary of my study. In RSV hospitalized children, 12 to 28% of them have a history of prematurity. When comparing with term infants, hospital resource usage is high in all premature infants, including ICU admission, intubation, in hospital stay, and ICU stay. This is a systemic review regarding RSV infection in children with chronic lung disease who do not receive prophylaxis. Chronic lung disease is a significant independent risk factors for RSV-associated hospitalization. Odds ratio 2.2 to 7.2. And it is also associated with a higher rate of RSV-H than other high-risk group. The reported instance of RSV-H is 12 to 21%, and with a median hospital stay of 4 to 11 days, and associated with the use of mechanical ventilation and ECMO, and a longer duration of mechanical ventilation. So the second summary, children born preterm and with chronic lung disease who do not receive prophylaxis have a higher hospitalization rate, morbidity, and mortality. We then move on to talk about the prophylaxis. And how to prevent RSV infection. We can avoid exposure and risk factors by limiting contact with infected people, remove from daycare and group settings, proper hygiene, frequent hand washing, disinfecting service exposed to infectious secretions, and cohorting hospitalized patients with RSV. And we can promote breastfeeding and also prevent nosocomial RSV infection by proper hygiene, frequent hand washing with alcohol-based hand cleaner, and wearing clean gloves and masks, and cohorting hospitalized patient with RSV. Currently, the only approved preventive treatment for severe RSV disease is palivizumab. It is a monoclonal antibody that binds the F protein of the RSV, so blocking the fusion of infected cells. It is produced by recombinant DNA technology, and it reduces viral activity and cell-to-cell viral transmission. FDA approved this therapy after the IMPACT RSV trial. This trial enrolled two groups of preterm infants. The first group just age less than 36 weeks and 6 months younger. The second group are patients with a clinical diagnosis of BPD, requiring ongoing medical treatment, and younger than 24 months of age. They were given monthly doses of 50 milligram per kilo IM injection of palivizumab during the RSV seasons. In the IMPACT RSV trial, significantly lower RSV hospitalization rate was observed among those who received palivizumab compared to those who received placebo in each of the subgroups. For all infants, there was 55% reduction of RSV hospitalization rate. And in infant less than 32 weeks, 47% reduction. And chronic lung group, 39%. Infant without chronic lung disease, 78%. 32 to 35 weeks, 80%. And 32 to 35 weeks without chronic lung disease, 82%. And this graph shows significant reduction, 57% reduction in the palivizumab group in the instance of ICU admission during the hospitalization for RSV infection. The current AAP guideline for RSV prophylaxis is published in 2014. For premature infants with no congenital heart disease, they recommended to provide prophylaxis at the start of RSV season in two groups of preterm infants. The first group with gestation age less than 29 weeks if they were less than 12 months of age. The second group with gestation age between 29 and 32 weeks, and if they were less than 12 months of age. This is the concept of RSV seasonality, defined as the onset, offset, peak, and duration. The onset week in an area is defined as the first two sequential weeks when the week's percentage of all specimens testing positive for RSV antigen in that area is greater or equal to 10%. The offset is the end of the last two sequential weeks when the weekly percentage of positive antigen exceeds 10%. And the peak is the week when the percentage of positive RSV test is highest, and the season duration is the period between the onset and offset weeks. This is the RSV epidemiology in the United States. Horizontal axis represent timeline. Vertical axis represent percentage of positive RSV antigen test. This horizontal line here represent 10% positive, and this arrow represent onset, offset, and in between is called the duration of RSV season. Regarding the RSV epidemiology, the exact timing and the duration of RSV seasons vary by region and from year to year. And social and demographic factors such as the population density, pollution, and climate, which might influence the national or regional RSV activity. So the surveillance data can be used to identify RSV activity and coordinate timing of immunoprophylaxis with polymisomate. In the United States and other areas with similar climates, RSV infection occur primarily during fall, winter, and spring. However, Florida has an earlier RSV onset and longer duration than other regions. This is a recent report published in August issue of Pediatrics. In this year, there's a delayed RSV season in the United States during the COVID-19 pandemic. In the past, the RSV season occurred from September to February before the COVID-19 pandemic. So the author suggests that we should extend the monthly preventive polymisomate for infants at risk for severe RSV disease and continue the protection during this unexpected surge. This slide summarizes the conclusions of several clinical reports regarding the children at risk, highest risk for RSV disease, and outlines why these children will be at severe risk for RSV. For example, here, premature births, they have altered airway anatomy and absence of maternal antibody protection. For chronic lung disease, there's bronchial hyperresponsiveness and reduced lung capacity. For congenital heart disease, there's point vascular hyperresponsiveness, and pulmonary hypertension, increased pulmonary blood flow, and also neuromuscular disease and immunodeficiency. And how about the condition in Taiwan? Taiwan is an island located in subtropical region. The epidemiology of RSV infection is different from some other part of the world. The RSV infection occurs throughout the years, and with the peak in spring and fall in northern Taiwan, and without significant seasonality in southern Taiwan. Some studies also found that logic age is the single most important risk factor for RSV-related hospitalization, and most of them occur in the first 5 months after birth. And in this paper, we found that preterm infants were most vulnerable within the 9 months of chronologic age. This slide summarizes the length of stay or LOS for preterm babies in Taiwan. For preterm infant with gestation age less than 29 weeks, their mean LOS is from 2 months to 4 months, and the other group is from 1 month to 3 months. Therefore, a normal RSV preventive protocol for high-risk preterm infants has been proposed by the Taiwan Society of Neonatology and reimbursed by National Health Insurance since December 1, 2010. The protocol consists of 6 IM injection of 50 milligram per kilo of palimizumab given at a monthly interval. For 2 group of infants, infant with gestation age less than 29 weeks, and infant with gestation age between 29 and 35 weeks with chronic lung disease, and the first dose is administered 3 to 5 days before the baby is discharged. And in 2017 April, we changed the criteria to enroll more preterm infants for prophylaxis. So the first group with gestation age less than 31 weeks, and infants with gestation age from 31 to 35 weeks with chronic lung disease. And all of them are younger than, when we give the palimizumab, also another criteria is that they have to be younger than 12 months of age. And we found that this regimen effectively reduced RSV associated hospitalization and all-cause mortality of preterm infants in Taiwan. And admission to ICU and mechanical ventilation were also reduced in infants with gestation age between 29 and 35 weeks with chronic lung, and the hospital stay and total hospital cost were also reduced in that group. So the take-home message, globally, RSV is the most frequent cause of a lower respiratory tract infection in children, and resulting considerable morbidity and mortality. And prematurity, chronic lung disease are important risk factors for severe RSV infection. And palimizumab prophylaxis reduced RSV-related hospitalization in high-risk infants during RSV seasons. And 6 monthly palimizumab prophylaxis reduced RSV-related hospitalization in the subtropical region with prolonged RSV seasons. And thank you for your attention.
Okay. Thank you. Thank you
Okay,
for
moderator.
Professor Lin's excellent speech. Any question from the audience? You can write down the questions in the chat box. Okay, maybe I can ask one question. You said the ISV reinfection occurs frequently in all children during the first 2 years of life. Do you think the 6-monthly palivizumab schedule in Taiwan enough for premature?
Yeah, I think because we know that one of the factors that affect on the severity of RSV infection is chronologic age. And you know, actually there's a paper from Dr. Xu from Mackay Royal Hospital. They reported that for children infant, if they have a severe RSV infection, most of them occurred within the 9 months. So they are vulnerable during that period. And the duration for the hospitalization, one longer one is for term with gestation less than 29 weeks is 3 months. So we put it together. If we have the 3 months during the hospitalization and 6 months of 6 doses of artemisinin, resulting covering at least 9 months at that group of patients. So that's why that's a good decision for cost benefit balance. So I think it's a good idea to do that. And later on, we analyze those data and then telling the people that actually it's a good strategy to that our country, because we have the prolonged season and we cannot choose at what time let's give the prophylaxis to the children during that period. So that's a good strategy, I think, at present.
Okay. Thank you for your answer. And there is still one question in the chat box, but the time is up. So we need to end this speech. Okay.
Well, thank you.
Thank you very much.
Okay, thank you. Thank you, speaker, Professor Lin, and moderator, Professor Chen. If any question, you can write down in chat box. Speaker will provide answer for you. Okay, let's proceed the next talk. Welcome the moderator, Professor Zhi Chen. Professor Chen, please.
Okay, ladies and gentlemen, Ladies and gentlemen, it's my great honor to introduce our second speaker, Dr. Chiu Sun-nan. Dr. Chiu is a professor and also an attending physician of Department of Pediatrics in National Taiwan University and National Taiwan University Hospital. And then he graduated from National Taiwan University College of Medicine and acquired his PhD at National Taiwan University Institute of Clinical Medicine. He also majored in pediatric cardiology, including infection, susceptibility in congenital heart disease, electrophysiology of pediatrics, and also intervention and imaging of congenital heart disease and pediatrics. And Professor Chiu is also a director of Taiwan Society of Pediatric Cardiology, and he also organized many multi-center studies for Taiwan Society of Pediatric Cardiology, including RSV, palivizumab, for respiratory virus infection in congenital heart disease and pulmonary artery hypertension in congenital heart disease. So Professor Cho is a perfect speaker for this session, and I think he just finished his COVID-19 speech this morning. He's in a very Russian people. So we have the honor to have Professor Cho. Please, Professor Cho.
Thanks for the chairman's introduction, and also thanks the organizing committee and also AstraZeneca to invite me to have a speech here. Today I will talk about the RSV infection and the prevention in infants with congenital heart disease. This is the outline of my speech. First, I will talk about the RSV infection in congenital heart disease. Then we will see the effect of parasitary prophylaxis, and we will special focus on a new subtropical protocol for RSV prevention in congenital heart disease. Then finally, we will see the proposal for subtropical parasitary prophylaxis guideline. Let's see the RSV infection in congenital heart disease. Respiratory syncytial virus (RSV) is a single-strain RNA virus with envelope. It belongs to Paramyxoviridia. It has 11 proteins, with 3 proteins will help virus to bind to the host cell receptor. The F protein, fusion protein, will mediate the fusion of cell and the viral membrane. This protein is relatively constant and is always the target of the vaccine and the automonoclonal antibody. Through the G protein and F protein, the RSV will enter and duplicate in our nasal cavity. It will then invade the lower respiratory tract, which may cause the bronchiolitis and the pneumonia. It often invades the infant and toddlers because they have narrow airway and an immature immune system. RSV is an important cause of death in children. It is the third most important cause of death in infants from the WHO report, and it is also the primary viral cause of death in infants younger than 1 year of age. It causes more than 30 million cases annually and causes more than 60,000 to 200,000 cases of death annually in the whole world. In Taiwan, it is also the leading cause of respiratory tract infection in children less than 5 years of age. We can see it causes more than half of the case of the lower respiratory tract infection. In pediatric population, for patients with chronic lung disease, congenital heart disease, and prematurity, they have a especially high risk of RSV hospitalization. From this report from the United States, we can see the bronchopulmonary dysplasia is the leading risk factor, followed by congenital heart disease. This is the health insurance nationwide database study from Taiwan from 2005 to 2010. With more than 8,000 congenital heart disease patients, we can see the RSV hospitalization rate is especially high in patients with cyanotic and the hemodynamic significant cyanotic congenital heart disease, and the risk is especially higher for patients younger than 1 year of age. Not only the hospitalization rate, but the symptoms are also more severe in these congenital heart disease patients. From this figure, the hospitalization deaths and the hospitalization costs are all higher in patients with cyanotic congenital heart disease and the hemodynamic significant cyanotic congenital heart disease. The ICU admission rate, ventilator support rate, and also mortality are all higher in cyanotic congenital heart disease, followed by the hemodynamic cyanotic congenital heart disease. From this study, the age is an important risk factor of RSV infection in congenital heart disease patients. For the age younger than 1 year of age, the RSV infection rate is significantly higher both in cyanotic and cyanotic congenital heart disease. Then we will talk about the effect of parasitary prophylaxis. Then let's see how to prevent RSV infection. The general prevention is very important. We have to avoid secondhand smoke to decrease RSV infection rate, and the breast milk feeding can increase immunity and decrease infection rate and severity. Vaccination is always an important tool to prevent virus infection. Like COVID-19, we use the vaccine to decrease the transmission and also infection rate. However, there is still no effective pediatric vaccine for RSV prevention yet. There are some new vaccines to perform for maternal immunization during pregnancy and to see if it can prevent RSV infection for neonates after birth. We will discuss it later. So till now, the passive immunization is still the most important tool for RSV prevention. We give the patient monoclonal antibody, the pembrolizumab, and it can use to prevent RSV or respiratory infection in high-risk patients. As early as 2003, there is a large multi-center double-blind clinical trial in Europe and Northern America. For more than 1,200 patients, hemodynamic significant control heart disease patients less than 2 years of age. They found the pulmonary prophylaxis will reduce hospitalization rate in this young age patient. We can see the hospitalization rate will decrease by 45%. The days of hospitalization will decrease by 56%, and the oxygen therapy days will decrease by 73%. So, from this study, we can see the pulmonary prophylaxis is very useful for the prevention of the RSV infection in hemodynamic significant congenital heart disease. Because of the evidence from this multi-center study, the AP guideline now suggests the children younger than 1 year of age with hemodynamic significant CHD should receive pulmonary prophylaxis in this patient. They suggest the cytopenic congenital heart disease with heart failure symptoms or require cardiac surgery should receive the pulmonary prophylaxis. For the patient with cyanotic CHD, the decision of pulmonary prophylaxis depends on the pediatric cardiology suggestion. For children receiving prophylaxis and receiving operation, 1 more dose of pulmonary should be considered after cardiac bypass. They suggest total 5 doses of the pulmonary during RSV season should be given in these high-risk patients. However, the severity of RSV infection differs a lot in different countries. This is the RSV cases in the United States. We can see there is a very clear RSV season beginning at around September till March in every year. However, in our country, it is in a subtropical area. We can see the RSV cases we have RSV cases all around the year, and the RSV peak in March, April, May, and also peak in June, August, September, and October. So we don't have a clear RSV season. Because most of the audience is from the Asia Pacific area and many of the audience from the Southeast Asia, so the RSV season may be not very obvious in our country. So we have provided our experience, which is a Taiwan policy of pulmonary prophylaxis. We suggest the pulmonary prophylaxis for all infants less than 1 year old with hemodynamic significant congenital heart disease, which is defined as the all cyanotic congenital heart disease before total correction or after total correction with residual cyanosis or heart failure. Or for patients with a cyanotic congenital heart disease with heart failure, the definition of heart failure should fulfill the 2 of the following 3 statements: the failure to thrive, significant cardiomegaly, and more than 2 anticongestive medication needed. We will give the patient monthly pulmonary injection since the diagnosis till total correction, and 1 more dose before discharge from cardiopulmonary bypass surgery. The maximum dose of pulmonary injection is 6 doses. We then perform a multi-center study to see This novel pyruvate prophylaxis protocol have efficacy in preventing ICV infection in hemodynamic congenital heart disease patients. This multi-center study is from the northern part, middle part, and southern part of Taiwan, and between 2010 to 2016. We use the study group and also the historical control, and we divided it into 3 areas: the synergies area, transitional area, and the synergies area. This is a clinical characteristic. We have formed the propensity score match, and we can see after match, all the clinical parameters was similar between the two groups. Then let's see our results. Under this novel pyruvate prophylaxis protocol, compared to the control group, the ICV hospitalization rate decreased around 50% after propensity score match. The ICU admission rate also decreased by 57%. We also see separately for the cyanotic and the cyanotic congenital heart disease. For cyanotic hemodynamic significant congenital heart disease, the pyruvate prophylaxis will decrease hospitalization rate around 35%, and for cyanotic congenital heart disease, the ICV hospitalization rate decreased by 65% after propensity score match. This is the Kaplan-Meier ICV hospitalization-free survival curve. We can see after pyruvate prophylaxis, the ICV hospitalization rate decreased more than half of patients. And also compare these 3 areas, we can see the ICV hospitalization rate decreased dramatically after pyruvate prophylaxis. Then we try to find the cost effectiveness of this subtropical guideline. The mean dosage of pyruvate is 3.9 doses in the current guideline, which is less than 5 doses in the AAP guideline for countries in temperate zone. However, the prevention of ICV hospitalization is as effective in the current guideline. It decreased the ICV-related hospitalization by 49% compared to the 45% in the multi-center study. So I will make a brief summary here. Using this novel pyruvate protocol, the ICV-associated hospitalization rate and severity reduced significantly in hemodynamic significant congenital heart disease patients in the subtropical area. And compared to previous multi-center study, the efficacy is comparable, and it is also effective in cyanotic congenital heart disease patients. So, this subtropical pyruvate prophylaxis protocol may be applied to the area with no previous ICV season, like tropical and the subtropical area. Finally, I will talk about the appraisal of subtropical pyruvate prophylaxis guideline. So, after 5 years of the subtropical guideline of the pyruvate prophylaxis, we try to find out if there is any other revision necessary for this subtropical protocol. This is a single-center study for more than 700 patients receiving a subtropical guideline for pyruvate prophylaxis in hemodynamic significant congenital heart disease. We can see in these 772 patients, 42 patients still have ICV infection, and we try to find if any risk factor is associated with the ICV infection. We can see the associated anomaly, especially genetic syndrome and the non-airway anomaly, is more common in the ICV infection group. On the current study, we can see the most important cause of ICV-related hospitalization is then the patient not fully vaccination criteria, around 70% of the patient. This means the current subtropical guidelines still have some shortage. Because after the patient receiving total correction, they are no longer fulfilling the criteria of the pyruvate prophylaxis. So there may be some patients still at high risk. On this figure,
we can see the associated anomaly has significantly higher ISV associated hospitalization rate compared to those without, both in the age below 1 year and 1 to 2 years of age. When we consider a subgroup of associated anomaly, we can see the genetic syndrome has higher ISV associated hospitalization rate. The patient with down airway abnormality, especially below 1 year of age, has higher ISV associated hospitalization rate. Not only the increased ISV hospitalization rate, but also the increased ISV severity. We can see the ICU admission rate, the intubation rate is all higher in patients with associated anomaly. And for genetic syndrome and for the down airway abnormality, the ICU admission rate and the intubation rate is also higher. So we may suggest the patient with associated anomaly, especially genetic syndrome or down airway abnormality, is at especially high risk and should receive more doses of pyruvate prophylaxis under recent guidelines. The mean doses of pyruvate is around 3.3 in our cohort. Compare those with associated abnormality and those without. The mean dose of pyruvate differs significantly, both in the whole group and in the subgroup. These patients are at especially high risk of ICU hospitalization, but we didn't give them extra dose. So further guideline revision may be necessary to give them further prevention of RSV infection. Here I will make a brief summary about this study. From this study, the patient with associated abnormality, especially genetic syndrome and down airway abnormality, carry especially high risk of RSV infection in hemodynamic significant controlled heart disease patients. Further subtopical pyruvate prophylaxis guideline adjustment may be necessary, and the extra doses may be necessary for a patient with associated abnormality to give them extra prophylaxis. Then let's see the ICV prevention strategy in the future. There are many new antiviral medication, vaccination, and immunoprophylaxis for ICV prevention under investigation. For the antiviral treatment, the only market-approved drug is ribavirin, but its use is still controversial. Some new drugs has been developed, but is now in phase 2 trial. For the vaccination, there are two targets. Some of the vaccine target on the maternal, and some of the vaccine target on the pediatric infant. The only vaccine now under phase 3 study is race-based. We will discuss it later. For the immunoprophylaxis, there is a monoclonal antibody. We have the synergies, which is now under market approved, and the nirsevimab, it is now under phase 3 trial. Okay, let's see the new monoclonal antibody for immunoprophylaxis and the maternal vaccination under investigation now. The nirsevimab, it is now under phase 3 trial. It is targeted on the preterm and high-risk children. And the Merck has a new vaccine which is under phase 1-2 trial. It is targeted on preterm infant. The ResVax, which is maternal vaccination and try to provide prophylaxis for the neonate and the young infant. It has completed its phase 3 trial. However, it didn't meet primary endpoint. Then let's see a comparison of the maternal immunization and the infant monoclonal antibody use. They all belong to passive immunization. For the maternal vaccination, we give the pregnant woman a single dose vaccination in the third trimester, and the mother will induce a maternal monoclonal antibody. The antibody will transmit through placenta to the newborn and to a fetus, and after birth, they will have a maternal antibody in the blood. However, the half-life is not very long, so the protection will decrease around 2 to 3 months later. For the monoclonal antibody, has been used widely now. However, the pyrumab still has some shortage because it has short half-life, so we have to give the patient monthly injection. Now, the naxitamab has prolonged half-life, and we can give the patient only 1 to 2 doses, and they will have a 6 months protection. And about the pediatric vaccine, there are alternative vaccine, chimeric vaccine, and the vector-based vaccine. However, they are all now at the phase 1 to 2 trial. So we have to see whether it can provide adequate prevention efficacy in the patient, in this high-risk patients. So I will make a brief conclusion here. The RSV infection is an important cause of admission for those respiratory infection in controlled heart disease patients, and carry high mortality rate still, especially in the development country. And the severity and the hospitalization rate is especially high for those with under 90s, especially controlled heart disease. Thus, pyrumab prophylaxis monthly injection has proved its efficacy to reduce hospitalization rate and severity. And the subtropical guideline proposed by Taiwan has proved its efficacy in subtropical area through multi-center study. And we may apply this protocol to the country with no previous RSV season. And the further guideline adjustment with extra doses for those with associated abnormality may be necessary. Thank you for your attention.
Thank you very much, Professor Cho, for your excellent speech. It's very informative. And now I would like to invite our audience, if there is any question, please. I saw in the chat board, there are 2 questions. Yes, please. Question 1 is from Dr. Professor Lin Yuzhi.
So, moderator, Professor Chen, you have to explain or to say what is the question.
Yes, okay. The question from Professor Lin is that he's asking that the expense of RSV provided by the National Health Insurance and is very expensive. It's very expensive, and so from the study, it shows that the preterm is most valuable in the first 9 months, and the duration of hospitalization is less than 3 months in these high-risk patients. So is this why we provide 6 months doses for these patients? So Professor Cho, do you have any comment for this question?
I think this is all about the cost and benefit because the pyrumab is still relatively expensive and it needs the monthly injection. So in the AP guideline in United States and other Western countries, they suggest 6 doses during the RSV season. And in our country, because there is no clear RSV season, but when we use the monthly injection for the 12 months, it will be double the cost. So we provide a modified guideline to provide the RSV pyrumab prophylaxis at a especially high-risk patient. And it will decrease our cost and also provide adequate immune prophylaxis for these high-risk patients. So I think this is the issue of cost and benefit. Maybe if someday the pyrumab is very cheap, then we can provide maybe till 2 years old. It is also okay.
All right, thank you very much, Professor Cho. Is there any question for Professor Cho? If not, I have one question for Professor Cho. I think this type of question goes to any type of vaccine. So after we giving regular giving to the RSV vaccine to those hemodynamic compromised congenital heart disease children, is that are we going to change any lower lung infection microorganism panel or virus infection panel during this type during the age?
I think it is a very difficult question because there is no such study about the virus or bacteria spectrum change after the pulmonary prophylaxis. We can know that after the prophylaxis, the ISV spread and ISV infection and the ISV infection rate will decrease dramatically. And maybe some may say if there is any virus strain change after the immunoprophylaxis, fortunately, because the immune is still target on the F protein, it is relative constant. So it will not, after prophylaxis, all of the strain can be prophylaxis now. So still till now, there is no breakthrough, there's still no virus strain which is resistant to the immune. So I think this may need further study about this issue.
Thank you very much. I think due to our limited of time, yeah, we have to close this session. Thank you again for your excellent speech, Professor Cho. Thank you.
Thank you. Thank you.
Okay. Thank you, the speaker, Professor Cho, and moderator, Professor Chen. Let's take a break. Welcome back 5 minutes later. Enjoy yourself in professional dessert. Back in 5 minutes later. Remember back on PM 1:30. Thank you.
Thank you. Bye-bye.
Bye. See you. Back. Have to back.
Hi, I'm Dr. Mu Shuqi from Single Memorial Hospital, Department of Pediatrics and Education, also staff of Wuren University Medical College. Okay, let's move on the plenary lecture, the hot topic symposium. We will talk about the novel coronavirus, especially Delta virus in children. It is important to discuss. It's our 12th annual scientific congress in pediatric pulmonology for 3 places across the strait. How to kill children with COVID. Let's take the beginning of the hot topic. Welcome the Professor Qing Yuan Lin, the moderator. Professor Lin, please. Thank you.
May I start? Okay. I'm Dr. Qing Yuan Lin, and the first speaker is the Professor Cho Zhengxun, and it's my pleasure honor to introduce Professor Cho Zhengxun. Professor Cho is a professor of pediatric infectious disease and currently director of the Molecular Infectious Disease Research Center at Chang'e Memorial Hospital, Chang'e University College of Medicine in Taoyuan, Taiwan. He received his medical degree from the Chang'e Medical University and his doctorate from the Graduate Institute of Clinical Medicine, Chang'e University College of Medicine. He completed a residency in pediatrics at the Department of Pediatrics, Chang'e Memorial Hospital, and the postdoctoral fellowship at the Department of Pediatrics, University of British Columbia, Vancouver, British Columbia, Canada. Dr. Chu's research interested focus primarily on pediatric infectious disease, antimicrobial resistant vaccines, Salmonella pathogenesis, bacteria-host interaction, and empiric infectious disease. Currently at Chang'e Memorial Hospital, he leads an infectious control committee and continue to pursue and expand his studies in microbiome genomics, bacteria-host interaction, and microbiome and fecal microbiota transplantation. He is the recipient of several research awards, primarily in the area of infectious disease. Dr. Chu is a member of the Pediatric Infectious Disease. Dr. Chu is a member of the Pediatric Infectious Disease Society, Taiwan Pediatric Association, and the Infectious Disease Society of Taiwan, among other associations. In addition, Dr. Chu has been reviewing manuscripts for a number of medical journals, including Journal of Infectious Disease, Clinical Infectious Disease, Pediatric Infectious Disease Journal, and the Clinical Microbiology and Infection, and currently serve as the Chief Editor of the Pediatric and the Neonatology and the Editor of the Pediatrics and the International Child Health, Journal of Microbiology, Immunology and the Infection, Biomedical Journal, Journal of Medical Microbiology, and the Journal of Formosa Medical Association. He is the International Advisor Board to the Journal of Pediatric Infectious Disease Society and the Clinical Infectious Disease. He has authored more than 450 scientific papers, including some in high prestigious journals such as New England Journal of Medicine, New England Journal of Medicine, and The Lancet, for which he has earned international recognition. Moreover, he is the author of 5 book chapters and has presented papers at many national and international scientific and medical journals. Today, Professor Chu will talk us about the overview of COVID-19 and the experience in Taiwan. Professor Chu, please.
First of all, I would like to thank Professor Chen and the organizing committee for the invitation. And it's my great pleasure to attend this conference. And today I'm going to talk COVID-19 in Taiwan from pediatric perspectives. Here is the outline of my presentation. I will give an overview on pediatric COVID-19. I will talk about the transmission dynamics. I will address the very specific so-called multi-system inflammatory syndrome in children due to COVID-19. And finally, I will talk a little bit about the epidemiology of COVID-19 in Taiwan. What are the clinical features of pediatric COVID-19? In general, children are less susceptible to SARS-CoV-2 infection. Even infected, they usually presented with less severe symptoms. And having said that, children with COVID-19 can become potential disease spreaders. And the clinical presentations reported from children across the world included asymptomatic infection and mild to moderate diseases, pneumonia, and critical patients. But majority of the patients actually belong to asymptomatic infections. And most of the children actually had only very mild clinical symptoms. This is a review article from Taiwan. This is a review article from Taiwan published in 2020. They reviewed 9 pediatric case series in the literature in 2020. You can see from this table, majority of children actually are asymptomatic or only mildly symptomatic. And you see 98% of the patients actually only had mild to moderate diseases. Only 2% of the pediatric COVID-19 patients are severe or critical. Now, we can take a look at the information from the states. in United States, there was a big community outbreak of COVID-19 in 2020. From this report, you can see among many confirmed cases, only about 1.7% of the patients are children less than 18 years of age. The median age of these patients is 11 years. And you can also see from this table, most of the pediatric cases are school-age children or adolescents. Talking about the clinical symptoms of these pediatric COVID-19 patients in the United States, they usually presented with fever and also respiratory tract symptoms, and they also presented with some systemic symptoms, including myalgia, runny nose, sore throat, and headache. And additionally, some patients presented gastrointestinal symptoms, including nausea, vomiting, abdominal pain, and diarrhea. Among the pediatric patients reported from the United States, you can see that only a small proportion of these patients required hospitalization or ICU admission. And you can see from this figure, only a higher proportion of COVID-19 patients less than 1 year of age required hospitalization or ICU admission. Now, moving to Korea. This is a study published in JAMA Pediatrics in 2020 from Korea. In this study, they reviewed 91 COVID-19 pediatric patients. Again, you can see from here, most of the patients actually are school-age children or adolescents. And most of these patients acquired the infection in the household setting. And of course, some of the patients is actually associated with some clusters, maybe in the school. From the same study, you can see that pediatric patients with URTI or LRTI usually carry a higher viral load in the nasopharynx compared to those who are asymptomatic. And following the onset of the illness, usually the viral load declined quickly. And you can see the decline is quicker in those who are asymptomatic compared to patients with URTI or LRTI. And the average duration of the presence of SARS-CoV-2 in the nasopharynx of these patients is about 2 weeks. Talking about the association between the diagnosis and symptom onset, you can see from this slide, more than half of the children actually presented symptoms prior to the onset, prior to the confirmation of the diagnosis. And the median interval between the illness onset and diagnosis is about 3 days. 6.6%, a small group of the patients actually were diagnosed right after the symptom onset. And 20% of the patients actually presented symptoms after the diagnosis. So we can say that for children, early diagnosis remains to be a problem given the non-specific presentation of the COVID-19. Also, from the Korean study, you can see that majority of the patients actually presented with very mild disease. About 22% of the patients actually are asymptomatic. Only 2% of the patients required intensive care. In this Korean study, you can see that most of the patients actually associated with the household clusters, and a few patients imported from the overseas, and a few patients probably contracted the infection in school. But after school closure, the cluster at school of COVID-19 is usually very rare. And the world has changed nowadays. As you know that there is an emergence of Delta variant that caused epidemic in many countries. So Delta variant actually right now is sending more pediatric patients to the hospital. And you can see from this figure, since July 2021, there is a sharp increase of child COVID-19 cases in the United States. And according to the report from the states, children actually represented about 15% of all available COVID-19 cases in the states. And 11 states actually reported 18% or more of the new cases were children. So in the United States, as of August 2021, the incidence of COVID-19 in children between 5 to 11 and 11 to 15 years of age actually surpassed the incidence of COVID-19 in adults more than 50 years of age. And the situation is also observed in Australia. You can see from the figure in the left upper panel, there is a sharp increase of the COVID-19 cases after July. And from the left lower panel, you can see majority of these new cases actually are adolescents and young adults. But fortunately to say, you can see that in terms of the death rate of these patients, the death rate in the young adults and children actually remains to be very low. Now I'm going to talk a little bit about the viral shedding in children with COVID-19. In general, the duration of viral shedding in the respiratory tract range from 10 to 14 days. And some patients may shed the virus longer for more than 21 days. And the highest viral load in the nasopharynx of the patient usually can be found in the pre-symptomatic period. That is 3 days before the illness onset, and also in the first 2 days after the illness onset. And it's very interesting that the virus can be shed from the stool for 2 to 3 weeks, which is longer than the shedding in the respiratory tract. But whether or not this viral shedding in the stool causes environmental contamination remains to need further studies. This is the case report of the first Korean pediatric case in the literature. You can see from here, after illness onset, from day 0, you can see the shedding of the virus from the upper respiratory tract can persist as long as about 2 weeks. But the shedding of the virus from the stool actually can last longer for nearly 3 weeks. And here is the X-ray and CT scan of this patient. You can see the ground glass opacity of the COVID-19 infection in the lung of this child. As I mentioned earlier, that although the disease usually is milder in children with COVID-19 infection, but they can children can be viral spreader along the course. According to a study from Canada, they traced more than 6,000 families in 2020. When one index case less than 18 years of age appeared in about 27% of the family, 7 secondary cases usually can be identified afterwards. And those index cases less than 3 years of age, in fact, are 40% more infectious than adolescents, 14 to 17 years of age, to spread the virus in the household setting. And you can see the figure at the right lower panel. You can see young children less than 5 years of age usually carried a higher viral load than older children with COVID-19 infection. And in the left panel, you can see that if a young infant with COVID-19 was killed at home, the young infant can even shed the virus to the environment. For example, in this figure, you can see the virus can be found in the infant bag and also can be found in the infant's cot side and also on the table. And such environmental contamination can facilitate the spread of the virus in the household setting. This is another study from states showing the household transmission of SARS-CoV-2 from children and adolescents. They traced 377 household contacts of COVID-19. And among them, 12.7% turned to be positive. And the serial interval, the average serial interval between two patients is about 5 days. So the suggestion based on the result is that children with a non-exposure SARS-CoV-2 history should remain at home, don't go outside, and maintain physical distance from other household members to avoid or to minimize the household spread of the virus. School is a very important place for school-age children and adolescents to learn. And during community outbreak, school closure is a very important measure to contain the spread of the virus in the community setting. But eventually, the school must be reopened. This is a very nice study published in Science in 2021. They show that when school reopened, at least 7 to 9 different kinds of infection control measures should be implemented to minimize further spread of the COVID-19. What are the effective so-called NPI, non-pharmaceutical intervention should be undertaken when school reopen to minimize the risk of virus spread in the school? And these measures included mask mandate for students, mask mandate for teachers, same school at a class all day, same students at a class for all day, outdoor instruction, restricted entry of the school, reduced class size, no extracurriculars, and daily symptom screens for children and also teachers. And a few measures actually are least effective in terms of the infection prevention, such as closed cafeteria, closed playground, and use of the desk sheets. I think these information are very important for the teachers and school faculties to implement some non-NPI to avoid COVID-19 spread after school reopen. Now I'm going to move to emerging inflammation condition associated with COVID-19 in children. This refers to multi-system inflammatory syndrome in children, so-called MISC. And MISC refers to children who develop Kawasaki disease-like appearance with signs of systemic inflammation. This specific clinical presentation only found following COVID-19 infection. And in terms of from children with MISC, usually presented symptoms very similar to Kawasaki diseases, including bubble conjunctivitis, red and cracked lips, and cervical lymphadenopathy, and skin rash. But there are two hallmarks of the clinical presentation in children with MISC. One is the left ventricle dysfunction that may result to shock of the patient. And also the other one is the very common digestive tract involvement. This table shows that the top 4 mucocutaneous presentation of MISC include diffuse non-specific skin reaction, eruption, the dry and crackled, dry, red, and crackled lips of the patient, and the hand and feet erythema and edema. Here are some pictures that I took from the publication. You can see that the cervical lymphadenopathy, the erythematous skin eruption on the trunk, and also the edematous and erythema change of the palm of the patient. Again, a hallmark of the clinical features of MISC in children is the GI tract involvement. A high proportion of these patients actually presented with abdominal and GI symptoms, including vomiting, diarrhea, and also abdominal pain. Most of the patients actually presented with fever, and a high proportion of them, they presented with shock due to LV dysfunction. And this is a nice study from States showing that the median age of MISC in US is about 8.7 years, which is a little bit higher than the average of Kawasaki disease we saw in the Asia. And coronary artery involvement can also be found in children with MISC in about 8% of the patient. And according to the report from the States, less than 2% of the MISC in children actually showed the mortality. And cardiac presentation in MISC is very important. As I mentioned earlier, majority of the patient, about 1/3, presented with shock due to LV dysfunction, and also around 10% of the patient may presented with coronary artery involvement, like what we saw in Kawasaki disease. And this is a study from States showing that the peak of the occurrence of MISC in children always follow the peak of COVID-19 in the general population. There is usually a 1-week interval between the 2 peaks, suggesting that MISC is an immune-mediated disease following the COVID-19 infection. It has been reported in from many countries that adults with COVID-19 can present it so-called with long COVID syndrome. And this is also true for children, especially for children between 17 to 24 years of age, and in those young adults, long COVID-19 is not that uncommon following the acute infection. And long COVID syndrome in children usually included fatigue, muscle and joint pain, headache, insomnia, and respiratory problems following the acute COVID-19 infections. And these symptoms can persist for years. And long COVID syndrome is also more common in children with MISC. And this is a table comparing another very important viral infection in children, which is influenza with COVID-19. And there are three big differences between the two infections. First of all, in terms of the incubation period, the incubation period in influenza is significantly shorter than the incubation period of SARS-CoV-2 infection. The major difference between the two infections is that SARS-CoV-2 infection usually showed a very strong pre-symptomatic transmission of the virus. And this is not the case in influenza. In terms of the risk factors for severe disease, there's some difference. The severe influenza usually occurred in the very young and also in the very old population. But SARS-CoV-2 infection, severe SARS-CoV-2 infection can occur in young adults and also in the elderly with chronic illness. In contrast, children with SARS-CoV-2 presented with less severe disease. And again, pediatric cases between influenza and SARS-CoV-2 infection also different that I have mentioned in my previous slides. And with this figure, I would like to emphasize that COVID-19 is highly contagious 3 days before the onset of the illness and also 3 to 5 days after the onset of the illness. So a wider period of contagious stage make this infection difficult to control. And also pre-symptomatic transmission of the virus in COVID-19 is the hallmark of the SARS-CoV-2 infection. Now I'm going to talk a little bit the epidemiology of COVID-19 in Taiwan and what's happened in Taiwan right now. And in Taiwan, since mid-May, we have seen a big community outbreak caused by Alpha variant in Taiwan. But with the implementation of lockdown and also non-pharmaceutical interventions, the community outbreak can be well controlled in 2 months, as you can see from this figure. Among the cases identified in this community outbreak, only about 6.9% are children. And majority of these pediatric cases actually are school-age children or adolescents. And they all presented with mild diseases, and there is no mortality reported from these pediatric cases in Taiwan. And as you can see from here, the occurrence of pediatric cases always follow the peak of adult cases in the community. And the so-called serial interval between the two peaks is approximately 5 to 6 days. This is in accordance with some previous literature publication from other countries. Majority of the pediatric COVID-19 infection in Taiwan usually associated with household clusters. And here I'm showing you some clusters reported from Pingtung City in southern Taiwan. You can see that one of the 4 clusters actually caused by the Delta variant, and the other 3 actually caused by the Alpha variant. But you can see from this figure that the pediatric cases labeled as the red circles always occurred at the outskirts of these clusters, suggesting that the pediatric cases usually acquire the infection in the household setting or in the clusters from the adults or from their families. And again, I'm showing you the cluster analysis from patients in Keelung City in North Taiwan. You can see that the red circles, usually who are actually pediatric cases. Usually the infection occurred in these children at the outskirts of the skirts of the clusters, suggesting that children usually acquire the infection from their families in the household setting. And so 2 most important places for children to acquire COVID-19 infection. One is school, the other one is family, household. And so in terms of the infection control, when school reopen, first of all, we should promote vaccination for both students and children. Also, mask mandate, very important. Always, we have to keep physical distance for students and also teachers, and better to keep a good ventilation for the classrooms. And also, we have to encourage hand washing, and also once you see any suspected case, immediate and quick contact tracing is very important. And in the household setting, again, we better get vaccinated for all family members. And also be sure to get everyone in your family who is more than 12 years of age to get the vaccine. And also try to wear a mask in the public place. This is a figure showing that with the implementation of a different level of the lockdown and the MPI, and the community outbreak in Taiwan beginning in May actually gradually controlled in about 2 months. And the different black and color actually in this figure actually reflect the level of the non-pharmaceutical intervention implemented. So MPI actually, strict MPI implementation is very important for an outbreak control. And again, these figures shows that the importance of MPI in terms of the control for a community outbreak. In Taiwan, in this community outbreak, with the implementation of MPI and lockdown, you can see that the estimated reproduction number actually returned to below 1 very quickly. And from the our experience acquired from the this outbreak, we found that all the interventions usually take 2 weeks to see the outcome. This is a very interesting study from my hospital, Changgen Memorial Hospital, showing the importance of MPI during the community outbreak. You know, from 2020 to 2021, Taiwan actually implemented very strict MPI for population not only in the hospital setting, in the public setting, but also in the community setting. You can see that very interesting we analyze in this study, we analyze the pneumococcal infection in children following the implementation of this MPI in 2020 to 2021. You can see the sharp decline of severe pneumococcal disease in all age group of the persons following the implementation of MPI and lockdown. So this is a so-called collateral benefit from the very strict lockdown or MPI implementation for COVID-19. We see the also the decrease of other respiratory tract infections. In this case, it's pneumococcal infection. Not only the MPI, but also vaccination, very important. And the rollout of COVID-19 vaccine is very slow in Taiwan. You can see from here, with the beginning emergence of the community outbreak of COVID-19 in May 2021, we started to push the vaccine rollout in mid-May. But as of August 29, 2021, the overall one-dose COVID-19 vaccine coverage in Taiwan is about 42%, and two-dose coverage remain very low at about 3.7% at the end of the August. But I think not only the MPI, but also this rapid vaccine rollout also play a role in the overall control of the community outbreak of COVID-19 in Taiwan. So here I would like to stop my presentation. So in conclusion, that in general, pediatric patients usually presented less severe disease of COVID-19, but they potentially can become spreader of the virus. And MPI in school and also in the household setting, very important to prevent COVID-19 clusters involving children. And vaccination is also very important. Now the vaccine, many vaccines, COVID-19 vaccines is now approved for the use in the pediatric population. So it's better for all the countries to get their children vaccinated for COVID-19. Thank you for your attention.
Good afternoon, ladies and gentlemen. I am Professor Helen Sun from Zhongshan Medical University Hospital, and I appreciated the opportunity to listen to the wonderful speech from Professor Chu. This speech talking about the COVID-19 infection in Taiwan, from epidemiology to clinical condition. We are lucky the mortality of children in Taiwan is still very low. Now, we are going to our question from our members. There are some questions in our audience. This is a question from Yu Zhi Lin. The virus shedding from carrier range from 2-3 weeks. So the question is it safe to have the quarantine period for only 15 days in Taiwan now? So Professor Chu, are you online?
Can you hear me?
Yeah. Professor
Yeah,
Chu.
I think yeah, for alpha variant, I think 14 days quarantine plus 7 days of self-health control is enough. But for Delta variant, they tend to shed longer. But it has been observed that at a later stage of the shedding, the viral load is not that high. So if the quarantine remains at 14 days,
if you check at the viral load by RT-PCR at the end of the quarantine, if the viral load is more than 30, let's say 31, 32, I think you can still, it's still safe to move from quarantine to health monitoring for 7 days more of health monitoring. So I think currently the Taiwan CDC keep 14 plus 7 days for those infected by Delta variant is based on such observation.
So I think Taiwan is safe right now. And there have another question. We know it is difficult for young children to keep social distance from carrier, and it also difficult for them to wear a mask. Since the COVID-19 severity is decreased, especially we got vaccination. So will it be better to treat COVID-19 as flu in the following day? Thank you.
Yes, always it's very difficult to implement MPI for children, and that's the reason why we should encourage immunization. And now we can immunize adolescents from 12 to 18 years of age, and also I think a lot of clinical trials are being undertaken to evaluate the efficacy and also safety of the vaccine for younger children. So I think vaccination is the most important. And you mentioned about we should treat COVID-19 as influenza. This is correct. I think, but we should base on, I think such concept should be based on a situation. If we can reach the vaccination rate for all population more than 70%, one dose, at least one dose coverage for 70 to 80%, two dose coverage for 30 to 40%. I think we should treat COVID-19 as influenza. But right now in Taiwan, we still have to push people to get immunization.
Okay, thank you, Professor. Thank again, Professor Chu, share the important speech with us. And we also thank for our co-chairman, Professor Lin. And we will close this session due to limited time. Okay, thank you. Bye-bye. See you.
Okay, thank you. Thank you, the speaker, the Professor Cho, and the moderator, Professor Lin and Helen Sun. Let's pass on the following lecture. Welcome the moderator, Professor Ya Yu-Chen. Professor Chen, please.
Good afternoon, ladies and gentlemen. I'm Dr. Jia Yichen, and my dear co-chair is Dr. Daijin Yang from Ruan General Hospital in Kaohsiung. It's a great honor for me to introduce the speaker, Dr. Daniel K. Ng. He is the founding president of Asian Pediatric Pulmonology Society, as well as the honorary consultant, Hong Kong Sanatorium and Hospital. He also served as the honorary consultant pediatrician in Guangwan Hospital and the United Christian Hospital. He is the honorary council member of the Hong Kong Society of Pediatric Respirology. Dr. Ng's main research interests are sleep disordered breathing, asthma, and allergic rhinitis. He has published 108 peer-reviewed papers. He is currently the associate editor of Journal of Pediatric Respirology and the Critical Care Medicine and the Respirology Case Report. The topic of his special lecture today is ambulatory pediatrics during ongoing COVID-19 pandemic. Dr. Daniel Ng, please start your talk.
Good afternoon, ladies and gentlemen. Thank you for coming to today's meeting. My name is Daniel Ng, founding president of APPS.
I'd like to thank the organizing committee and especially Polytechnic Central for organizing this excellent congress. And at this time of pandemic, I think it's very appropriate and timely for us to exchange ideas. Today, I'm going to talk about COVID-19 in embryonic pediatrics. For COVID-19 infection, the incubation period is 5 days, and it's infectious before the onset of symptoms. You usually go through the flu-like illness with fever, sore throat, cough, running nose. Most of the patients will directly move from phase 1 to phase 3 with recovery. A small subset of children will develop critical illness, and that usually starts in day 5 to day 7, with excessive immune response leading to a different organ failure, like the respiratory tract ARDS, myocarditis, or DIC. For COVID-19, most of them are in adults. The children only account for 2%, as reported from China and the United States. For children with contact history, and you screen them with a swab, 12% of them will be positive from nasopharyngeal swab or throat swab. And of these 12%, 65% of them will have pneumonia, 20% of common respiratory tract infections, and 16% of them would be asymptomatic. Only 2% of infected children require ICU care. For all children admitted to hospitals, half of them belong to mild severity, 40% belong to moderate severity, 5% belong to severe COVID-19 disease. And of the admitted children, 6.6% of them require ICU care. This line shows the symptomatology of COVID-19 in children. You could see that the commonest clinical features are fever and cough, and followed by URI symptoms like sore throat, pharyngitis, rhinorrhea, fatigue, and malaise, and followed closely by GI symptoms like vomiting, nausea, diarrhea, abdominal pain. Skin rash and anosmia account for a small percentage of children. Looking at children of healthcare workers, this study in UK screened for COVID infection in 1,000 children. 7% of them turned out to be positive, and the median age is 10 years. Half of this group of children are asymptomatic. The other half has symptoms of fever, GI symptoms, headache, lethargy, change in smell. Change in smell is not uncommon in patients with COVID-19, with either loss or decreased smell or distorted smell. The dysthymia is, of course, more disturbing because you could smell something noxious even when you're smelling perfume. And looking at this group of patients, the rhinorrhea and nasal congestion is actually quite mild. So the suggestion is this smell disorder is in fact neurosensory problems rather than due to conductive problems and due to inflammation of the olfactory neuroepithelium. In Hong Kong, 3 cases were reported. All are teenagers. The first case, a 17-year-old girl. The only feature of COVID is anosmia, lasting for 8 days. The second case is a 15-year-old girl with mild running nose and anosmia again, lasting for 8 days. And last case is a 14-year-old boy with transient anosmia, much shorter time of illness for 3 days. So for COVID-19, divided into mild, moderate, severe, and critical. So the mild case is the common upper respiratory tract infection. The moderate one is tachypnea with only mild or no insucking. The severe one is tachypnea with moderate severe insucking or hypoxemia. The critical case involves organ failure with ARDS, shock, encephalopathy, myocarditis, DIC, or acute kidney injury. The severe critical case occur more commonly in infants. Up to 11% infants will develop severe critical illness. The risk factor for severe disease are age, the young age, the infancy, and teenagers. They have more than one comorbid conditions, or they have cardiac and neurological disorders, or they have obesity. Multi-system inflammatory syndrome in children is recently described. It's not unlike that of Kawasaki, with high fever of at least 3 days. So it's important not to suppress this sign with regular ibuprofen. And also with the two of the following criteria being fulfilled. Number one is GI, with vomiting, diarrhea, abdominal pain. The next is non-purulent non-conjunctivitis, skin rash, mucosal changes in the lip or tongue, the kidney insucking. Also, you need to exclude other infections before we said this is a multi-system inflammatory syndrome of children. Interestingly, SARS-CoV-2 PCR is often negative, and the diagnosis is based on the IgG being positive. The median age is 10 years, and nearly 44% of them require PICU admission. Management of mild moderate COVID belongs to every expertise of general pediatrics. We should be able to maintain hydration and nutrition, prescribe as needed antibiotic like paracetamol to control the fever and relieve the discomfort. NSAID like Brufen should be used with caution because the regular use of it may delay diagnosis of multi-system inflammatory syndrome with the suppression of fever. It will also make the brain tendency worse for undiagnosed thrombocytopenia, which is not uncommon in children with COVID. And also, the animal study has shown that reducing fever may increase the adverse outcome. For SARS-CoV-2 transmissions, looking at about 400 children and adolescents with COVID-19, 70% of them report contact history, and almost all of them have contact history of infected family members. It's important to vaccinate the adults to protect the children who could not be vaccinated, especially for young children. Co-infection is quite common in COVID infection. It's up to 40% in one reported series. The co-infections are usually flu A, B, so it's important to give flu vaccination in the coming season, RSV, and mycoplasma. As we know, severe disease is more common in infants, so one should consider to give azithromycin empirically for infants who develop COVID infection, so as to decrease the chance of hospitalizations, which is very important in the current epidemic because of the paucity of bed availability in many countries. The hospitalization rate is very high in infants, about 15 to 60%. It's much lower in older age group, 4 to 14%, which of course is lower than that in adult, which report as high 30%. Mortality in children much lower, 0.1% compared to 2.3% in adults. For COVID-19, different social measures have been adopted to control the spread. One is the COVID-19 lockdown. There are some unintended consequences of this. There's evidence of increased depression in children, but not anxiety. And risk factors include loneliness, reduced access to play, or increased access to social media. During this pandemic, almost all children spend their schooling at home, so-called homeschooling. Of course, there will be some biological effect, with increased myopia reported up to 3-fold from China. The lack of social contact, outdoor activities also affect the psychological well-being of children, especially those with special needs, those with parents with mental health problems, or those coming from single or low-income family. To decrease the impact, we should encourage a good sleep hygiene, so avoid social media exposure a few hours before sleep onset time, rise in the morning, exercise adequately during the afternoon for an hour or so, and also we should encourage the parent-child interaction with interactive play, playing together with the electronic device, games, or watch the television together. Vaccine is our best hope to control the pandemic. And fortunately, WHO concluded that the BioNTech is suitable for use by children older than 12 years. So it's not uncommon for us to be asked the adverse effect of COVID vaccine. The most worrisome is the myocarditis. It is more commonly reported from male adolescents, young adults, more than equal to 16 years old. And the main reported are the mRNA vaccines, and usually occur after the second dose of it. So the Pfizer Moderna one is reported to have a higher incidence of this myocarditis, and usually occur a few days after vaccination. And up to August 11, 762 cases have been reported. Most of the myocarditis are mild, with only some chest pain, and full recovery are expected or have been reported. So for all vaccinees, we should advise against strenuous activity for 1 week. And there's a speculation that the patients who develop this myocarditis may be inadvertently given IV injection of vaccine when the syringe is inserted in the muscle but not aspirated. So we do not know whether it's in fact intravenous. Because we know that COVID vaccine injected intravenously will cause myocarditis. To diagnose COVID vaccine-related myocarditis, we need the appropriate clinical symptoms, i.e. chest discomfort, and then airway myocardial markers with airway troponin T, troponin I, or CK. Also, we also demonstrate the ECG, echo, MI abnormalities before we said this patient has suffered from COVID vaccine-related myocarditis. Herd immunity is important to contain this pandemic. So we need to know the arithmetics. First of all, the reproductive number, the basic reproductive number, the R0, which refers to the number of cases infected by one case. And the R0 allows to calculate herd immunity required to contain the pandemic, meaning that the number, the incidence will decrease with time. The threshold is this formula, R0 minus 1 divided by R0. We know that the new variant, the Delta variant, has much higher infectious rate. One patient infect up to 7 persons. So simple arithmetics, the herd immunity required with 86%. We know vaccine is not 100% effective. The BioNTech has been reported to be effective for 88% of patients, vaccinees. So the vaccination rate required to achieve the 86% herd immunity would be 86% divided by 88%. And that means that we need to vaccinate 98% of the population before reach the threshold to contain the pandemic. So in effect, it means that if the current situation continues, it's very unlikely we contain the pandemic. Because I think in almost all population, 98% vaccination rate is impossible. So we have to decrease the R0, but that allows to have lower vaccination rate to contain the pandemic. So how? Well, COVID vaccine, one of the current problem is COVID vaccine does not produce IgA. Okay? So it will not protect the mucosal cells from being infected by COVID virus. And this asymptomatic infection of the upper airway is very common in children. You could remember that half of the children of healthcare workers are asymptomatic carrier. So it's important to try to eradicate the mucosal infection that is asymptomatic. So here comes the nasal vaccine. A very good example, i.e. the flu vaccine, FluMist. This is a live attenuated co-adapted temperature-sensitive trivalent influenza virus vaccine. It's engineered not to cause disease, and it mimics the natural infections and stimulates production of IgA and IgG. So nasal herd vaccine is being developed right now, pioneered by Hong Kong U, and they use the live attenuated influenza virus, modify the genes so that the spike protein of SARS-CoV-2 is expressed. It's currently undergo phase 2 trial. Hopefully, we'll have it in a short time, and that will improve the control of asymptomatic infection of the nasal or pharyngeal mucosa. That's in fact the main factor that leads to increase in the basic reproduction number. There's a lot of collateral damage. A lot of patients do not want to go to clinic or hospital now, especially those who are sick because they do not want to get sicker with COVID. So the end result is a lot of chronic disease patients with asthma, diabetes, epilepsy, tech-dependent patients have very high default rates. So someone with a ventilator round the clock or for most of the time of the day, they will be reluctant to go to clinic to have a checkup. So with changes of their conditions, they will not be able to adjust the setting because they have no access to clinical service. Technology-dependent children is defined as more than one technology used to maintain health or well-being. The commonest tech-dependent children are in fact those on home ventilation for more than 16 hours per day. Even in normal time, the children and the parents may face high stress because of the fact that they are on ventilator. The parents need to keep a close eye on them, and the children also know the problem, their current chest infections, and so on. So with this limited access to medical establishment, it will make the situation much worse. The patient will be, and parents will be very stressed and feel unhappy with the current situation. So here comes telemedicine. As you know, necessity is the mother of all invention. So the patient cannot come to us, we cannot go to them. What do? What we connect by internet, telemedicine. Okay, that is the new norm. To run an efficient telemedicine service, we need good technical support. Okay, audiovisual equipment, internet hooked up at a decent speed. To start the consultation, I think it's no different from a face-to-face clinic consultations. We should introduce ourselves, explain the purpose of this consultation, make sure that we're talking to the right people. So the identity of the carers should be identified, and then we confirm the carers that they are parents with responsibility for the kid. We need to confirm their consent to have this clinical consultation done remotely. So I'd like to present a model of this hospital-at-home service for home ventilated patients that incorporate the use of telemedicine. So in this model, we have the different team members, okay, that include nurses, technicians, off-site doctors. So what we do is we first, the off-site doctors see a patient remotely and then see the problems. And a team of nurses and technicians goes into the patient's home, assess the clinical conditions, check the data from the ventilator, set a monitoring mechanism like the overnight oximetry, overnight transcutaneous CO2 monitoring, or level 3 ESG monitoring. All this data gathered, then the attending doctors will communicate with the team while the team is at the patient's home, and then to decide on the intervention required and see whether the patient tolerates well the intervention. The intervention include adjustment of ventilator setting, the iPad being inappropriate, appropriate, and so on. The circuit being well done with little ring out. The nurse assess the tracheostomy and gastrostomy. If that's not optimal, then they will try to teach the parents how to optimize care of this stoma site. And also there's many different nursing issues like pressure ulcers, skin rash. The nurse will help the parents to understand the conditions and how to home manage the conditions. Eye care is important. A lot of these patients are neuromuscular, the eyelid cannot be closed properly. So appropriate eye care is very important, not to be missed. And a lot of these patients are on elemental diet, so we need to check the dietary provision to make sure it's adequate. We also found that the psychological problems like depression and anxiety is very common in the parents. We also provide clinical psychological support by clinical psychologists who deliver the service remotely. So far, this program has been done for a year. We have 12 patients. The age is from 4 to 40 years. 8 of them are spinal muscular atrophy, and 4 are other myopathy patients. 4 have been tracheostomized, and 5 are on 24-hour ventilations. We look at the data. An average of 2.5 problems are identified in these 12 patients. And with this team approach, all these problems is either solved or has been improved or lessened. And we ask the parents and the patients, and all we got this service excellent. Well, COVID-19 is obviously a big threat to the normal life of humanities. But there's also other aspects, the benefits of COVID-19. I'm sure you noticed a significant decrease in respiratory admission, and also there's a significant decrease in late preterm delivery. And that's probably related to less pollutions, and the mothers getting more rest at home. For respiratory infection, this is interesting data from the US. You could see that the asthma admissions from 2016 and 2019, okay, and while for 2020, it dropped precipitously a week or so after the report COVID-19 pandemics. Okay. So the similar data was available from the US, the UK, and Europe. There's nearly 80% reduction in asthma emissions. And also, not surprisingly, respiratory infection also decreased by a huge percent, 80%. So I think this reduction in infection in respiratory tract that leads to a decreased emission for asthma. There's also similar reduction in other respiratory diseases, although the impact on non-respiratory diseases are much less marked. A similar trend of decreased emission for respiratory diseases are also observed in Hong Kong. And looking at the macro factors, we noticed that the NO2 has been reported to have a significant reduction of 60%. I would like to end with this slide that shows our home, a beautiful Earth, and here are Asia. Asia is a huge expanse of lands, and where hosts the three most populous countries, i.e. China, India, and Indonesia. I think members of APPS are very important to band together to share information, develop programs to cater and protect children of your own countries. We should collaborate, exchange information, promote health practice that ensure well-being of our children. It's important to remember we are one family. Okay? When we share our resources, our information, I'm sure together we'll overcome the current challenge, and tomorrow will be better than today. And in a reasonable time frame, we'll be able to overcome this pandemic and make it manageable. Hopefully, next time we meet in the APPS conference, we can all look back and see how good we have done to bring our community back to a normal level of activities. So with this, I'd like to thank you all for your attention. Thank you.
Okay. Thank you, Professor Wu.
Thank you.
For your wonderful speech. It's really informative and helpful for us. And I am Haijin Yang from the General Hospital in Kaohsiung City, and I hold this session for our discussion. And I see one question is from our society member by Jenny Lee. Yes, is there any contraindication in using ibuprofen? This is question one. Okay, thank you, doctor.
Yeah, hi. I'm sorry I'm late. And the problem with my connection. For ibuprofen, I think it's very commonly used, especially in the private sector, because of the pressure to control fever. But we know that in animal studies, ibuprofen would increase adverse effect by decreasing the perfusion of the kidney. So if we have equally effective medication like acetaminophen, I think we should not be too eager to suppress all the high temperature and give a false sense of security. So yes, it's safe. It's not unsafe to give ibuprofen, but probably it's safer to give acetaminophen, and there's no extra benefit.
Okay, thank you. And Professor Wu, there is another question from our society member. His question is, how the insurance company qualify the quality of the telemedicine? Does the laws confines doctor change after telemedicine come out?
I don't know now how the insurance company ensure the quality of doctors, because we bill them, and they sometimes they come back and ask us to clarify, but that's all. They do not really audit our practice. Luckily, I mean, not yet. I'm not sure when Taiwan, where the insurance company audit your management and grant round your case, but in Hong Kong we don't. It's just as long as we are reasonable, that's fine. I think that the challenge of telemedicine is that, yes, as you said, the funding model. How do we charge the patients, and how do they get reimbursement? I think that require
trilateral negotiation between the medical care provider, the doctors, the insurance companies, and the parents. I think the law is not very clear on this in Hong Kong. But I think that as long as we practice a reasonable standard, meaning that we establish consent, ideally we saw a patient first before face-to-face, before move on to telemedicine.
Okay, thank you, Professor Ning. And another question from me. Can I ask a question? And do you ever meet any problem during your intervention to the children by the teleconference? Do you ever meet any problems?
I think that, well, luckily have not yet. The problem is mainly the communication. We need to make sure that the logistic of it, meaning the parents can communicate by internet. It's just like me using the WebEx, and I have a problem this morning in the clinic. So I mean, technical support is very important. And next is the communication between a team and a doctor. Let's say I change the iPad setting. They must repeat my instruction. So I make sure they understand my instruction. And then they're going to apply to it to the patients. The miscommunication, the wrong communication is the biggest problem. I remember one time I said increase the iPad to 25. And then I said, okay, perhaps not, we should go down a little bit down to 23 first. But technician already down up to 25. So I think it's important to make sure both sides has a feedback. So he repeat what I said, and I should okay that before he does action. So the communication needs to be double check and would be slower than usual face-to-face communication.
Okay, thank you. There's no other questions from our audience. And okay, due to time limited, we thanks again for Professor Ning for bringing us such a wonderful speech, and looking forward to meet you again in our conference. Okay, yes. Thank you. And let's move forward to the next section. And I have to close this session. Okay. Thank you.
Okay.
Thank you.
Thank you. Thank you, Daniel. Just wondering, because the telemedicine could be the XU in private, because the telemedicine without PE, the physical examination, what's the difference? Okay, I just wondering, maybe ask a question in children. Okay, thank you, Daniel. Our old friend and dear friend, wish you everything and could be and should be everything. Okay, are you?
Yes.
Okay. Everything is okay. Okay, Daniel. Okay, miss you. Thank you. Thank you, Daniel, and the moderator, Professor Chen and Professor Yang. And that's close the session. Keep going to the next talk. Welcome the moderator, Professor Xiu Zhan. Professor Zhan, please.
Dear colleague, thank you for being here this afternoon. I'm Dr. Zhang from Zhanghua Short-Term Memorial Hospital. It's my great pleasure to co-chair with President Dai, and my great honor to introduce our distinguished speaker from India, Dr. Varinder Singh. Dr. Singh is a Director Professor of Pediatrics in Lady Hardy Medical College and Associate Kalavati Children's Hospital in New Delhi. He trained at Maulana Azhar Medical College in New Delhi and worked with the Pediatric Chest Disease Unit at the leading Lucknow Yak Hospital for 6 years. His field of research or expertise are tuberculosis and pediatric respiratory disease. Dr. Singh is recipient of the Commonwealth Academic Staff Fellowship in 2003 under Professor Andrew Bush at Royal Brompton Hospital, London, UK. He currently champions the cause of rational antimicrobial use and also in leadership position for the Indian Academy of Pediatric National Respiratory perspective. Besides, Dr. Singh is the founder of Asian Pacific Pulmonary Society, APPS, and member of the editorial board of Pediatric Respiratory Review, India Pediatric, etc. Today, he will be sharing with us his childhood experience of COVID-19 in India. Please start.
Good afternoon. Greetings from India. I am thankful to the organizers for having given us this opportunity to share with you the experience of management for COVID-19 in children in India. I work at Lady Hardinge Medical College and an associated children's hospital in New Delhi, India. What I'm going to talk to you about is what has been the burden of disease amongst children in my country. What is the clinical presentation and how does it compare or contrast with the clinical presentation elsewhere? Talking about the multi-systemic inflammatory syndrome in children, which is a unique presentation or a unique way the disease manifests amongst children, our experience of that. Then I'm going to talk about the pandemic management, what all was done in our country to manage it, what all was affected because of COVID. There were some collateral damages and then some carry home messages. As a disclaimer or an acknowledgement, I acknowledge that while the sources have been named, but some of the authors were anonymous because of the online sources. There I may not give those names. If you look at the COVID pandemic dashboard till last week, the world has seen practically 3 waves, or if we consider this part as a continuation of the same wave, 2 waves. And this purple part, which you see here, represents Southeast Asia, and India, with its population of 1.2 billion, forms the most populous state within Southeast Asia. So the bulk of disease or pattern which you see here represents my country. So we had first major wave in about September, October in 2020, and then a much larger wave thanks to Delta virus in March, April, May, and now there is another surge which has happened in some of our southern states. People say it's a continuation of the same wave, or maybe it's the third wave. Whatever it is, the cases which have started declining are slowly increasing again. And what these 3 waves mean to us, apart from maybe there is a new variant and maybe the disease pattern may have changed, more than that is the understanding that when we were in the first phase, we were in absolutely new, uncharted territory. There were preparations for pandemic, but nobody knew the scope of things. Nobody knew how bad and how fast it is going to hit. There were experiences coming from other countries who were hit earlier than us, like US, UK. Yet, it took us some time because there was a big lag. And its own difficulties and its own challenges. We are a populous country, very heterogeneous. When it comes to urban areas or big cities, you have almost all possible healthcare available. But when it goes to the distant areas, in the rural areas, or certain not so well off areas, things are very challenging there. And this is the disparity which comes very often in your face whenever there are disasters, whenever there are emergencies, and COVID was one of them. By the time we reached second wave, we were better off. We had diagnostic capacities, we had personal protective equipment, yet it was such a big onslaught. It also challenged us so much that at some point of time, we did require our friends globally to help us tide over. It was for a week or two that things were totally out of hand. there was lack of oxygen because suddenly the things spiraled out. So that's a very important learning from COVID pandemic, that the redundancy you have to build in the system is perhaps huge, which may be very difficult for challenging economies. At the same time, you have to have a system in place which can very rapidly extend and expand. And that's what we currently are working on, anticipating a third wave and hoping it doesn't happen. So when it comes to children, the children were not as often affected, as nearly about 10% of our all confirmed cases were below 20 years. We do not have a complete age disaggregated data with us. And this proportion did not differ a great deal between first and second waves. While the number of adults who were affected in the second wave were huge, but the proportion of adults, the total numbers were high, but the proportion of adult in pediatrics was maintained to about 10-12%. When it came to hospitalization, children had much lesser need for hospitalization. There were less than 5% of children who required, of the patients who were hospitalized, who were amongst children. We did come across this unique condition, which is multi-inflammatory syndrome. This is less than 0.1% of all COVID cases, but very challenging indeed. And I will discuss more about it as we go back. Since I do not have the countrywide data, but some of the local data sometimes were able to give us a better insight. So I chose this study, which was published in Lancet, where in one of the districts of Madurai in the southern part of our country, if you looked at the positivity, the nearly 13.5 diagnostic tests were done per 100 population. So that's a fairly good proportion of diagnostic tests being done. You are not doing active surveillance. These were on symptomatics or their contacts or exposed. And among those, the positivity was about 3.6% at that time. And when you look at the positivity in the pediatric age group, below 9 years, it hovers between 1 point less than 1%, while between 10 to 14% was a little higher, about 1.7%. And among these, there were far more asymptomatic than symptomatic, because this is an initial data. A lot of tests were being done for the purpose of quarantine amongst those exposed. Now, once we are fully into the pandemic, that testing is largely focused on symptomatics and to the very close exposed cases to exposure to a confirmed case. The mortality which we saw at that time in that district was about 0.4 to 0.5%. If you compare that with United States or England, it's far higher. And subsequently, this is the data from a district. So it is a community-based data. Once you start looking at data from the hospitalized children, this figure goes up further. Children largely remain at low risk of mortality due to COVID. This is the another data from across the world, from USA, UK, Italy, Germany, Spain, France, and South Korea. Most of the time, the mortality due to COVID has been about less than 1% in 0 to 4 years, and about 1.3 to 1.9%, maximum of 3% in Spain. So that's the range you have of mortality due to COVID, and our country is also reporting something similar. So overall, we have seen much less severity than adults. If you look at the seroprevalence data, which is looking at antibodies, not an antigen test, where you pick up silent transmission within the community, the overall reported positivity amongst children is about 50% amongst those tested. So that means there is a lot of asymptomatic infection which is there in the community, which is providing the herd immunity, which may help us stall this epidemic till we have a better way, which is the vaccination available for children. A lot of vaccines are available in our country, but unfortunately, none for children. They are only approved for 18 years plus. We are still working out studies on between 12 to 18 years, and it's possible that we would have vaccination available for younger children too. Till then, most of the seropositivity is by natural infection. A more recent survey shows about 68% or 78% of our under 18 were seroconverted. So with this background, which shows an increasing seropositivity and a very small load on the clinical part by children, but what has been the disease pattern? As I said, this is a study which is a multicentric study on about 400 patients. Most patients were asymptomatic, 35%. The rest had mild disease. Moderate to severe disease was seen in about 10%. Large proportion of them, nearly 44%, had comorbidity. The average duration of stay in the hospital was 10 days, and most survived. We had a reported mortality of about 3%, most of which was with those who are having an underlying comorbidity, CNS disease, congenital cyanotic, rheumatic, or leukemia. In my own institution, we had tested about 3,000 children, and close to about 9% of them had a positive test. Out of these 255 patients, 100, that's about 40% of them required admission. Out of these, 60% had a comorbid. Most had undernourished. The comorbidities which were common were tuberculosis and hematological malignancy. We, in our institute, had a mortality of 11%. It was much higher in young infants and those above 10 years. We haven't been able to do a risk factor analysis so far. When it comes to symptomatology, how do our cases compare with others? If you look at data from across the countries, China, Indonesia, Japan, Malaysia, Pakistan, Singapore, there is no great difference of, this is in all the Asian countries, there is no great deal of difference between the proportions which are asymptomatic, which presented with fever, cough, coryza, or sore throat. We are seeing a quite similar picture here, and most children have mild to moderate disease, very few have severe disease. The risk of severe illness and death is increased in neonates, those who have a pre-existing medical conditions, fever, lower respiratory tract infection. In the new wave, second wave, we found that those who had vomiting and diarrhea were more likely to have severe illness, have either MIS-C or have death. Those who had radiological pneumonia or ARDS or required inotrodes when they came in were obviously having a more severe course. Those who were co-infected with other viruses, we did see co-infection with dengue, co-infection with influenza. They also ran a severe course. Those with comorbidities like hematological malignancy, nephrotic syndromes, or immunosuppression, severe malnutrition on one hand, and obesity on the other hand, two extremes of poor nutrition, and tuberculosis were found to have increased mortality. Quickly going to another manifestation of COVID, which is multi-system inflammatory syndrome in children. We have less than 0.1% burden. Usually, we have seen it below 5 years, and a little higher incidence in the older age compared to under 5 years. Mortality, which has been reported from our country, is to the tune of 20 to 30%. It's much higher than the Western country, which is less than 5%. The diagnostic criteria which we utilize for identifying MIS-C in our country is the diagnostic criteria given by WHO, which is about rash or bilateral non-purulent conjunctivitis, hypotension, features of myocardial dysfunction, coagulopathy, or with or without gastrointestinal problems, with elevated markers of inflammation like a greatly increased C-reactive protein, with no other obvious microbial cause for this inflammation, and an evidence of exposure or recent COVID-19 infection. I must say, add here that not more than 30 to 40% of our patients who were diagnosed or treated at MIS-C had evidence of recent infection. But because of the background pandemic, they were treated with either IVIG or steroids, which are the standard of care currently recommended. We also have seen those with, this is basically a hyperimmune phenomenon, and we have seen other immune dysregulation phenomena in the form of Kawasaki disease due to COVID in our city. So we have seen certain patients with Kawasaki also. We have seen patients with subsequently having coronary artery dilatation. There have been some centers which have also reported acute encephalitic-like illness. So these are some of the studies which I am presenting here. Since they were based on the WHO criteria, they obviously have a fair degree of presentations which is inclusive of mucocutaneous involvement, fever, abdominal and respiratory symptoms, because that's the diagnostic criteria we have been using. Most of these patients required intensive care, and deaths were about 20 to 30%. This has been the spectrum of multi-inflammatory syndrome, which we have seen in children in our setting. If we recognize it early and use early use of IV immunoglobulins, is something which helps. I've seen several patients with absolutely disproportionate tachycardia, PNP going haywire, CRP extremely high, ferritins levels in thousands. You give them IVIG and they settle down within 24 to 48 hours in most situations. Methylprednisolone has also been useful. Very few of us have used biologicals like tocilizumab, and because it's usually more often a distant infection which following which you have this hyperimmune phenomenon. And since there is no active replication of viruses, there is no role for any antiviral. All you use is these biologicals or steroids or IV. So when we had childhood illnesses, what did we do to prepare ourselves? So in our country, we have created a number of courses online and training sessions across the states till the peripheral level, till the community level, helping people to identify various severities, where to seek help, and trying to demystify this classification so that not everyone rushes to the hospital for care the moment you have a COVID positive report, because this is a disease because of its mortality and that only being highlighted in the media. People forget that it is mild in a large proportion. It doesn't kill everyone. It is a serious disease, but it is not serious for everyone who is positive. So everyone doesn't need to be admitted or has to rush to the hospital. And therefore, this is a good education which is required for the frontline workers to know whom to refer in early referral. And for that, they also have to know, they have to be equipped with the fact that they should, if somebody is at home, they should not stay at home when they get sick. They need to be monitored. So you could either use a pulse ox, which is a very good way to do it. But then even the availability of pulse oximeter, when we had a complete, second wave, was so difficult to find a pulse ox everywhere. So alternative 6-minute walk test in the house to identify if a child is likely to become hypoxemic because he's becoming he's breathless, maybe one way of dealing with it. Obviously, the most objective measure is a pulse ox, where possible. We also have very clear guidelines on what drugs to use, whether to use antiviral. No, actually, that's a complete no. Where to use antimicrobials, because there can be risk of a secondary infection, but very limited situations. Steroids, again, not for everyone. No early use unless you have hypoxemia. There are situations where one would need anticoagulants. And there is also something about, because now the difference between lay and literature and medical literature has become very hazy, because the general lay public is listening to a so-called press which highlights even the medical papers in the way they interpret. And as a result of which, everybody is familiar of what all is being done and the early recognition of a pneumonia by CT. But does that mean everyone needs a CT, or whether it is possible? So we have given those guidelines and guidelines. The government has created those tools to be used across the country for everyone to use. People have also looked at whether children, like in influenza, can have a longer viral schedule and be a bigger risk for transmission. These studies do not suggest that. One of the things which came up during this pandemic was that most children have mild disease, so they have to be managed at home or are asymptomatic, or are just have to be home because of pandemic. They may not have COVID, but they have to be at home because during the lockdown. And that led to a lot of mental health issues like anxiety, depression, irritability, boredom, sleep disturbances, excessive fear for all the negativity which the news around COVID was producing. And even the caregivers were very anxious and depressed. COVID also had an impact on other childhood illnesses. Access to care was impacted by lockdown, barriers of movement, conversion of hospitals into COVID-only facilities. Because of COVID appropriate behavior, much of our hospital beds were not available because we are overcrowded. We often have sharing of beds, which was not possible. Many clinics were shut down for chronic diseases because they were overwhelmed with the acute emergency which COVID brought up. At some times there were non-availability of diagnostic facilities, like many of the PCR machines for TB work were shifted to COVID. There were lack of blood products because blood donation drives could not be held. And lockdown also impacted repairs of maintenance of equipment and supply chains. And this had an impact again across the other parts of child care, like immunization, like antenatal care, cancer care, TB, diabetes, thalassemia, all were affected. And we have to find new solutions. Amongst the solutions which were found, one of the things which worked very well was teleconsultations, which spread out the follow-up care and helped us triaging, for which the regulatory authorities provided guidance and acceptance. Novel methods of hub-spoke models of transfer of patients were used, where not everything was centralized to a major hospital. The peripheral hospitals provided intermediate care. There was new networking between private and public sector, and community support organizations also played very important. As we go further, there are larger issues we need to look at, which will be the increased vulnerability of the marginalized households due to lack of economic activity, loss of wages, poor food security, and risk of child labor. While governments have taken steps by providing free provisions and sustenance money to the very poor, the impact has had a ripple effect beyond. And that's something we will have to see in future, how child health is going to be impacted by poor food security, poor income within the families. And that's a challenge which many vulnerable populations in our countries would have to face in future. So COVID, friends, has had an impact on child health, both directly and indirectly. When it is directly affecting you, it's a comorbidity which increases the risk of severe disease and death. Hyperimmune response in form of multi-systemic inflammatory syndrome can cause serious sickness and death, which requires prompt therapy and investigations. Large nations with very large populations need to make bigger efforts to train and prepare the health functionaries. And one has to worry about the ripple effect these pandemics have on the healthcare for other segments too, particularly of the psychosocial aspects and the learning issues of the children. These have been the learnings of COVID. I hope we are able to overcome this pandemic and go back to the life pre-COVID, the so-called normal. I hope we are not resetting a normal because of COVID in our lives. Thank you. Thank you so much for your patient listening.
Thank you, Professor Biden Singh, for the excellent talk. Actually, because time is limited, so let's move on to the next section. Thank you.
Okay. Thank you, the speaker, Professor Ranger Singh, moderator, Professor Xiu Yuzhen, and Ren Gongdai. Let's move on to the next lecture. If any question or any comment, please write down in the chat box and Sharon. Okay. Welcome the moderator, Professor Hongbin Huang. Professor Huang, please.
Yes, good afternoon, ladies and gentlemen. I am Professor C.B. Huang. It is with great pleasure that I chair with Mei Zizhen to introduce Professor Kina Harper, Division of Pulmonology Medicine, Boston Children's Hospital, to you. As an academic pediatric pulmonologist with 30 years of experience in clinical care and medical education, Professor Harper is most recognized for his clinical experience and mentoring program development in the subject of asthma. With the goal of setting a standard of care for pediatric asthma patients, among care providers, Professor Harper developed and directed an international asthma allergy and immunology postgraduate course for physicians from Brazil and Hong Kong. He's also the co-author for two respected books, the Harvard Medical School Guide to Taking Control of Your Asthma and the Asthma Education Handbook. In addition, Professor Howard is currently the editor for online clinical resources, including UpToDate and the Medscape, and also serves on the pulmonology editorial board for the AAP. Not only has Professor Harper's work improved the care of children with respiratory disease, he's also a trailblazer that helps shape the field of pediatric pulmonology medicine into the future. Most importantly, I hear that Professor Harper has a Taiwanese wife, which makes introducing him feel extra special and close to heart for me. Today, Professor Kina Harper is going to share with us with the topic asthma and COVID-19 in children. Professor Harper, please start.
Good afternoon. I'd like to thank the course directors for the opportunity to speak to you today about asthma and COVID-19. I work in the Division of Pulmonary Medicine at Boston Children's Hospital. Just wanted to share this view of downtown Boston, which is where Children's Hospital began. And then this is the Charles River, which separates Boston from Cambridge. These are my disclosures. So I wanted to talk to you about what's currently known about asthma and coronavirus, review asthma treatment recommendations during the pandemic, describe how to manage asthma exacerbations, and then consider some of the unanswered questions. So the CDC reports that people with moderate to severe or uncontrolled asthma are more likely to be hospitalized with COVID-19. There's at least a theoretical risk that infection with COVID-19 in a child with asthma may increase the risk of pneumonia or acute respiratory disease. But questions remain as to whether pre-existing asthma in children increases the risk of either infection, morbidity, or mortality due to COVID-19. So we knew prior to the pandemic that coronaviruses can cause upper and lower respiratory tract infections in adult and children of all ages. This is a particular concern when you think about current pandemic where there are 70 million individuals who've been infected. Now, fortunately, that number in children is fairly low, but it's still 1 to 5% of all cases. Prior to the pandemic, we've known that respiratory viruses, including coronaviruses, can be recovered from the respiratory tracts of children with asthma exacerbations, and that coronavirus infections have been associated with eosinophilic inflammation, which is one of the hallmarks.
Intensivist.
So multiple international organizations, including the CDC, list asthma as a prognostic factor for COVID-19 outcomes, such as morbidity and mortality. However, it's been noted that this classification is based more on common sense rather than evidence. A systematic review notes that there's scarcely any data on whether children with asthma constitute a risk factor for either infection or disease. And there's a theoretical risk that COVID-19 could trigger viral-induced asthma exacerbations. But to date, there's little data to support or refute this. So I think there's no question that the number of cases have been increasing. And this is taken from the COVIDnet, looking at the children less than 4 years of age. Those rates are increasing and increasing even more quickly than they are for those children ages 5 to 17. But overall, if you look at the cases by age group, this is shown here. This is a percentage of cases in red and the percentage of the US population in gray. You can see that in children, both the number of cases and the percentage of the population is low. But we need to be aware that it may be too early to assess what this impact is going to be of the Delta or other variants. Now, when thinking about those with asthma, we know that they're less likely to be admitted with COVID than other diseases or known conditions. And this is taken from the CDC. It's interesting here, the numbers are the percentage with asthma, lower than rates seen with other diseases. And the largest group is those with no known underlying conditions. And I think it's a very interesting group with chronic lung disease, other chronic lung diseases. Now, some of these may be from patients with CF who, during the same time of the pandemic, have been treated with CFT modulators that have been shown to decrease the frequency of exacerbations. So that may be one of the reasons why this number is low. So asthma appears to be underrepresented in the comorbidities reported compared with the prevalence in the general population. Systematic reviews have not shown an increased risk of severe COVID-19 in people with well-controlled, mild to moderate asthma. But at least in one study from the UK looking at mortality in people of all ages with asthma, that there was a higher risk for those treated with oral steroids who were recently hospitalized. However, there have been 2 meta-analyses looking at studies that were conducted worldwide that found no evidence of increased risk of diagnosis, hospitalization, or severity from COVID-19 in patients with asthma. Now, to give you an idea of what's happening locally, my colleagues have published this study of emergency department visits for patients with COVID. What they found is that there's a dramatic reduction, looking here before and once the shutdown with COVID, about an 80% reduction in emergency department visits. This number has stayed quite low. When we initially saw these numbers, we were thinking, well, maybe patients were just waiting longer before they came in. And when they came into the emergency room, they'd be sicker, more likely to be admitted. In fact, that was not the case. There was no change in the rates of admission looking at the prior years. Now, many countries have reported very similar reductions in asthma exacerbations. And interesting also, there have been reductions in visits for influenza as well as for otitis media. So I think at the beginning of the pandemic, early on, we were all concerned about the likelihood of an increase in asthma exacerbations. We knew that viral infections were a very common trigger for exacerbations and included COVID in that group. Perhaps once the children were staying home from school, they're going to be exposed to more secondhand smoke, which we know also could induce exacerbations. So the same thing with allergic exposure in the homes. Certainly increased stress, which has been linked to asthma exacerbations. This is experienced by lots of children as they're isolated from their friends and not going to school, participating in other activities. So perhaps there was a risk of decreased adherence to medications without the structure of school, with regular waking up or going to sleep times and regular times to administer these medications. And then we thought, at least for the older children, there's this risk for increased tobacco use, vaping, and water pipe use. In fact, what happened is really this significant decrease. And it's unclear whether this is due to social distancing, a decrease in participation in group activities such as organized sports. Maybe overall there are fewer infections, staying away from daycare, school, and work when they're ill. Certainly we've seen in the local daycares much more vigilant about screening for fever when children come. Increased adherence with home monitoring. And finally, the decreased exposure to traffic and industrial pollution, which we know also can trigger asthma exacerbations. And when thinking specifically, well, what about the emergency room itself? There has been some avoidance of medical facilities with the concern by parents that they bring them to the emergency room, their children would be exposed to more other children with COVID. Perhaps they have a higher threshold for coming to the emergency room in an effort to try to avoid it. And then finally, higher tolerance for risk during the pandemic. Maybe they're more aggressive about managing things at home. Again, if we thought that we're getting sicker, we had anticipated we'd see this uptick in hospitalizations, which we're not seeing. So preliminary evidence suggests that these rates for these children with asthma are lower. It raises the question about why. So one possible mechanism is this observation that allergic conditions, that persons with allergic conditions, including asthma, have preliminary evidence suggests that having an allergic condition paradoxically may reduce a person's susceptibility to SARS-CoV-2 infection and severe disease. It's been noted is that both children and adults with allergies and asthma have reduced angiotensin converting enzyme 2, or ACE2. And that ACE2 is an enzyme that's also a functional receptor on cell surfaces through which SARS-CoV-2 enters the host cells, and it's highly expressed in the airways and shed into the plasma. So there's now an NIH-funded epidemiology study, which is the Human Epidemiology in Response to SARS-CoV-2, or HERO study, which has begun to evaluate ACE2 levels and rates of SARS-CoV-2 infection. They plan to enroll 6,000 people, including children with and without asthma, determine what percentage of infected children develop symptoms of the disease, and examine whether rates of SARS-CoV-2 infection differs between children with asthma and other allergic conditions compared to children who do not. So what about treatment during the pandemic? Recommendations from the CDC, from the Global Initiative for Asthma, from the North American Consensus Guideline on Allergy during COVID, the treatment should be the same. Continue current asthma medications during the pandemic. When you have the opportunity to interact with patients, try to reinforce the importance of consistent use of long-term control medications and proper use, proper administration. Don't step down the controller medication unless it's clearly favorable from an individual standpoint, with careful consideration of the balance between benefit and harm or burden. Now, what about steroids? Well, theoretically, the use of steroids may increase SARS-CoV-2 replication, which could lead to exacerbation of symptoms, prolonged viral shedding. This was observed in the Middle East respiratory syndrome coronavirus, as well as an increased risk for nosocomial transmission and secondary infection. However, the current data suggests that both inhaled steroids and oral steroids, when indicated for the treatment of exacerbations, are safe to use. What about the biologics? Currently, there's no evidence that the use of asthma biologics increase the risk of COVID-19 infection or morbidity. And in fact, a recent study has shown that biologic therapy targeting type 2 inflammation may actually be associated with a protective effect on the clinical course of COVID-19. And during this time, we've been continuing to administer the biologics to patients, and we've also initiated other patients during the pandemic. Now, thinking about exacerbations. So if those patients have high severity of asthma, high risk of COVID, you're probably going to schedule them to be seen face-to-face and would include COVID testing. If the COVID risk is low, you still may want to see them face-to-face to do an evaluation to determine if they need an escalation of care. If the asthma severity is low, but the COVID risk is high, you're going to go ahead with a COVID test, but then schedule them for a telehealth visit. And then if the risk of COVID and asthma are low, going to think maybe just a telehealth visit. So at the beginning of the pandemic, this is relatively new for us. We had very few patients who were receiving telehealth prior, but then very rapidly, the state and federal regulators moved to reduce the barriers to telehealth. And also there were a large number of my colleagues who were working from home and still able to care for patients. And the Centers for Medicare and Medicaid Services, or CMS, expanded the coverage, including increasing the types of providers able to use telehealth, allowing providers more freedom to use different modalities. The number of sites could also, the variety of sites, including homes, federally qualified health centers and rural clinics could start using these modalities. We could even use phone-based services when patients didn't have access to video, and at least open the opportunity for some remote patient monitoring. So surveys have shown that of more than 1,300 physicians, that 90% were using at least some form of telehealth, and that a full 60% were planning to continue that practice after the pandemic. The global compounded annual growth rate is between 13 and 27%. And valuation is expected to be growing to over $20 billion in the next several years, and the telemedicine market is set to be valued at $175 billion by 2026. This is from Global Market Insights. So what have we learned about telehealth? Well, as a first point of contact, you can actually assess patient needs and decide on a course of action, which may actually end up reducing some of the expenses when you're just seeing patients in clinic for the first time and making decisions on the spot. And it may in fact lead to some improvement of quality of care, but that clearly needs to be assessed. It has been helpful for managing patients with chronic needs without them needing to travel to clinic or to the hospital. But we also learned that patients and providers needed training to make this effective. And I think, like many of my colleagues, I don't think this is going to replace in-person visits, but it can be a very effective bridge between those visits, particularly for the patients who have to travel great distance, where requires a lot of services to even allow them to come to those clinic visits. So now the unanswered questions. Well, now that we've seen this decrease in exacerbations, is this going to change now that there are new mutations, including the Delta, maybe other mutations in the future? I think really trying to understand what led to the reduction of asthma exacerbations, and of those things, what are we willing to continue into the future to help keep our patients' asthma under good control? Do any of the asthma treatments provide some type of protective effect? And the hope is that despite all the morbidity and mortality we've seen during the pandemic, that's maybe something useful or positive can come from the pandemic. And I'm quoting Dr. Wang from his letter to the editor, which is, misfortune might be a blessing in disguise. So in conclusion, ED visits for treatment of asthma exacerbations has been remarkably reduced during the pandemic. Note that we don't understand all the factors that have impacted this. At least for our patients, that's been a remarkable observation. Current recommendations are not to change asthma therapy if patients are well controlled. Oral steroids are recommended when indicated for treatment of asthma exacerbations. Telehealth has certainly given us the opportunity to remain connected with our patients and is likely to remain an option in the future. And I think we have to all stay alert because all of these may change as we acquire new information. So thank you very much for your attention, and I'd be happy to be available if there are any questions or comments.
Thank you. Thank you, Dr. Heather. It's so nice to hear your excellent talk. It's really very impressive. So, Dr. Heather, would you like to say something to our audience? Say hello.
Hello, and thank you very much for the opportunity to be part of this program. Very interesting to hear about everyone's experience with this. I mean, we're in uncharted territory. And now we're seeing what we've heard earlier in the day about new Delta variant, and really so many questions still out there about what's going to happen now with the mu variant that's been identified. So at this point, we're just hoping that we can keep things well contained, and hopefully as we get new information from everyone around the world about how best to manage things.
Thank you. I see, because time is limited, but let's do a quick QA. Dr. Daniel has a question. What is the practice of empirical antibiotics in children with mild COVID who deteriorated with increased tachypnea? Do you give us a quick answer?
So we've not been using empiric antibiotics. I mean,
Yes.
I think my talk was really more focused on asthma, but we've not been using a lot of antibiotics for these children, at least empirically. And for those who have been admitted, unfortunately, those numbers have been quite low, but we have not at this point.
Therefore, that's usually not necessary to use empiric antibiotics for the mild COVID or even with asthma, right? Thank you, Dr. Heather. I know it's a difficult time for you, it's sleeping time, but thank you again, sincerely, to join us and give us such a wonderful talk. Thank you.
Well,
Thank you.
very nice to see you
Bye-bye.
and to see so many colleagues from around the world. Thank you.
Yeah, in the near future. Okay, so this session
Thank you.
has to be closed now. Thank you. Bye-bye.
Thank you.
Thank you.
Thank you. Thank you, the speaker, Kenan. Welcome to Taiwan. Thank you, the moderator, Professor Huang and Professor Zheng. Let's proceed the following lecture. Welcome the moderator, President of Kaohsiung City Medical Association, Professor Chong Hong Lai. Professor Lai, please.
Next is Dr. Savikang Rao is a pediatric intensivist at the Faculty of Medicine, Siraja Hospital, Mahito University, Thailand. He graduated MD from Faculty of Medicine, Siraja Hospital, Mahito University in 2007. He had a general pediatric training at Siraja Hospital in 2010 to 2013. He underwent pediatric intensive care training at the Royal Children's Hospital, Melbourne in 2015 to 2018. His area of research interested is PICU procedures. Today, he will give us a topic, severe pediatric COVID-19, 3 ways. Welcome, Dr. Do.
Good afternoon. In this session, I'm going to present 3 cases and highlight some of the interesting points from these cases. We'll start with case 1. We have a 17-year-old girl with lupus nephritis. She's on prednisolone. She had 4 days of fever and 2 days of dyspnea. Her COVID-19 PCR was positive. Ambulance was sent to retrieve the patient from her house. Her saturation was 88 to 90% in room air, so she was put on non-rebreathing mask during transport. On admission, she had no fever, her heart rate was 90, blood pressure is slightly high, respiratory rate was 34. Her saturation was only 90 to 92% while she was on non-rebreathing mask. She had mild to moderate subcostal retraction. This is her X-ray. So she has severe COVID pneumonia, but it doesn't seem bad enough to intubate. So we thought about doing awake prone positioning for her. So in ARDS, when we do prone positioning, what happens is gas entry into collapsed dorsal alveoli improves, and it decreases hyperinflation of ventral alveoli. Overall, it makes lungs more homogeneous and improves VQ matching. So awake prone positioning in COVID, we probably can do it in patients who can cooperate. Adult studies perform awake prone positioning when saturation is less than 93 while receiving at least 5 liters of oxygen, or when PF ratio is less than 300. This study done in New York emergency department shows that awake prone positioning improves saturation. Median saturation of 84 improves to 94 5 minutes after proning. However, 24% of patients in this study required intubation within 24 hours. This study performed in Spain and Andorra. This is an observational study which compared prone versus non-prone in patients on high-flow nasal cannula. It shows that awake prone positioning did not improve intubation rate or 28-day mortality. And there's a trend toward delayed intubation in prone group. So if we are to do awake prone positioning, there are a few cautions here. If intubation is the most appropriate action, then we should not wait or try non-invasive modality. If high FiO2 is needed, this is a dangerous sign that the patient reserve is minimal now. Along the way, we should assess patient fragility. For example, when changing to supine position, see how saturation fluctuates. And please don't wait until it becomes physiologically difficult intubation. This happens when intubation is delayed for too long. And then now we have very unstable patient with low saturation. And during intubation, there is a high risk of severe hypoxemia or even cardiac arrest. This is the situation that we should avoid if possible. So back to case 1, she was put on high flow with FiO2 of 60%. She was given antiviral and dexamethasone. We put her on prone positioning, alternating with semi-prone. Her saturation improved to 95 within 1 hour. And after that, she had slow improvement. We could stop doing prone positioning for her on day 3. And on day 6, we could reduce FiO2 to 40%. On day 16, she was weaned to low flow, 3 liters. And currently, she's still in hospital, and she's on low flow nasal cannula. This is her X-ray on day 14, which looks better than previous X-ray. So now we are going to case 2, which is a 7-year-old boy with Prader-Willi syndrome, morbid obesity, DM, and OSA. He's on night CPAP, 11 centimeters of water. He had fever for 1 day without respiratory symptom. His COVID test was positive and he was admitted. His temperature initially was 37.9, heart rate was 108, respiratory rate of 30, blood pressure was normal, saturation was 92 in room air. His body weight was 87 kilo. His height was 135 centimeters. He had no chest retraction then. This is his first day X-ray. He was stable initially and was on low flow 2 liters in the daytime and was on his night CPAP as usual. He was given antiviral and dexamethasone. On day 2, he required CPAP both day and night, but otherwise was still doing okay. On day 6, he started to get worse with more opacity in the chest X-ray, and he required CPAP of 12 centimeters of water with oxygen 8 liters per minute. On day 9, he got even worse, and we decided to intubate. And this is X-ray after intubation. So with severe COVID pneumonia, so now let's talk about adult COVID pneumonia phenotypes, originally proposed by Gattinoni. Type L here, L stands for low elastance, which is good compliance, low VQ ratio, low lung weight, and low lung recruitability. So this type is not like typical ARDS. So the usual ARDS treatment is probably not suitable for this type. The other type is type H. H here means high elastance, which is poor compliance, high right to left shunt, high lung weight, high lung recruitability. This type is similar to typical severe ARDS. So usual ARDS treatment should be okay for this type. Here's an example of CT for type L and type H. You can see that type L, there's not much collapse consolidation. There's really nothing to recruit there. In type H, this looks like severe ARDS with large areas of collapse and potential to recruit. However, in type L, there is hypoxemia, which must be caused by VQ mismatch. But then what causes VQ mismatch? It's probably pulmonary vasoplegia or pulmonary vascular endotheliolitis or microthrombosis. And what we can do with type L is probably to allow higher FiO2, higher tidal volume, and not to use too high PEEP. Awake prone positioning may help in some patients. On the other hand, there's this paper showing that in COVID ARDS, on average, compliance seems low, kind of just like usual ARDS in general. Then what about pediatric COVID ARDS? Unfortunately, there's no data about lung compliance or phenotype in pediatric COVID ARDS. However, in reality, ARDS is a heterogeneous syndrome. There are spectrums of pathophysiologic changes in ARDS. There are different degrees of alveolar edema or collapse causing shunt, different degrees of recruitability. There can be vasoplegia of poorly ventilated alveoli, which causes shunt. Dead space can increase as well due to pulmonary vasoconstriction or microthrombosis. And pulmonary vascular resistance can go up and cause pulmonary hypertension or right heart failure. So in COVID ARDS ventilation, there's probably no single best ventilation strategy for all. We have to assess lung compliance. In children, we probably can look at delta P needed to obtain target tidal volume and have a rough idea about compliance. So if the compliance is low, then we use lower tidal volume, like 3 to 6 mils per kilo. If compliance is good, then we can allow higher tidal volume, probably 5 to 8 mils per kilo. What we can do also is to just slowly titrate up the PEEP and wait and see how the patient responds. Is oxygenation improve, or can we reduce FiO2? This is probably the most common thing to do in ARDS, is slow incremental PEEP titration, and this works in most cases, actually. The newer method called recruitment to inflation ratio probably can assess the degree of recruitability as well. I do recommend this paper by Lu Chen, cited here, and the website here for more details about recruitment to inflation ratio. We probably can do CT to compare lung recruitment on different PEEP, but this needs transport and infection control measures. Electrical impedance tomography can be used to find the right balance between recruitment and hyperinflation. ARDS network PEEP FiO2 table is probably okay to use in type H disease. Overall, COVID ARDS and ARDS in general requires some degree of individualization. And we have to assess patient response to ventilator changes and maneuver. So back to the case, we set up initial ventilator setting at PIP of 30, PEEP of 10, FiO2 of 80%. This, we have tidal volume of 5.3 mils per kilo of ideal body weight with saturation of 92. Blood gas looks not bad. Here, we're using high FiO2 relative to PEEP, and he looks like typical ARDS or type H. He's obese as well, and we know that he has poor chest wall compliance. So actually high PEEP requirement is expected. So we increase PEEP to 14 and PIP to 32, which is allowed for patients with poor chest wall compliance. And within 1 hour, FiO2 decreased to 40%. He slowly improved after that. He was extubated on day 18 and discharged on day 28. Now we move on to case 3. Here we have 12-year-old boy with asymptomatic COVID infection 1 month ago that did not require treatment. He had fever and myalgia for 5 days. At another hospital, he had fever and he had hypotension. He was given normal saline bolus, and that improves his blood pressure transiently, and then it dropped again. So he was started on epinephrine and norepinephrine and transferred here. He had red eyes, strawberry tongue, and skin rash as shown here. His first EKG showed first-degree AV block. On echo, he had LV dysfunction with EF of 45. His laboratory results showed elevated cardiac enzyme, low platelets, and increased inflammatory markers. So in summary, he had recent COVID-19 infection with fever with 3 organ system involvement, which are myocarditis, mucocutaneous, and hematologic involvement. And there's evidence of inflammation. So this fits with multisystem inflammatory syndrome in children, or MIS-C. He was treated with IVIG and methylprednisolone. In the afternoon, this is his EKG. Initially, it looks like sinus rhythm, but if you look at the later part of this EKG, you see that in the at red arrow here shows that PR interval seems to be shortened in the later part of the strip. This actually happens because his QRS comes earlier. So actually, this is accelerated junctional rhythm. And you can see that in the last beat here, P wave is behind QRS complex. So here it means that QRS comes earlier than P wave. So he has accelerated junctional rhythm. And the next day, EKG was even more interesting here. So now we have what seems like irregular rhythm and different QRS morphology here. So let's identify first that we have 2 types of QRS complex. We have Y QRS complex labeled with W here. And then to try to determine the rhythm, we have to look for P wave. And here are P waves labeled with P there. You can see that in the first part of the EKG here, P wave and QRS are dissociated. So this is AV dissociation, and we have Y QRS complex, which is likely originated from ventricle itself. So at this part, this is actually ideal ventricular rhythm. And then the next 3 beats here, there are narrow complex, and this is narrow complex preceded by P wave here. So these 3 beats are sinus rhythm labeled with S. This narrow QRS here does not have preceding P wave. It comes by itself. So this is actually a junctional rhythm. So I'll label this with J. These 2 are sinus rhythm because we have preceding P waves there. This particular QRS seems strange. It's not very wide, but not narrow either. This is likely what is called fusion beat, which is QRS that originates from ventricle, which causes Y complex. And it happens at the same time with the QRS that originates from the AV node, which should have narrow complex. So its morphology is somewhere in between the narrow and the wide QRS complex. So I'll label with F here for fusion beat. So overall, this EKG is accelerated ideoventricular rhythm alternating with sinus rhythm and junctional beat. There are various types of arrhythmia in MIS-C. Bradyarrhythmias like sinus bradycardia, junctional rhythm, atrial bradycardia, AV block. There are tachyarrhythmias like atrial tachycardia and ventricular tachycardia, but luckily these rarely require ECMO. There can be just EKG change without arrhythmia as well, as shown here. So incidence in MIS-C, the abnormal EKG is quite common, up to 35%. Arrhythmia is less common, like 12 to 21%. Bradyarrhythmia is more common than tachyarrhythmia. However, most did not require antiarrhythmic medication. But some required inotrope or vasopressor due to cardiogenic shock or vasodilatory shock as a manifestation in MIS-C. So back to case 3, we started Mirinone because it is less arrhythmogenic, and we continued for 5 days. We weaned off epinephrine and norepinephrine. We treated with diuretic, and on day 3, arrhythmia resolved. On day 6, echo showed normal ejection fraction of 62. He was discharged from hospital on day 12. In summary, in severe COVID pneumonia, awake prone positioning could be an option to improve oxygenation in cooperative children. But please do avoid physiologically difficult intubation if possible. For COVID ARDS, ventilator setting needs to be individualized based on physiology and patient response. In MIS-C, both cardiogenic shock and vasodilatory shock can occur. Arrhythmia is not uncommon, but is rarely severe, and bradyarrhythmia is more common than tachyarrhythmia. Thank you for your attention. I'm happy to take.
Okay, the moderator, Professor Xia. Moderator,
Okay.
Professor Xia.
Thank you,
Okay,
Dr.
thank
Law.
you.
Thank you for your awesome lecture. And we have one question here. When you intubate patients, do you let them breathe themselves or just paralyze them? Thank you.
Yes, usually you can see that when we have COVID-19 patients, they're in negative pressure room, and we avoid going in and out frequently for these type of patients. So practically, we do rapid sequence intubation with paralysis for all, and usually if they are still having severe ARDS, we keep them paralyzed for quite some time, really, for practical logistical reasons more than medical reasons, really.
Thank you, Dr. Law. Because the
Moderator Xia. Professor Xia.
because the time is running late, so we have to close this session. Dr. Law is very happy to answer questions in the chat part. Okay, we are moving to the next session. Thank you. Thank you, everybody.
Okay, thank you. Thank you, Dr. Low. Thank you for your cooperation to answer questions in the chat. Moderator Professor Lai and Professor Xia. Let's take a break. We'll come back, I think, 3 minutes later. So have fun, enjoy. Back on PM 4:10. So don't forget, remember back. Thank you. 4:10. Thank you.
a demonstration to teach you how to enter to room B. Please click participant. We can see the breakout section, room B. Then click join room B. Congratulations, you finished. So in conclusion, first one, the participant, and second one, breakout section. The third one, join room B. Then how to back to main meeting? Please click the red button. Nearby the stop and close the video button. So just click the red button. We can see the one of the options. Choose back to main meeting. In conclusion, click red button, back to main meeting. So we finish. Thank you.
In a world that is perpetually changing, there is increasing need for steady leadership. Companies demonstrating the courage to address the world's emerging healthcare challenges with passion and compassion. Viatris is redefining the healthcare landscape. We are uniquely positioned to be a source of stability with the commitment, capability, and vision to meet the world's evolving patient needs. Viatris believes in healthcare not as it is, but as it should be. We know the way to provide access to a sustainable, affordable, and diverse portfolio of high-quality medicines, regardless of a patient's geography or circumstance. We are leading the way by providing a versatile, scalable platform that combines best-in-class manufacturing and supply capabilities with innovative solutions that span therapeutic areas. And as a partner of choice, we are pioneering a way to empower companies of any size to leverage our distinctive global healthcare gateway, so products from across the industry and around the world can rapidly and effectively reach patients where they live. We do so with a collective spirit of resilience, driving forward until each challenge is addressed and every opportunity embraced. We are inspired by this moment of shared purpose, because as Viatris, we know the way to empower people worldwide to live healthier at every stage of life.
Okay, welcome back. Hi, dear friends and audience. Welcome back. Let's start the satellite symposium about pulmonary hypertension in children. Let's welcome Mr. Jim Lin. Professor Wu, please. Thank you.
Good afternoon, everyone. It's my honor and pleasure to host this satellite symposium with other. The first speaker will be my best friend, Professor Ren Gong Dai. Professor Ren Gong Dai now is the Professor of Pediatric Pharmacology and Respiratory Therapies of Medical University. He also is the president of the TPPCC 2021. He is not only a pediatric pulmonologist, but also a pediatric cardiologist. Today, he will give us the talk, Pediatric pulmonary hypertension associated with the congenital heart disease. Professor Dai, please start.
Ladies and gentlemen, it's my honor to be invited to give the talk, Pediatric Pulmonary Hypertension Associated with Congenital Heart Disease. The definition is mean pulmonary artery pressure more than 20 millimeter mercurial, normal pulmonary capillary wedge pressure less than 15 millimeter mercurial, and increased pulmonary vascular resistance more than 3 units meter square. The so-called endothelial dysfunction is an imbalance between vessel constriction and vessel dilatation. and between growth factors and growth inhibitor, result in pulmonary arterial remodeling and increased pulmonary muscular tone, which is closely related to vessel constriction, inflammation, vascular remodeling, insidial thrombosis, dysfunction of underlying cellular pathway, and the imbalanced vessel active mediator. There are 10 basic categories of the pediatric pulmonary hypertension vascular disease. Pediatric heart disease is included. An updated clinical classification in mid 2018, pulmonary hypertension associated with congenital heart disease is included in Group 1. The distribution of the pediatric pulmonary hypertension associated congenital heart disease. Group 1, 24%, Group 2, 14%, Group 3, 19%, Group 4, 30%, Group 5, 2%. The patient with either idiopathic pulmonary hypertension or secondary pulmonary hypertension will develop progressive increase in pulmonary vascular resistance, then right heart failure subsequently lead to death. In 100 patients listed for transplantation, actual survival of patients who did not receive transplant was in different groups, as Menger syndrome, idiopathic pulmonary hypertension. At 1 year, 2 years, and 3 years, you can find the survival for Menger syndrome is related to congenital heart disease is better than idiopathic pulmonary hypertension. Among different group of the pulmonary hypertension, the worst group is HIV infection, and the best survival also congenital heart disease. In children with pulmonary hypertension, congenital heart disease in 40 to 50% and heterogeneously. Idiopathic pulmonary hypertension and hereditary pulmonary hypertension is the remainder. Advances in pediatric cardiology and surgery have led to many more congenital heart disease patients surviving to adulthood. A wider spectrum of the defects are associated with pulmonary hypertension associated congenital heart disease, leading to severe functional impairment affecting both survival and quality of life. The demographics of the congenital heart disease patients are changing. In 1985 and 2000 years, in age below or 12, the two in different year is similar, but from the 1985 to 2000, the prevalence is increasing. Totally, there are 4 clinical classification of the pulmonary hypertension with congenital heart disease. As Menger syndrome, left to right shunt, pulmonary hypertension with coincidental congenital heart disease, post-operative pulmonary. Case 1, 72 years old male, ventricular septal defect with Menger syndrome. You can find cardiomegaly with increased pulmonary muscularity. In the scintigraphy, you can find the non-specific defect. In pathology of the autopsy, you can find endothelial proliferation and medial hypertrophy and small vessel in the adventure. Case 2, 35 years old male, atrial septal defect type 2 with Menger syndrome. While 21 years, you can find a slightly cardiomegaly. Then this is the 35 years old, you can find the markedly cardiomegaly and with increased pulmonary vascularity. Recently, there are many authors emphasize there are metabolic remodeling in right ventricle with pulmonary hypertension. Therefore, there is increased uptake of FDG in a PET of hypertrophy right ventricle in a 54 years old female pulmonary arterial hypertension. You can find this is the uptake of the right ventricle compared with the left ventricle. So is emphasized to be related to metabolic syndrome, mitochondrial dysfunction, pseudo-hypoxia environment, which is adequate therapy for pulmonary hypertension. Is vasodilator therapy, therapy for heart failure, therapy for diastolic dysfunction. Pulmonary hypertension is associated with increased morbidity and mortality in congenital heart disease. There is development of the pulmonary hypertension in adults with congenital disease is associated with more than twofold higher risk of the mortality and threefold higher rate of the morbidity complications. The goal for pulmonary hypertension associated congenital heart disease, Group 1 provides pulmonary vasodilator therapy, except in patients with venous occlusion or pulmonary capillary hemangiomatosis. Group 2 treated the heart disease. Group 3 treated the lung disease. Group 4 treated thrombo embolectomy or the anticoagulation. Group 5 managed the underlying systemic disease, then support the right ventricle and avoid the congenital heart failure. The strategy of the management of the congenital heart disease with pulmonary hypertension. Conventional or the supportive therapies, including digoxin, diuretics, anticoagulation, and antiarrhythmic. But none was shown to increase survival. Targeted therapy, the aim is to improve exercise tolerance, hypoxemia, physical capacity, and ultimately survival. As a medicine, patients are unlikely to experience a significant decrease of the pulmonary vascular diseases. Prostaglandin and the serine receptor antagonist enos, nitrous oxide cyclase GMP axis approval and investigation targeted receptor stimulation would blockade. Bisantan, bonsantan, marcipantan, epostanolol, treprostinil, celestipag, sildenafil, tadalafil, Rioshiclate, iloprost. Targeted therapy for adult and pediatric pulmonary hypertension. Intravenous epoprostanolol in adult is 1A, pediatric is 1B. Bonsantan adult is 1A, pediatric is 1B. Sildenafil is 1A, and the pediatric is 1B. They are the determinant of the risk for pulmonary hypertension. Clinical evidence of the right ventricular failure, progression of syndrome, syncope, gross WHO functional class, BNP, NT-probe, BNP, echocardiography in the hemodynamics. How to determine defect, collectability in the presence of the pulmonary hypertension. While less than 4 Wood units or pulmonary vascular disease less than 2.3 is collectability. 4 to 8 Wood unit or the 2.3 to 4.6 is individual patient's evaluation in tertiary center. This is a treatment algorithm. Initially, can give with anticoagulation, diuretics, oxygen, and digoxin. Then arrange acute vasoreactive testing. Positive oral calcium channel blockade. inactive in different risk is low risk and higher risk group. In low risk group can give with ERA phosphodiesterase 5 inhibitor, epoprostenol and treprostinil, iloprost and treprostinil. Then we assess, consider combination therapy, then investigational protocol. In higher risk, can give with the epoprostenol or treprostinil, iloprost, ERA phosphodiesterase inhibitor. The treprostinil. Last step is atrial septostomy, then do the lung transplantation. The comparison survival rate of the clinical subgroup of the pulmonary arterial hypertension associated congenital heart disease is enzymatic syndrome, is a systemic to pulmonary shunt, is a collective defect, and a small defect. You can find enzymatic syndrome is the best survival. Pulmonary hypertension specific therapy has been shown to reduce mortality in enzymatic syndrome in Bonsantin groups in the 7, 3.5, in the sildenafil 25, epoprostenol 1.5. In breast-fied protocol, Bonsantin therapy reduced pulmonary vascular resistance and increased 6-minute walk testing in enzymatic syndrome. This is alternative protocol, treat and repair the strategy. This is an example case. Adverse was diagnosed as ventricular septal defect at 49 years old age, treated with sildenafil and Bonsantin. 3 months later, added the epoprostenol and the titration of the dose. 1 year later, the patient received the ventricular septal defect repair. 22 months later, his mean pulmonary pressure is 42 millimeter mercury, and the pulmonary vascular resistance index is 11 Wood unit. Then give with Bonsantin and epoprostenol. Reverse porous shunt. By interventional strategy, with surgery with a transcatheter, you can find some cases good long-term responder, but also is a higher early mortality, need to better define the indication and the contraindication. The last step, we also can arrange lung transplantation, atrial septostomy, but it is difficult to find the donor and the related effect is not satisfied. Recently, there are also several novel therapy, metabolic pathway, nuclear activator, activator T cell, tyrosine kinase inhibitor, statin, 5-HT2B receptor antagonist, EPC, and SGC activator is a real SHIG8. You can find the fascidural and simvastatin and dichloroacetate and another patient. This is a Celeste Peg. Thank you for your attention.
Thanks, Professor, for wonderful speech. The discussion will be left after 4 sections. I will transfer the moderator, Professor Peter Huang, please.
Okay, thank you, the moderator, Professor Wu. Let's proceed the next. Welcome, the moderator, Professor Peter Huang. Professor Huang, please.
Good afternoon, my dear colleagues, ladies and gentlemen. Welcome to join the Symposium on Pediatric Pulmonary Hemorrhage, Symposium on Pulmonary Hypertension. It is my great honor and pleasure to introduce the next speaker, Dr. Jin-Wei Lu. Dr. Lu is an experienced young pediatric cardiologist in Taiwan. He was graduate from the National Taiwan University. After medical education at the Taiwan University, he postdoc training at the Laboratory of Molecular Cardiology, College of Medicine, Houston, Texas, United States, from 2002 and 2003. Currently, Dr. Lu is the assistant professor of the Department of Pediatrics, National Taiwan University, and also he is the director of the Department of Pediatrics, Hsinchu branch of National Taiwan University. His most experience on adult congenital heart disease, especially the gauge with a complete congenital heart disease with pulmonary hypertension. So today, he is one of the best speakers for the congenital disease with pulmonary hypertension. So Dr. Lu, please start your talk.
Thank you, Chairman. Today, my topic is about pulmonary hypertension in CSD after Fontaine operation. The multi-stage Fontaine surgery, introduced about 45 years ago, is a tremendous progress in the treatment of patients with single ventricle. The first stage operation, such as Norwood procedure, can keep the pulmonary vascular bed away from injury due to high pressure and high flow, at the same time to enhance the growth of pulmonary arteries. The stage 2 bidirectional shunt can relieve the ventricular volume load by directing the flow of SVC into pulmonary artery. The final stage of operation connecting the IVC and the PA can separate two circulations and relieve cyanosis. The benefit from Fontaine circulation is to restore normal systemic arterial oxygenation, and it can also relieve valve overload from single ventricle. But the cause is it can cause lower cardiac output and the passive non-pulsatile venous flow to the lung without ventricular pumping can cause systemic venous hypertension and pulmonary artery hypotension. The pulmonary circulation in Fontaine acts as a dam between systemic vein and the ventricle. It can cause upstream congestion and downstream decreased cardiac output, and therefore cause the cardiac and atriocardiac complications in Fontaine patient. The pulmonary vascular resistance is the primary modulator of cardiac output. When PVR increases a little, the cardiac output drops dramatically because of insufficient ventricular filling, no matter how good the ventricular performance in Fontaine patients. Because many clinical trials using the result of exercise test as an endpoint, we will introduce the exercise performance in normal subject and the Fontaine circulation. As exercise in normal subjects, the cardiac output can increase 3 to 5-fold due to greater preload, increased heart rate, increased myocardial contractility, and the reduced afterload. Because in Fontaine patient, there is no RV to provide this work demand, so the LV filling and the cardiac output are unable to increase normally. Even the Fontaine patient with very good ventricular performance, the exercise level is about 50% of normal subjects. And another important phenomenon in Fontaine circulation is the PVR can change with age. When the Fontaine patient becomes aging, the PVR will increase. It can cause even higher systemic venous pressure and lower cardiac output. And through the pathological study from the Fontaine patient, study with the autopsy from soon after Fontaine patient and group B patient with long-term die after Fontaine operation. And they also collecting the age-matched control. They found that in patient died soon after Fontaine operation, their pulmonary vascular bed revealed medial muscular hypertrophy. However, in patients died long after Fontaine operation, they found the pathology of pulmonary arteries revealed eccentric acellular intimal fibrosis with thrombosis and decreased vascular smooth muscle cells. And we can see that compared to age-matched control, the intimal layer thickness is increased with age. That is different from the pathology observed in idiopathic pulmonary arterial hypertension or PAH after left to right shunts. These two kind of patient had medial layer thickening, but in long-term Fontaine patient, they found the thickening layer is intimal layer. What caused the PVR in Fontaine circulation increase over time? The first reason occurred before the Fontaine completion, because there is possible excessive pre-Fontaine pulmonary flow or pulmonary artery hypoplasia, distortion, and the stenosis of pulmonary arteries before Fontaine completion. Those can also cause increased PVR. And because there is no positive systemic venous flow direct to the pulmonary arteries, there are many clinical undetectable microemboli can cause increased PVR. And the main reason with PVR increase over time in Fontaine patient is the lack of positive flow in Fontaine pathway. It can cause pulmonary artery endothelial dysfunction, such as impaired shear stress medial release of many endothelial vessel-active molecules, such as NO, and the increased apoptosis of vascular smooth muscle cells can impair the pulmonary artery vasodilatation. And the chronic hypoxemia in Fontaine patient can cause hypoxia-induced factor targeting gene encoding for pulmonary artery hypertension, such as endothelin and vascular endothelial growth factors. And because the pulmonary artery pressure in Fontaine patient is rarely above the 20 millimeter mercury, that's the definition of the pulmonary artery hypertension. There is in need of another definition of pulmonary hypertension in Fontaine patients. The European Pediatric Pulmonary Vascular Disease Network defined a new definition for elevated PVR for Fontaine circulation. They define PVR index above 3 or transpulmonary gradient above 6 millimeter mercury as pulmonary hypertensive vascular disease in Fontaine. However, the measurement of PVR in Fontaine patient is often difficult and sometimes misleading because there are many patients of spontaneous circulation with sustained venous to pulmonary venous collaterals or fenestration. It can hamper the actually estimation of the PPR in Fontaine. So the better measurement method is to determine the pulmonary blood flow by cardiac MRI and measure the pressure by cardiac cath to avoid the misleading results. And how about the pulmonary vasodilators in Fontaine circulation? Let's check out the result from the real clinical trial. In short term, pulmonary vasodilators
Okay. Moderator, Professor Huang.
Yes. I cannot hear you. I'm sorry. I can't hear you.
Professor Huang, the
Yes,
doctor
yes.
lose the lecture. Yeah, okay. Yeah, okay. We will discussion together. Yeah,
I
okay.
cannot hear you.
We
I cannot hear
together.
you.
Yeah. Can you hear me? Can you hear me?
No, I
Okay.
cannot hear you.
I can hear you now. Yes.
Yeah, I hear you now. Okay. Okay. Okay.
for some
Because
small scale long-term trial. The sildenafil and the bosentan showed variable effect. The sildenafil showed it can reduce the VCO2 slope at an anaerobic threshold, but the VO2 during peak exercise was not different. But the echocardial performance was improved after the assessed weight of sildenafil. Another study using bosentan for 6 months showed no difference in VO2 mass NT-proBNP after bosentan use. And another small-scale study using bosentan and macitentan showed improved cardiovascular hemodynamic and exercise performance. Abrisentan can also increase the VO2 mass and decrease VCO2 slope during exercise. And the most important two long-term trial involving bosentan and sildenafil. We will see more detail about these two important clinical trials. The Temple study involved 75 Fontaine patients from 4 centers in North Europe. When they gave 14 weeks of bosentan, the exercise performance using oxygen consumption during peak exercise showed improved about 3.5% compared to 2.1% of placebo group. There is a significant difference, but the difference is not large. The secondary endpoint is the duration of exercise stays from 6 minutes to 7 minutes. Although it's different from the placebo group, but the change is also not a lot. When we see the recent field trial involving 400 adolescent Fontaine patients from 30 centers in North America and Korea. They use Unanofil for 26 weeks. We can see the concentration during peak exercise changed a little, 2.8%, did not reach significant compared to placebo group. However, the secondary endpoint about anaerobic threshold increased a little compared to placebo group, with a significant difference, but not very much. So, from the clinical trials of the pulmonary vasodilators in Fontaine circulation, we know that pharmacological manipulation of Fontaine circuit is extremely challenging, partly because the mechanism and the pathology of PH in Fontaine is different from the idiopathic pulmonary artery hypertension. So the medication targeting pathogenesis of Fontaine with PAH may be more suitable for Fontaine patients. There are also many unanswered questions from these clinical trials. Is there a role in patients with Fontaine failure, or can these vasodilators can decrease mortality? What kind of Fontaine patient may benefit from vasodilators? The longer the better. Or is the prophylactic use of vasodilators helpful? Which drug is more effective and safe for Fontaine? This we all not know. In conclusion, the PVR is a key determinant of cardiac output in Fontaine patients, and it can increase with age. That's why the pulmonary vasodilator may be benefit for Fontaine patients. Although the clinical trial was performed so far, the safety and the well-tolerated results encourage us to use the pulmonary vasodilators in Fontaine patients, but the results of clinical trials shows variable and marginal improvement in exercise capacity and the hemodynamic profiles, and the impact on long-term prognosis is still unknown. Thank you very much.
Okay. Thank you. Moderator, Professor Huang.
Yes.
Okay. Because our discussion session put it together, so let's go proceed the following lecture. Okay. Okay. Welcome, moderator. Next talk, the president of Pingdong Christian Hospital, Professor Tae-Sean Tuck. Professor Tuck, please.
Thank you. Good
Professor
afternoon. Yes. Can you hear me? Yes.
Yes.
Ladies and gentlemen, I am Dr. Tok from Pingdong Christian Hospital. It is my privilege to introduce our next speaker, Professor Yi Ling. Today, this is his second talk, and the topic is pediatric pulmonary hypertension associated with bronchopulmonary dysplasia. Currently, he is the director of pediatric pulmonology of National Cheng Kung University Hospital. Professor Ling earned his MD degree at China Medical University in Taichung, Taiwan. He completed his pediatric residency, neonatology, and pediatric pulmonology fellowship training in National Cheng Kung University and became an attending doctor since then. Professor Lin has published 61 papers. He is also the director of Taiwan Society of Neonatology and vice president of Taiwan Society of Pediatric Pulmonology and Critical Care Medicine. Professor Lin, please.
Good afternoon. Thank you for your kind introduction. It's my pleasure to share with you this topic here. So what is BBD? Can we define it? It is currently a challenge for us, and we need to improve this definition of BBD, because that is a disease that is created in part and defined in part by our changing therapy. So we have the evolving definition of BBD over the years, and for this talk, the definition of BBD is the NIH consensus classification published in 2001. The newer definition is published in Blue Journal in 2019, an evidence-based definition of BBD. In this paper, the best definition that predicts early childhood morbidity is the disease severity based on the mode of respiratory support at 36 weeks PMA in respective of supplementary oxygen. Outline of this talk. First, we focus on its clinical significance. Late pulmonary hypertension is associated with poor survival in BPD. Pulmonary hypertension is a risk factor with highest adjusted odds ratio for mortality in this study. And in another study, 47 of patients die 2 years after the diagnosis of pulmonary hypertension. BPD with pulmonary hypertension is also associated with suboptimal osmotic growth, poor neurodevelopmental outcome, higher rates of tracheostomy, increased use of oxygen, breathing problem, and frequent hospital admission. We then discuss a little bit the idea of pulmonary vascular disease, known as PVD. What is PVD? The definition is any condition that affects the blood vessels along the route between the heart and the lung. And some evidence suggests that PVD precedes the onset of clinical signs and symptoms of pulmonary hypertension, and likely exists long before pulmonary arterial hypertension is detected due to the structural reserve of the normal growing pulmonary vascular bed. It is a condition that exists across the lifespan. This slide illustrates the pathogenesis of PVD in BBD. Preterm birth, lung injury, placenta dysfunction, epigenetic and genetic factors. All of these factors have effects on developing lung circulation. And subsequently, we have abnormal function, abnormal structure, also known as remodeling, and decreased growth in angiogenesis, vascular growth, and alveolar growth. And let's move on to the epidemiology of pulmonary hypertension. This slide summarizes 3 studies of pulmonary hypertension in preterm infants. All were diagnosed by echo with different patient inclusion criteria. Screening at different time point with different occurrence rate of BPD and pulmonary hypertension. This slide shows the relationship of pulmonary hypertension with the severity of BPD in 3 cohorts. As shown here, high occurrence rates of pulmonary hypertension were observed in more severe form of BPD. And the occurrence rate of pulmonary hypertension in these 3 cohorts are different. The meta-analysis studies showing that compared with BPD alone, BPD-associated pulmonary hypertension is linked to poor growth at discharge and also in hospital mortality. There were 25 studies included in this meta-analysis. Group 1 bubbles with dashed line, they have poorly defined time of assessment. Group 2 bubbles with solid outlines, they have well-defined time of assessment. And the bubbles area represents the number of infants. And the few bubbles represent prospective studies. For all the infants included in this study, 12% had pulmonary hypertension. For infants with BPD, 20% had pulmonary hypertension. Hypertension is also different. No BPD is 2%, mild BPD 4%, moderate BPD 8%, severe BPD 39%. And in summary, current publications do not provide sufficient data for an accurate assessment of the true prevalence and risk factors and the outcome of pulmonary hypertension in preterm infants. And let's talk about screening. So how to identify these kids early and get them appropriate management. Several issues have to be addressed regarding how to screen, when to screen, what is the diagnostic evaluation, and what is the role of cardiac catheterization and whom to screen. To define pulmonary hypertension in preterm infant is a challenge at present. The precise pulmonary arterial pressure to diagnose pulmonary hypertension in preterm infants is not clear. The mean pulmonary arterial pressure over 25 millimeter mercury is considered abnormal for infants over 3 months of age, and cardiac catheterization is the gold standard for diagnosis of pulmonary hypertension. And systemic arterial pressure rise with gestational age. So we have the speculation pulmonary arterial pressure may be developmentally regulated. And echocardiogram provides tremendous amounts of diagnostic information regarding pulmonary hypertension, but need for standard. How to screen? EKG lacks sensitivity. And echocardiogram is multi-parameter measurement is currently the best non-invasive approach. The slide illustrates the relationship between pulmonary arterial pressure measured by cardiac echo and cast. Horizontal axis representing air pressure measured by cardiac cast. And the vertical axis represents PA pressure measured by cardiac echo. As you can see, there's a poor correlation of the two measurements. In different group of pulmonary hypertension categorized by CAS measurement, there was overlapping of PA estimate by cardiac echo. These are the proposed measurements in the pulmonary hypertension studies in newborn and young infants. There were no uniform standard measurement in the literature. Photo screen, extreme prematurity, IUGL preeclampsia, maternal smoking, prolonged ventilated course, inability to win FiO2, lack of overall improvement with time, poor growth, recurrent spells, severe BPD, or infants with BPD near term correct age, even if they are clinically stable. So these are the high risk factors for pulmonary hypertension in BPD. And pediatric pulmonary hypertension net proposed this protocol for screening. And there are different protocols suggested by European experts. And the criteria for screening are screening by echo, severe BPD in preterm infant gestation less than 28 weeks, established BPD at the PMS 36 weeks and before discharge, or prolonged oxygen requirement, poor growth, and unsatisfactory clinical improvement. For cardiac CAS, if you want to introduce a second pulmonary hypertension specific medication, or if pulmonary hypertension was under dual therapy, or if unsatisfactory treatment response is seen in any infant with pulmonary hypertension at a corrected postnatal age over 3 months. And we are going to talk about this therapy. We need a team with multidisciplinary, such as the neonatologist, pediatric pulmonologist, cardiologist, specialists in the field of intensive care and management of pulmonary hypertension. In addition, before initiating the treatment, always evaluate the underlying lung disease. So we need monitor of oxygen, monitor the PaCO2, also note for survey for coronary aspiration, sleep study, structural airway disease, including the flexible bronchoscopy, reactive airway disease, and also perform a CT scan. And sometimes we have to confirm by cardiac catheterization. Supporting care of these patients, cardiac SaO2, over 93% for suspect pulmonary hypertension and over 95% for proven pulmonary hypertension. And we had also to maximize the non-invasive respiratory support, provide high calorie for these kids, and use BPD-friendly ventilatory strategy, and sometimes consider diuretics. BPD is a lung disease with heterogeneous lung component, and they have different time constant in each component. So if you use low tidal volume and short inspiratory time, and then there will be a loss of adverse effects. If you use the so-called BPD-friendly strategy with high tidal volume and longer expiratory time, there are lots of benefits. For pulmonary vasodilator therapy, there are 3 primary pathways: the endothelin pathway, nitric oxide pathway, and the prostacyclin pathway. For the endothelin pathway, a well-known endothelin receptor blocker is prosentin. And for nitric oxide pathway, the well-known medication is PDE5 inhibitor, sildenafil. And so these are the drugs for BVD-associated pulmonary hypertension. And these are the approved therapy for pediatric pulmonary hypertension. In Europe, EMA, it's a sildenafil with a body weight over 8 kilogram and over 1 year old. Bosentan with age over 1 year old. And for American FDA, it's bosentan with age over 3 years. And however, both sildenafil and bosentan are frequently off-label used for acute and long-term treatment of infants with BVD-associated pulmonary hypertension. After the use of these therapy for pulmonary hypertension, the survival improved. Blue line indicates studies before the use of this therapy, and the green line indicates studies after the use of this therapy. As you can see here, the survival rate increased. So the take-home message, BVD is an evolving disease, and BVD with pulmonary hypertension is associated with poor outcomes. Experts suggest screening with echo and confirmed by cardiac cath. Survey for underlying lung disease is important, and use of BVD-friendly ventilation strategy, and improving survival rate with pharmacotherapy in these children. And thank you for your attention.
Okay, the moderator, Professor Park. Let's proceed. Next talk, welcome the moderator, Professor Zhang. Professor Zhang.
Good afternoon. Can you hear me? Can you hear me?
Yes.
Okay.
Yes, very clear.
Yes.
Okay. Good afternoon, dear colleague. I'm Dr. Zhang Zhongyi. It's my great honor to introduce the last speaker, Professor Xu Shaoxun. He was my dear colleague. Professor Xu currently is the chief of the thoracic surgery division and deputy executive officer of the International Medical Office Center at National Taiwan University Hospital. Over the past 20 years, Professor Xu has dedicated his career to the research and the practice in the thoracic surgery, pulmonary hypertension, and lung transplantation. He also chairs the Pulmonary Vasculature and the Pulmonary Hypertension Committee of Taiwan Society of Pulmonary and Critical Care Medicine. He has published more than 100 original articles on lung transplantation, pulmonary hypertension, and thoracic surgery. Today, he will give us a speech about pulmonary transplantation, lung transplantation for pulmonary artery hypertension. Professor Xu, please.
Good afternoon, ladies and gentlemen. I'm Dr. Xu, come from the National Taiwan University Hospital. Today, I'm very honored to be invited for the special topic, pulmonary transplantation for pulmonary arterial hypertension. Pulmonary transplantation was a life-saving surgery for end-stage PH patients. However, there were some issues still under discussion for this kind of surgery. We may consider lung transplant or heart lung transplant in PH patients. We should also consider bilateral lung transplant or single lung transplant in PH patients. In an area where donor scarce was still a big problem, there are some surgeons that perform the living donor lobar lung transplant for PH patients. In the United States or in the European country, donation after circulation death could be a feasible method instead of the brain death donor. In the following slide, I would like to use the database from the ISHLT to introduce the difference between lung transplant, heart lung transplant, single lung transplant, and the bilateral lung transplant. The first slide is the number of the annual lung transplant and the heart lung transplant in the world. In the left-hand side, we can see the number of the lung transplant was increased significantly in the past several years, and the majority of the lung transplant was performed in the North America and Europe. The right-hand image shows the total number of the heart lung transplant. We can see the annual number of the heart lung transplant was significantly decreased in the past several years. Currently, the annual number of heart lung transplant in the world was less than 100, and also the majority of the heart lung transplant was performed in the North America and Europe. The following slide, I would like to show the survival difference between heart lung transplant and the lung transplant. For the left-hand side, this is the survival for lung transplant. So we can see the median survival for adult lung transplant was around 6.2 years, and the median survival for pediatric was around 5.7 years. Compared with the lung transplant, the survival for heart lung transplant was worse than lung transplant. The median survival for adult patients receiving heart lung transplant was around 4.5 years, and for pediatric was around 3.6 years. The next slide I would like to introduce about the survival between double lung transplant and single lung transplant. Go through this slide, we can see bilateral or double lung transplant has better survival than single lung transplant. So based on the previous slide, we can know if we can perform bilateral lung transplant in end-stage PAH patient, the patient will have better survival compared with heart lung transplant or single lung transplant. So in the following lecture, I would like to focus on bilateral lung transplant for end-stage PAH patient. The first case is about an IPH patient received the bilateral lung transplant. This is the trajectory of our patient. Although the patient under targeting pH therapy for 2 years, the size of the right heart significantly increased, and the patient's condition was worsening. The chest CT image shows the size of the mean pulmonary artery and the RA and the RV size. We can see the patient will still have some ascites. All of this picture implies that the patient was an end-stage PAH patient, and the patient was listed for lung. Although the patient under triple combination therapy, including the foreign treatment, the size of the heart was still very big. After bilateral lung transplant, we can see the heart size become normal. Before lung transplant, the patient was very critical and needed to rest on bed. And after bilateral lung transplant, the patient have a good quality of life. So we compare the chest CT image before lung transplant and 5 years after bilateral lung transplant. We can see the size of the right heart and also the pulmonary artery became normal after bilateral lung transplantation. Before lung transplant, the patient needed to take the pH drug daily. However, after lung transplant, the patient still needs to take drug, but this time she needs to take immunosuppression. So we may cure the disease, PAH disease. However, the patient still needs to take medicine regularly. This slide shows the day of discharge when the patient take photo together with our lung transplant team. And 10 years after bilateral lung transplant, the patient remained well. This is her daughter. Now she was a high school student. The following 2 cases I would like to introduce about using the bilateral lung transplant for CHD-PAH patient, which means congenital heart disease with PAH. The following case, I would like to introduce a patient with ASD and Asperger syndrome who received bilateral lung transplantation. This slide shows the diagnosis triad for ASD with Asperger syndrome. The patient will develop pulmonary hypertension due to the right to left shunt. And in this feature, we can see at the end of the PAH, the patient will develop medial hypertrophy, intima hyperplasia, and small lumen. The mean age at death was around 37 years. So this is our patient's right heart cath data. We can see at the diagnosis of Asperger syndrome, the pulmonary artery mean pressure and the situation was very severe. And this is a shunt area. At the first beginning, it may left to right shunt, and at this end, it will reverse to right to left shunt. And this trajectory shows a very typical huge pulmonary artery. This CT scan image shows the huge pulmonary artery, and compare with the ascending and the descending aorta, we can see the MPA was very huge. We perform bilateral lung transplant with intraoperative ASD repair under cardiopulmonary bypass support. Go through the craniotomy procedure, we perform the ASD repair first, and then bilateral lung transplant was performed following. The donor ischemic time was around 4 hours, and the total bypass time was around 4 hours 20 minutes. The table shows the parameter before and after lung transplant. We can see the LV ejection fraction and the right ventricle ejection fraction was very good after bilateral lung transplant. The mean PAP decreased from 70 to 28, and the situation was also improved a lot. This photo shows the native lung was taken out and the patient under cardiopulmonary bypass. And this slide shows after implant the 2 lung in the patient. So this slide shows the trajectory image change before and after lung transplant. We can see ASD patient with Asperger syndrome, when she received bilateral lung transplant, the size of the heart can also become normal. The last case I would like to introduce is about the PDA with hypoplasia of bilateral pulmonary artery. The patient received bilateral lung transplant. This serious image shows a PDA when the patient was 2 months old and 9 years old. The size of the MPA was huge. And this trajectory shows the patient have a big heart size, and the clinical condition was very worsening. So he was referred to us for bilateral lung transplant at the age of 12. This slide shows the severity of our patient. Go through the right heart cath and the cardiac echo data. We can see the TR pressure gradient was increased from 80 to over 130. And also the proBNP data also increased from 170 to over 2,000. And this is the right heart cath data when the patient listing for lung transplantation. We can see the pressure of the mean PAP was equally to the pressure of the aorta. So the condition of the patient was very severe. This the image shows here have a large PDA, and the mean PAP pressure was equally to the aorta pressure. So the patient have very poor quality of life and need to use the oxygen all day long. This slide shows the donor and the recipient information. Before lung transplant, we can see the donor was a 32 years old male, and this is the trajectory of the donor, and this is the donor lung. because right now the recipient was already 12 years old, so the body height, body weight, and the chest circumference was nearly equal compared to the donor size. And this is a recipient image survey before lung transplant. We can see the heart was very big and tortuous to the right side. The patient had a huge MPA, which due to the PDA with severe PAH. The reconstruction CT image show the pink color was the MPA, and the blue color was the pulmonary vein. So we can know the patient has very few pulmonary perfusion, which was corrected from the systemic area. So this is the image when we perform lung transplant, the huge MPA and the large PDA. This slide shows we perform the bilateral lung transplant with intraoperative PDA repair under cardiopulmonary bypass support. We can see after bilateral lung transplant, the left lung and the right lung looks good, and the MPA was still huge. However, in the following months, the size of the heart become normal. Go through our reconstruction chest CT image. You can see the pink color was the pulmonary artery system. The MPA, right side pulmonary artery, and the left side pulmonary artery have normal size. The important is the venous return. So you can see the pulmonary vein was normal. So go through this slide, we can see we have already resumed the pulmonary circulation for this patient. After bilateral lung transplant with PDA repair, the patient's cardiopulmonary function and the exercise ability was improved a lot. We can see the FVC and the FEV1 both improve very significantly after bilateral lung transplant. The level of the proBNP decreased significantly, and the 6 milliwatt distance improved from 80 millimeter to over 400 meter. So we know the patient's condition was improved a lot, and the quality of life was good. The size of the heart was also different. This is the before lung transplant and the after bilateral lung transplant was with PDA repair. We can see the heart size become normal. After bilateral lung transplant, the patient regained her exercise ability and could go to the rehabilitation room for exercise training. So we can see the chest CT reconstruction image before and after lung transplant. And right now, the patient living very well with good quality of life and return to school. Before ending my talk, I would like to give you some important information go through the ISHLT database. So basically, this slide shows the outcome difference between heart lung transplant and the lung transplant for CHD PH patient. So when we perform heart lung transplant for CHD PH patient, the 1 year survival was around 64%. When we perform lung transplant for this kind of patient, the 1 year survival is over 70. So go through this photograph, we can know lung transplant have better survival than heart lung transplant in patients with CHD PAH. The second point I want to mention was about the disease difference. So we can see when the patient was diagnosed as the IPH, the heart lung transplant survival was better than PH, but not caused by IPH. So this is very interesting. IPH patient received heart lung transplant has better survival compared with cystic fibrosis and the PH patient which was not caused by the IPH. For lung transplant patient, we can see the red color was IPH patient received lung transplant. Also, when the patient received lung transplant, the survival was better than PH, but not caused by the IPH. So go through this slide, we can see when the patient with CHD-PH patient, the patient have better survival when the patient receive lung transplant compared with the heart lung transplant. And the most important is when we perform IPH patient for lung transplant, the patient has better survival than other PH patient, but not caused by IPH. I want to summarize my talk. Instead of heart lung transplant, the heart function could be resumed after bilateral lung transplant in patients with end-stage PH, including IPH and the CHD-PH patient. Although the operation time was longer because we need to repair the cardiac defect, and we need some expertise in the surgical technique. However, lung transplant with concomitant cardiac repair could be a acceptable and favorable therapeutic option for some selective end-stage CHD patients with complex cardiac defect. I would like to thank you for your kind attention.
Thank you, Professor Xu. Excellent talk. I think we will start the panel discussion and the question from the floor. Professor Dai.
Okay, that's particular discussion session. Welcome moderator Professor Ren Gongdai and Professor Zonghao Xu. The Professor Xu, please. Professor Dai, please.
Thank you for all of the speaker. It's very excellent talk. And on the congenital heart disease and after front-end operation, and also related to the prematurity with the bronchopulmonary dysplasia, and the last is the lung transplantation. I think this is a very important issue for our pediatric pulmonologists. So would you please, Dr. Shi, to lead us to discussion, please?
Okay. Thank you very much. It's my honor to. Could you hear me?
Okay, Professor Xu.
Yes, yes.
Yeah, yes.
Okay.
Proceed.
Okay. It's really my pleasure to host the discussion. First of all, I want to thank all the wonderful speeches given by the speaker, Professor Dai, for the talk of the PH with congenital heart disease, and Professor Lu for the talk about Fountain PAH, and Professor Lin for the BPT PAH, and finally the talk by Dr. Xu for the lung transplantation. So given the time limit, we only have 5 minutes for the question. I have one question for Professor Xu Shaoxun. Congratulations for your wonderful result for the patient with Eisenmenger syndrome. I just wonder that between the decision of heart lung transplantation versus lung transplantation in a patient with Eisenmenger syndrome, is there any clear criteria to choose between heart lung transplantation and lung transplantation? Because in Eisenmenger syndrome, in some cases with very irreversible PAH, do you still choose only lung transplantation instead of heart lung transplantation? Thank you.
Okay, thank you for your question. First of all, I want to mention about in Taiwan, currently the heart lung transplant is still a clinical trial, which means when the patient want to receive heart lung transplant, the patient need to join the clinical trial. And right now, the clinical trial was conducted in the National Taiwan University Hospital. The second is about the donor. If you want to perform a heart lung transplant, then we need a heart and also a lung. Actually, in Taiwan, the donor scarce is a big problem. So we think about if we can perform lung transplant with intracardiac repair,
which may let the donor heart to give another patient who need a donor lung. So if we want to choose the heart lung transplant, we need to keep in mind, can we perform lung transplant with intracardiac repair? If we can perform this procedure, then the patient do not need to go to the heart lung transplant clinical trial, and also another patient can receive the heart. So the question is about which kind of the patient is really need a heart lung transplant. And in our group, we think about if this patient is a complex heart disease, which means the patient has already received cardiac surgery when he or she was born or in the child. And also when the heart defect is too complex to repair in the operation, then we will refer the patient to receive the heart lung transplant. So this is our thinking process. Thank you very much.
Thank you, Dr. Xu. Any question from the moderators or the speaker in this section?
Yes. May I have a question?
Sure, please.
I have a question to Dr. Lu Jingwei. According to your speech, the pulmonary vascular resistance will increase after the Fontan operation. What do you think the role of the buffer fenestration in the Fontan patients? And do we need to close it?
In my opinion, I think fenestration for TCPC provides the way to avoid pulmonary vascular resistance and to increase the cardiac output. So if the saturation of the patient is not very low, I suggest keep the fenestration after the TCPC procedure, and try to avoid close the fenestration as possible, because when the PVR increased, the fenestration will provide a tool to improve the cardiac output in Fontan patient when the patient become aged. So, but you have to beware of that. The fenestration may cause some kind of cyanosis for the cause of increasing the cardiac output. When the patient become with the sign of Fontan failure, I suggest we may try some pulmonary vasodilators to decrease the PVR and to increase the performance of Fontan patient.
Thank you very much.
Okay, there's a question from the floor from Ross Anita. He asked, in Taiwan, what is the commonest underlying condition in children that had undergone lung transplant? Is the outcome the same as the PAH? Maybe Dr. Xu Shaoxun can answer this question.
Sure. And currently, the indication for lung transplant for children in Taiwan is including the CHD PH patient. Also, we also ever perform a cystic fibrosis patient, and the majority of the patient was referred from our pediatric department doctor. So about the survival, we find the pediatric lung transplant patients have better survival than adult lung transplant. I think the most important is about the family support, because when the patient want to receive lung transplant, which means the family will support the patient. So I think the patient have good survival, which not only means the patient, which means the patient family support was good, and also we have very strong cooperated with our pediatric surgeon. So we use the thoracic doctor and also the pediatric cardiovascular surgeon. We combine the two teams together to perform the surgery to let the patient have better outcome. And thank you for your question.
Okay. So Dr. Mu, do we still have time or do we need to close the section now?
Okay, depends on your life.
Any question from the moderators or speaker? Professor Huang?
Question to Dr. Lu. Dr. Lu, you just show us very beautiful slide about the pulmonary hypertension in Fontaine physiology patients. I wondering, is any data or study to show the number of the pulmonary pressure will be changed after your therapy, and the definition of pulmonary hypertension in that particular patient with the Fontaine procedure is the same as the different patients who use 25 or 30 millimeter. How about in the patient with Fontaine physiological? The number of pulmonary hypertension definition is the same, and the result of the treatment. How about the treatment? Thank you.
Yes. Some clinical trial they have do the hemodynamic study after the pulmonary vasodilator. But the change of the pulmonary artery pressure after therapy is marginal. This means that there's a big change after the therapy compared to the pulmonary vasodilator to the IPH patient. The effect of pulmonary vasodilator is less in Fontaine patient. And the definition I have shown in my slide, the definition of pulmonary hypertension in Fontaine is very different from the conventional pulmonary hypertension. We should measure the PBR. If the PBR above 3 or the transpulmonary gradient above 6 millimeter mercury, we think the Fontaine patient had pulmonary vascular disease or hypertension in Fontaine circulation.
Yes, you are right. Because if patient with a Fontaine physiology is usually a complicated conjunctivitis, and the peripheral pulmonary artery. Some patient with different branch of pulmonary stenosis. So should we exclude the so-called one or two branch of the pulmonary stenosis before you make the definitions?
Okay, because we have delay for 15 minutes, so I'm afraid I have to close this section. Again, I thank all the speakers and all the moderators, including Professor Wu Junmin, Professor Huang Bitao, Professor Zhuo Zhenzong, and Zhuo Desong, and Professor Zhang Zhongyi. Thank you very much. We have a wonderful section of PAH. Thank you very much. So I'll hand the time to Dr. Mu.
Okay, thank you. Thank you, our distinguished speaker and moderators, Professor Dai and Professor Xu. Let's take a break. We'll come back 5 minutes later, and then keep on your attention. We are going to see the useful practical experience sharing lecture. Please back on PM 5:40. Don't go too far. Remember back. Don't forget. Thank you. 5:40. Thank you.
Imagine this. Right this second, a 1-year-old girl somewhere in the world is taking her first step, unaware that she might be one of the first 200-year-old humans living on this planet. The future has never felt closer, and change is what pushes our world forward. It's happening every second, in every city, and in every aspect of life. And every cure, innovation, and medical breakthrough has been made possible because something changed and evolved into something new. Over the years, Getinge has grown and turned into a global market leader in over 40 different markets. The changing world has made us bring our many brands together so that we can change the world as one. And as we aim for an even greater future, we now take the next step. As your full-service partner, we support you through the entire clinical pathway so that you can continue to provide excellent care and enable cure without ever compromising on quality and safety. Through new innovations and thousands of passionate people working under one brand, we keep progressing, and we're just as dedicated to serving you as ever. Because to save lives is the greatest mission in the world. That's what you do. Our job is to enable you to save as many as possible, to be by your side every step of the way, maintaining the miracle that is life. Imagine this. Right this second, a one-year-old girl somewhere in the world is taking her first step, unaware that she might be one of the first 200-year-old humans living on this planet. The future has never felt closer, and change is what pushes our world forward. It's happening every second, in every city, and in every aspect of life. And every cure, innovation, and medical breakthrough has been made possible because something changed and evolved into something new. Over the years, Getinge has grown and turned into a global market leader in over 40 different markets. The changing world has made us bring our many brands together so that we can change the world as one. And as we aim for an even greater future, we now take the next step. As your full-service partner, we support you through the entire clinical pathway so that you can continue to provide excellent care and enable cure without ever compromising on quality and safety. Through new innovations and thousands of passionate people working under one brand, we keep progressing, and we're just as dedicated to serving you as ever. Because to save lives is the greatest mission in the world. That's what you do. Our job is to enable you to save as many as possible, to be by your side every step of the way, maintaining the miracle that is life.
Hi, dear friends and dear audience. It's time to start our tonight's dinner. Let's serve the main course, feature lecture. The welcome moderator, Professor Chun. Yeah. Professor here, please. To introduce the speaker, Professor Stan. Start.
Dr. Howard Stein is the medical director of the Neonatal Intensive Care Unit, section head of neonatology at the Abba Children's Hospital, used to be called Toledo Children's Hospital. Professor of Pediatrics at the University of Toledo Health Science Campus in Toledo, Ohio. He is the president of the medical staff of the ProMedica Everett Children's Hospital and chairman of the ProMedica Institutional Review Board. Dr. Stein has worked with NAVA ventilation since 2008 and has taken care of hundreds of neonates on NAVA and on NIV NAVA. He's an expert on NAVA ventilation and is actively doing clinical trials on how best to use the NAVA in the NICU. He has published articles and presented his findings about NAVA at national and international meetings. He also, with Dr. Kim Firestone at Akron Children's Hospital, developed a clinical guideline and management strategies for NAVA ventilation in neonates. The topic to be discussed today is application of neurally adjusted ventilator assist, so-called NAVA, in neonates. Dr. Stein, please.
Hi, my name's Howard Stein. I'm the Medical Director of the Neonatal Intensive Care Unit at ProMedica eBay Children's Hospital in Toledo, Ohio. Today we're going to talk about NAVA, or Neurally Adjusted Ventilator Assist, in the newborn. I am a speaker for McKay Gettinger Group, and I will be talking about products that are made by McKay Gettinger. However, I've received no financial support or incentives from McKay to use NAVA or to collect the data that I'll be sharing with you today. So I'm from Toledo, Ohio, and Ohio is located here in the top east northern corner of the United States, and Toledo is right at the top there, right on the border of Canada. I come from, our neonatal intensive care unit is in ProMedica Toledo Hospital, and we are part of that. We are a 71-bed NICU that is a level 3B unit, which means we do everything in there except for cardiac surgery and ECMO. Last year in 2020, we had 950 admissions, so we're a relatively busy unit, and about 350 of those babies were born outside of the hospital and needed to be transferred in, and the other remaining babies were all born at the Toledo Hospital. Today we're going to talk about how NAVA works. And then I'm going to discuss briefly the concept of the NAVA level, how to escalate the NAVA level and how to wean it. I'll then talk about apnea time, peak pressure limit, and then I'll do a very brief review of our respiratory outcome data from our neonatal intensive care unit. So before we talk about NAVA, let's do a quick review on how the flow trigger works. So the signal comes from the brainstem down the phrenic nerve to the diaphragm. When the diaphragm gets activated, it contracts, and that contraction causes a vacuum, which causes air to flow or be pulled into the lungs. And that flow into the lungs then opens a little valve in the ventilator and tells the ventilator that it's time to give a breath. And that breath is then delivered to the baby. So the baby's breath has already started before the ventilator is communicated with to give a breath. So there's a slight trigger delay between the initiation of the biologic breath and the beginning of the mechanical breath. NAVA works a little differently. The signal comes from the brainstem down the phrenic nerve to the diaphragm. When the diaphragm gets activated, a signal goes along the nasogastric tube picked up by specialized electrodes and is converted using this thing called the NAVA level into a mechanical breath, so that the ventilator then delivers the breath to the patient at exactly the same time that the diaphragm contracts. This breath is continued to be delivered until the lung has reached optimal inflation, at which point a signal goes back through the Herring-Brewer reflex that is a negative feedback that turns the signal off at the brainstem, so there's no longer signal coming down the phrenic nerve, and then immediately the signal is terminated to the ventilator and the breath is terminated to the patient. So that allows NAVA to then be synchronous with the initiation of the breath by using these electrodes, the termination of each breath, and it's synchronous for not only initiation and termination, but also the size of the breath, depending on the amount of electrical activity that is going to the ventilator. The NAVA level is this proportionality factor that converts the electrical activity of the diaphragm into a pressure. But what I want you to actually think of this is that it is a conversion of work of breathing. so that the higher the NAVA level, the more work of breathing the ventilator does, and the lower the NAVA level, the more work of breathing the patient does. And our goal is to unload the work of breathing from the patient who is struggling to breathe to the ventilator, but to do that without over-assisting the patient, and keeping in mind that the ventilator continues to respond to the patient's respiratory drive, but supports the patient's respiratory effort. So in this graph, what I'm going to show you is this distribution between the work of breathing between the two entities. The red over here is going to be the patient, and that is called the biologic diaphragm. So that's the patient's diaphragm, whereas the green boxes, which I'll show you in a moment, is from the ventilator. And I want you to think of that as the mechanical diaphragm. So the biologic diaphragm is the patient's contribution. The mechanical diaphragm is the ventilator's contribution. Over here, you can see this is the EDI levels, the tonic EDI, the peak minus min. And this is the peak pressure or the tidal volume. You can look at it either way that's going to be delivered to the patient. So initially over here, when you're not providing any support, this patient is in respiratory failure. They are looking to get a breath about this big, but they are unable to take the pressure or volume that they require. So therefore, they're grunting, they're flaring, they're retracting, and they're having clinical compromise because their diaphragm, the biologic diaphragm, is failing. They also have an extremely high respiratory drive because they're working really hard to try and make up for this poor pulmonary function. So once we put them on NAVA, the mechanical ventilator now starts to contribute. And you can see now that the baby is taking a larger breath, most of it biologic diaphragm, but a little bit from the mechanical diaphragm. As we increase the NAVA level, the contribution of the mechanical diaphragm gets higher and higher, and the biologic diaphragm is required to do a little less until we reach a certain point. And after that point, the mechanical diaphragm does more and more, the biologic diaphragm does less and less, but the total pressure or volume delivered doesn't change, because it's at that point that the Herring-Brewer reflex kicks in and sends negative feedback, because we've now achieved optimal inflation of the lung. We know we've achieved that because after we reach this point, the respiratory drive, or the EDI, starts to decrease. When we're out here, we are over-assisting the baby. When we're down here, we are under-assisting the baby. And the goal is to be right at this point here, which we have called the break point, where we're providing adequate pressure and tidal volume without under-assisting and without over-assisting. If you note over here, I've also put a dotted line where we're setting the peak pressure limit. And if we set the peak pressure limit too low, we never are going to allow these babies to take adequate breaths. So the peak pressure limit has to be set higher than what the optimal pressure is to allow these babies the opportunity to take recruiting breaths whenever they need it. And we'll talk about this again much more a little bit later. So this is how we escalate NAVA until we get to the peak, to the break point, and that's where we would then set the NAVA level. Now, as the baby starts to improve, we want to then wean the baby. So here you can see we've got a baby that's set at the break point where the biologic diaphragm is doing some work, but the mechanical diaphragm is doing most of the work. The baby is now improving. So we start to wean the NAVA level. Whoops, wrong way. And as we wean the NAVA level, you can see that our total breath remains the same, but the biologic diaphragm is now starting to do more work. And as we wean the NAVA level further, the biologic diaphragm does more and more work, the mechanical diaphragm does less work, and here we have a baby that we are now able to take away all respiratory support because the biologic diaphragm has recovered and is now strong enough to do all the work, and the mechanical diaphragm is no longer required. The apnea time is the time the neonate is apneic before getting a backup breath. This is not related to apnea of prematurity. If you remember, the discussion of apnea of prematurity is all about babies who are extubated. These are babies that have no respiratory support that then become apneic, and after 15 to 20 seconds, they then start to desaturate and become bradycardic. Babies on ventilators don't have apnea of prematurity because they're on ventilators and they therefore get immediate respiratory support. So the apnea time is actually a time that translates into providing a guaranteed minimum rate when the baby's going between NAVA and backup. Now, moving between NAVA and backup is not a new concept to us, because when we have babies on SIMV, pressure control, or SIMV, volume targeted with volume control as your backup, babies do the same thing. If they're breathing spontaneously, they get SIMV breaths, synchronized breaths. But if they don't breathe, then they go into pressure control if you're using that type of ventilation, or volume control if you're using volume controlled ventilation. And they move between their synchronized breath and their control breath depending on their respiratory effort. NAVA is exactly the same. They move between going between NAVA and backup. And setting the minimum rate, as with conventional ventilation, determines how long we allow them to go without a breath before we give them a control breath. The backup rate can then be set independently to the apnea time. So if they stay in backup ventilation, you can pick whatever rate you want to ventilate them at, and that is different to the apnea time. So if we look at the apnea time here, if you think of it as apnea of prematurity and you set your alarm at 10 or 15 seconds, you can see that you're actually providing a minimum rate of 4 to 6 breaths per minute. And I think we can all agree that any baby who's on a ventilator, to set the ventilator rate at 4 to 6 breaths per minute is very, very inadequate. And these babies are going to do very poorly on the vent. Even setting a rate at apnea time at 5 seconds gives you a minimum rate of 12 breaths per minute, which is also very inadequate, especially for the micropreemie. Those that are 23 to 27 weeks are going to fail very rapidly with an apnea time of 5 seconds. We set apnea times at a maximum of 2 seconds, and that gives breaths of 30 breaths per minute, minimum rate. And our feeling is if you don't need at least 30 breaths per minute, you probably don't need to be on a ventilator, and you should be having a discussion about extubation or moving to CPAP if you're on non-invasive ventilation, and not talking about going longer on the apnea time.
我等下上班，要上大夜班呢。
To much shorter apnea times, and we can go all the way down to 1 second, which is a minimum rate of 60 breaths per minute. And here you can see the stepwise progression from 30 to 60 breaths per minute as you shorten the apnea time. Remember again, this is different to the backup rate. That's the respiratory rate that you set when the baby remains apneic and is getting pressure control ventilation, and you can set that rate at anything you want. To study this, we did a 2-center prospective interventional study where we compared 2 seconds to 5 seconds apnea time. So we set the baby either at 2 seconds for 2 hours or then 5 seconds for 2 hours, and then we interchanged back to the other apnea time. So each baby acted as their own control. And we looked at small babies, 26 weekers, and we studied them at about 2 weeks of age if they were still on invasive or non-invasive ventilation. Our data shows that the 5 seconds is the white bar, green is 2-second apnea time. So as you would expect, if you were set at a 2-second apnea time, you would go into backup more often, because a 5-second apnea time is a minimum rate of 12. This is a minimum rate of 30. So you'd go into backup more often. You'd also stay in backup more often. But the differences here are very small. On a 5-second apnea time, we went into backup less than 1 time per minute. But on a 2-second apnea time, you'd only go in between 2 and 3 times per minute and stay in backup for less than 10%, which is 6 seconds. So 2% comes out to be about 1 second. So 1 second versus 10 seconds, it's not a big difference of the time in backup. However, you can see that there was a significant decrease in the number of bradycardia and desaturations events that these babies had, that they were going from an average of about 7 events per hour down to less than 2 events per hour when they were on the shorter apnea time. So what we really showed was that giving a minimum rate of 30 was better than giving a minimum rate of 12, which is not surprising to anybody. But what is surprising is that I find so many of my colleagues are still using that 5-second apnea time because they think that 2 seconds is too small, too short. But on conventional ventilation, they are setting ventilator rates at 30 to 50 times per minute and have no issue with that. So don't think of it again as apnea, but rather think of it as a minimum rate. I'm now going to talk a little bit about this peak pressure limit. This is another area that is quite challenging to us because a lot of people are very concerned about setting this limit too high. So remember, whatever you set your peak pressure limit at, the peak pressure will pop off at 5 centimeters below whatever number you pick. We set the peak pressure limit high enough to allow these babies to take sigh or recruiting breaths. This is something that we take all the time. When we're talking to somebody, we'll occasionally give this big sigh or recruiting breath. When we yawn, we take a recruiting breath. Even when we laugh, that is an opportunity for us to recruit lung. If we don't take those sigh or recruiting breaths, over time, our lungs will become microatelectatic, and with enough time, it'll become very difficult for us to breathe. If we set the peak pressure limit too low for these babies, they will be unable to recruit their lung. And over the next few hours, you will notice that they start having more events. Their respiratory rate goes up much higher because they're developing atelectasis and their tidal volume is starting to fall. We typically set the peak pressure limit at 35 to 40 centimeters of water in our newborn babies. So even a 22 or 23 weeker, we will set the peak pressure limit at 35, which means we will allow these babies to take breaths as big as 30 centimeters of water. Now, in reality, they hardly ever do that. But our feeling is if they want to, we should allow them the chance to do that. In the babies that are 25 weeks and above, we will set the pressure limit as high as 40 centimeters. And in babies that develop BPD, who are still on ventilators and have very stiff lungs, you may be required to set that pressure limit much higher than that, and maybe as high as 70 or 80 centimeters of water, which sounds incredibly high. But with very, very stiff BPD lungs, those pressures are essential to keep these babies stable. Fortunately, in the newborn babies, 35 to 40 centimeters of water is more than adequate to enable these babies to be comfortable. So the question then is this safe? If we set these pressure limits this high, what peak pressures and tidal volumes do these babies actually choose? So we did a number of babies that we collected data on, 27 babies on NAVA, 29 on NIV-NAVA, and these were small babies. They were 800 grams on average. They were 26 weeks gestational age at birth, studied them between about 1 and 2 weeks of age, and we looked at a lot of breaths. We looked at just under 500,000 breaths for NAVA and just over 500,000 breaths for non-invasive NAVA. So on this graph, you can see the percent of breaths on the vertical axis, and you can see pressure sections over here, 5 to 10 centimeters of water, 10 to 15, 15 to 20, 20 to 25, all the way up to 30 to 35 centimeters of water. These babies all had their pressure limits set at 40 centimeters of water. And you can see that 70+% of breaths, the babies picked breaths that were less than 20 centimeters of water. So if we had this baby on conventional ventilation, we would have set the pressure somewhere around 20 or 22 centimeters of water. That's where we typically ventilate these babies. And you can see that some of the breaths, that's what the babies wanted. But the majority of the breaths, over 50% of the breaths, the babies actually wanted much lower pressure. They took very low pressures, which we believe is very lung protective. However, to do that, you can see that a small percent, about 10% of the breaths, required very high pressures. And these are those recruiting breaths that I was talking about. And if you don't allow those babies to take those breaths and you set the pressure limit at 30 so that it pops off at 25 right over here, and they cannot take those recruiting breaths, what will happen is they'll start developing atelectasis and they will lose the ability to take those breaths, and all the breaths they will take will be in this range over here. And they would also become very tachypnic. We saw a similar distribution on non-invasive NAVA, where the majority of the breaths, well over 50%, were very, very low pressure breaths, and only a small percent were on the high recruiting breath side. Tidal volume distribution, the same way. If you want to do volume ventilation, most people pick tidal volumes somewhere between 3 and 5. So if we pick 4 as the middle line of setting 4 mLs per kilo as your breath to be delivered, you can see that the majority of the breaths, in fact, 50% of the breaths the babies wanted less than 2 mLs per kilo. That's all they needed. And the rest of the time they were in kind of this middle range, but they did take 5% of the breaths were between 7 and 10 mLs per kilo. And again, we look at those as these very large recruiting breaths that allow the babies to do the majority of their ventilation at these very, very small tidal volumes. And our theory is that this, again, is very lung protective. If we dig a little deeper into the distribution, this is looking at the peak inspiratory pressure by NAVA level. And you can see if we go between 0.5 and 4, even if we get to the very highest range, the maximum breaths do hit these top numbers. We are seeing 35 for an occasional breath. These are the peaks. But the red dot here is the mean. The line over here is median. And these boxes are the 75th and 25th percentile. So that you can see the majority of the breaths fall well within the normal range that we would expect to ventilate these babies, with only a few outliers as recruiting breaths on the higher end. We see the same thing with tidal volume. Even though we are seeing some very large recruiting breaths, the median and the mean are well within that 4 ml per kilo or the 3 to 5 ml per kilo range throughout. And even at the highest NAVA levels, where the babies have the stiffest lungs, their tidal volumes are actually very small because they require this high NAVA level because of their stiff lungs. So we are not delivering massive tidal volumes most of the time. The majority are well within our expected ranges, and we feel, again, that this is very safe. So by taking this strategy of very early use of NAVA, our babies get NAVA immediately on admission to the neonatal intensive care unit. I wanted to share how our outcomes have changed over the years using this strategy. So I'm going to share with you now our outcomes for the Vermont-Oxford Network database, which we are a member in the less than 1,500 grams per year category. And we contribute between 120 to 135 neonates per year. And I'm going to look at a comparison group, which is the same NICUs as ours, which is the level 3B NICUs. So on this graph and all the other graphs, the solid line I'm going to show you is our neonatal intensive care unit, and the dotted line is the 50th percentile from the Vermont-Oxford network. So this first line I'm going to show you is the first set of graphs. I'm going to show you how our practice has changed. So I'm showing you data for about 11 years, from 2007 all the way down over to 2018. In 2008, we started with NAVA, and in 2010, we started with non-invasive NAVA. As you can see back here in 2007 and 2008, we were ventilating about 80% of our babies less than 1,500 grams, which to me was shocking. I did not realize that we were intubating and ventilating that many babies. And over time, we are now ventilating less than 50% of these babies. Any ventilation, that means invasive and non-invasive. And you can see we've steadily been decreasing, and so has the collaborative, from about 70% to about 58%. Everybody is ventilating less babies. We've just started in a bad place, but we're ending in a much better place. If we look at our use of non-invasive ventilation, in the beginning, we didn't use a lot like the rest of the network, but our use of non-invasive ventilation has gone up significantly, and we are now using a lot more than the rest of the Vermont Oxford network. So non-invasive ventilation, specifically NIV-NAVA, is our go-to strategy, and the majority of our babies are ventilated with NIV-NAVA. Our use of CPAP before we intubate babies has also gone up significantly. In the beginning, we didn't use this very much at all, but after the confidence we got from the support trial, we then started using CPAP much more aggressively, and as you can see, we are very close to the 50th percentile of using CPAP. We don't use it as aggressively as we use NIV-NAVA, and we will rapidly go from CPAP to NIV-NAVA, especially on the tiny babies, in an effort not to have to intubate these babies. We've been successful. Back in 2007, 2011, we were intubating 100% at times of these babies after early CPAP. They were all failing. But with the use of non-invasive NAVA, you can see that we have made a huge impact of not intubating these babies all the way out here now, where very few of our babies actually end up getting intubated after early CPAP, because we can go to non-invasive ventilation. And of course, that is combined with early use of surfactant. We are very aggressive with our surfactant use, and we will use the INSURE technique, where we intubate, we give surfactant, and we extubate within 1 to 2 minutes back to either CPAP or non-invasive NAVA. And that strategy has been very effective, as you can see. So what sort of data have we had? Well, the first thing I want to show you is our death or morbidity. So the way to decrease, if we don't have a lot of babies surviving, then of course we're not going to have a lot of chronic lung disease. So I'm going to show you our morbidity, but I also want to show you the amount of babies for death. The dotted lines over here in yellow is the Vermont Oxford 50th percentile, and the dotted line in green is the Vermont Oxford Network 75th percentile. And of course, the lower you are, the better it is. And you can see that in our NICU, our trend line here of death and morbidity is a steady decrease down, and we are now well above the 75th percentile, or well below the 75th percentile. So most of our babies are surviving, and most of our babies are doing well. When we look at those babies that are surviving without morbidities, that means babies that are leaving our NICU without retinopathy or prematurity, necrotizing enterocolitis, interventricular hemorrhage, chronic lung disease, those that really have none of our major morbidities, you can see that, again, our trend is increasing over the years, very similar to Vermont Oxford Network, but we've actually crossed percentiles, starting off at about the 50th percentile, and we're now up around the 80th or 90th percentile of our babies leaving without any morbidities. Chronic lung disease is a huge challenge. And as you can see in the network, there's been very little progress over this 11, 12-year period, from about 27% down to about 23 to 24% at the 50th percentile. So chronic lung disease has been a major challenge. And even though we have done well, and you can see that our trend line is steadily down, and we're now doing about the 75th percentile for Vermont Oxford network. We are not where Columbia is, which is way down here at 3 or 4%, but we sit at about 15%. So we've done well, but our numbers are still only around the 75th percentile. What we have seen, though, is the type of chronic lung disease has changed. So the definition of chronic lung disease for Vermont Oxford network is oxygen requirement at 36 weeks corrected age. So you can have chronic lung disease and be on a nasal cannula. You can be on high flow, CPAP, non-invasive ventilation, or on a ventilator. And as you can imagine, a baby who is intubated on high ventilator settings at 36 weeks has very, very different chronic lung disease to a baby who is on a quarter liter oxygen, 100%, through a nasal cannula, but by definition also has chronic lung disease. But these two babies are very, very different babies. So looking at our data, again, the dotted line is the 50th percentile for the Vermont Oxford network, and the solid line here is our data from our NICU. And you can see that the percent of babies that leave our NICU on oxygen is about 15%, which is the majority of our babies with chronic lung disease. Vermont Oxford network is about 28 to 30%, so we are at about half the amount of babies compared to the network. Looking at babies with high flow nasal cannula, again, you can see we are about 50% of the Vermont Oxford network 50th percentile, and about 5% of our babies are going home on high flow nasal cannula. I'm sorry, not going home, but are on nasal cannula, high flow at 36 weeks. Very few babies are on CPAP, somewhere about 2 and 3% are on CPAP at 36 weeks, compared to about 6 to 8% of the Vermont Oxford network. And on non-invasive ventilation, again, we're about half of the Vermont Oxford network at about 2% versus about 1% in our NICU. And for invasive ventilation, about 3% at Vermont Oxford, and we sitting around 1 to 2%. This here really takes one baby a year to change this number. So we typically have 1, maybe 2 babies a year that are ventilated at 36 weeks. And they are typically the babies that have prolonged rupture of membranes and severely hypoplastic lungs. And we feel that that is not a ventilator issue as much as it is a pulmonary developmental issue. And those babies are very challenging for us. So in conclusion, what we've talked about today is NAVA is synchronous for breath initiation, for size, and for termination of the breath. The neural trigger works independent of air leaks. So this is the only mode that is available that is synchronous for non-invasive ventilation. The NAVA level distributes the work of breathing between the patient and the ventilator. The higher the NAVA level, the more work of breathing is coming from the ventilator. The lower the NAVA level, the more work of breathing is coming from the patient. Throughout all that, though, the patient controls initiation, size, and termination of the breath. The apnea time provides a minimum rate and should be set at 2 seconds or lower than that. The peak pressure limit should be set high enough to allow for large recruiting breaths, somewhere between 35 and 40 centimeters of water, and appears to be safe. The peak pressure and tidal volumes that are seen are mostly below the typical range for conventional ventilation. And the early use of NAVA, as soon as the babies come into the neonatal intensive care unit, resulted in less BPD overall in our neonatal intensive care unit and in significantly less severe BPD in those neonates that did develop BPD. Thank you, and I'll now be available for any questions.
Yeah, there. Dr. Mu, your microphone is on mute.
Okay. Thank you for Professor Stan's wonderful lecture. I'm another moderator, switching for the Dr. Mu. Okay, from Xinguang Memorial Hospital. Okay, the chat box, one question to remind when you use the CPAP, do you use the AD caster to titrate the CPAP, the CPAP level? I think it's NAVA level. So the question similar as, so I have the one talk in online workshop to talk about the heart monitor in ventilator strategy, to talk about AD caster as monitor. AD caster as a monitor when the CPAP, I think the NAVA is level is 0. So did you have any comment about it? I think the AD caster as a monitor. Howard?
I didn't understand the question. Can you repeat the question?
I mean, in the chat box, remind use the CPAP.
Okay.
When we use the CPAP, do you use the AD caster to titrate? So I mean, did you have any comment to use the AD caster as the monitor?
We have not used the EDI catheter to titrate the CPAP levels. In the adult literature, they show that there's a correlation between the EDI minimum and the PEEP levels, the de-recruitment of the lung, the tonic activity of the lung that prevents de-recruitment correlates with your EDI minimum. So in the adult literature, if you watch the EDI min, you can adjust your PEEP level depending on where your EDI min is. In neonates, EDI min is very erratic. It goes all over the place and it's not reliable. So we do not use it as a way to titrate. We will use more our work of breathing and our FiO2, the same way as everybody uses to use titrate CPAP levels.
If the neonates have an air leak or some kind of unilateral diaphragmatic paralysis, can you use the NAVA primary?
If they have unilateral diaphragmatic paralysis, NAVA still seems to work. We still be able to pick up a signal. So in babies with diaphragmatic hernia, or if they've had a PDA ligation, now they have paralysis, as long as the diaphragm area near the spine, the crural diaphragm, is still getting a signal, on either side, the EDI catheter will still pick it up. So we have found that with babies with diaphragmatic hernia, there's a number of experiences that have been published that show that even if you do a primary closure or a patch closure, you can still pick up the signal clearly and you can still ventilate with NAVA. With diaphragmatic paralysis, we have successfully ventilated with intubated babies, but once we've extubated, even with NIV-NAVA, the particular baby we worked with was not able to survive on just the one healthy lung. So that baby needed to have their diaphragm pulled down and plicated in order to be effective. But when we were ventilating invasively, it seemed to be adequate. But non-invasively, it was not very good.
Okay, thank you, Howard. Professor Ye.
Hi, Dr. Stein.
Moderator.
Hi.
Dr. Stein, thank you for that wonderful lecture. And in fact, this is a very physiological way to ventilate a baby. And I congratulate you have that kind of idea and come out to be a NAVA. I have a couple of questions. The first question is, if you think the signal from the respiratory center to the diagram is strong, is appropriate enough for a baby with severe RDS. As you know that in the baby's lung with RDS, there's different part, different millions of alveoli with different size, different airway. In fact, actually, no matter what kind of ventilator we used before, we always try to define what the proper airway pressure, what's the proper volume. And it's very difficult to define because there are uneven distribution of the air in the lung. So one of the question is, when you use NABA, what you have experienced if you ventilate the baby with high frequency oscillator first and then put a NABA? Do you think it makes some difference? Because I found some of the ratio you 30, 35 actually is quite high, although it's not many of them. How about use high frequency oscillator first and then you put NABA? Would that probably better? Second question is, now you use a definition of BPD, why don't you use a 28 days personal age? You use a 36-week definition. I know it's a different way of defining the BPD.
All right, I'll answer the BPD question first. This is not our definition. This is the Vermont-Oxford Network. This is the definition that they've picked. So that's how they present their data, and that's why I presented it that way. But I'm aware that there's a lot of other ways to present this data, and oxygen at 28 weeks is definitely another good marker. But I can only present the data that I have to work with. I can use our data differently, but to use a comparison group, I don't have that sort of ability. So I went with the Vermont-Oxford definition. As far as high-frequency ventilation in these micropremies as an early strategy, I know that that has been used very effectively. There are no studies that have looked at early ventilation with high frequency versus early ventilation with NAVA. Those head-to-head studies have not been done at this point, so I don't have the answer to it. But I can comment a little bit about the respiratory drive or the brainstem signal with severe RDS. Severe RDS seems to be a disease of the lung, not necessarily a disease of the brain. And their signal appears to be an adequate and appropriate signal. The disease is not very homogeneous. There is areas with overinflation and underinflation, just depending on how much surfactant there is. And I know that we've always strived to measure these different things. As you say, it's difficult to measure the pressure. It's difficult to know exactly what the baby needs. But it seems to be that the baby does a better job in figuring it out than I'm able to do. I'm guessing based on animal literature, based on other babies, whereas the babies using their brainstem and their chemoreceptors and their baroreceptors to make a decision breath to breath what they might need. And their response seems to be excellent. Even in our babies as young as 22 weeks, we bring them in from the delivery room, we put them straight onto NAVA, and within 36 hours, they are ready to extubate, and we typically move them to non-invasive ventilation by 48 hours. I would say even as young as 22 weeks, 90% of our babies are extubated at 48 hours. Not all of them stay extubated, but even again, with 22 weekers, occasionally one of them will stay extubated. So I do believe that their brainstem is mature enough to do it. Their diaphragm's not always strong enough. Their lungs are not always big enough, but I do think that their brainstem appears to have an appropriate response to the different things that go on.
Thank you.
I see another question.
Thank you, Harm. Thank you.
I was going to say, I see another question in the chat box here that it says, when you use the high pressure,
okay.
do you use that in newborns with airway obstructive disease such as meconium aspiration syndrome? Again, yes, we do, because we, just from a lot of experience, we trust that the babies know how to do this better than I know how to do it, because the babies got all these feedbacks that allow them to choose the right thing. If we have a baby with meconium aspiration syndrome that is on CPAP, is not sick enough to go onto the ventilator, we allow the baby to take whatever size breaths they want. We don't control it at all. We've just given them a little bit of support, but they pick big breaths and small breaths. When we put them on the ventilator, we allow them, in our unit, we allow them to continue to do that. So even with meconium aspiration syndrome, NAV is our go-to mode. And again, we find that they ventilate adequately. They don't over-distend. If they're air trapping, they seem to be able to figure it out the same as they would if they were just a little bit less sick and requiring CPAP. With things like meconium aspiration syndrome, we watch very closely for pulmonary hypertension. And if we see pulmonary hypertension, we follow a lot of the nitric oxide literature, where the evidence is early use of nitric oxide seems to give you better results than later use. So we will start nitric oxide. And over the last few years, we found that we have managed to take care of most of our babies with meconium aspiration syndrome non-invasively with early use of nitric oxide and non-invasive NAVA. Now, fortunately, we don't see a lot of them, so I haven't been able to collect enough data to put together a report. But we have found that our sickest babies that we used to have, where we needed to put them onto ECMO, those numbers seem to have decreased over time as well. But again, the numbers are small.
Okay. Thank you. Thank you, Har. Thank you. You accept our invitation because you have to get up so early because the time is limited. Thank you, Howard. Thank you. Good morning.
Thank you so much for inviting me. It was a pleasure to do this.
Dr. Cahan's here in Toledo.
Yeah, nice to meet you. Okay.
Okay.
When COVID pandemic infection is over, welcome to visit Taiwan. Okay.
That would be wonderful. Thank you so much.
Bye.
Okay.
Bye-bye.
Thank you.
Bye.
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 Bye. Thank
Bye.
you. Okay. Bye. It's a wonderful lecture. Let's pass on the next talk because the time is late. Welcome, moderator, Professor Yo Chun. Professor, please.
Hi, everyone. I am Yo Chun Su, a pediatric pulmonologist from Ida Hospital, Taiwan. And the other moderator is Professor Lai. He will hold the Q&A section. It's my great honor to introduce the speaker, Professor Raymond Orders. Currently, he is the Chief of General and Gastrointestinal Surgery, and also the Director of Minimal Invasive Surgery in University Hospital, Cleveland Medical Center, the United States. Professor Orders is a world-renowned surgeon and a distinguished expert in the field of diaphragm pacing. The diaphragm pacing has developed for more than 2 decades. This technology has helped many patients suffering from spinal cord injury, severe neurological disorders, and post-surgical patients. Today, Professor Orders will have a special speech. The title of the speech is Diaphragm Pacing Experience, the Growing Role in Pediatrics. Now, we start the speech by Professor Orders. Please start.
I'd like to thank all of you for having me speak this evening. I wish I could be in person. It'd be great to be at the 6th Annual Scientific Congress of the Asian Pediatric Pulmonology Society, the 23rd Annual Conference of the Taiwan Society of Pediatric Pulmonology and Critical Care Medicine, 12th Annual Scientific Congress in Pediatric Pulmonology for 3 places across the strait. Today, I'm going to be talking about my diaphragmatic pacing experience and a growing role in pediatrics. Conflict of interest is everything I'm talking about today was actually developed at my university with myself and researchers at Case Western Reserve University and University Hospitals of Cleveland. No other investigators had a conflict of interest. The problem, as we all know, is the increasing ventilatory burden, resource burden, morbidity. The COVID-19 pandemic highlighted this. We know prior to the pandemic, over 100,000 tracheostomies for failure to wean mechanical ventilation was performed in the United States each year. We know that 40% of the time on mechanical ventilation is spent weaning after the acute event. And this is really from ventilator-induced diaphragm dysfunction. 50% of diaphragm atrophy occurs in 24 hours. There's rapid conversion of type 2B muscle fibers. We know tracheostomies have inherent risks. Part of the solution is to maintain diaphragm strength and drive respiration with diaphragm pacing. Diaphragm pacing has been shown to decrease the 40% of the time the patients spend weaning by 60% in previous experience. The background is I've spent 25 years in research on this aspect of diaphragm pacing so far. Numerous animal models, canine, swine, rats. I have multiple IRB protocols and IDE protocols for this. There's been over $60 million spent on this project. Over 2,000 patients have been implanted with this type of technology worldwide in 28 countries. My own institution, we've done over 700 implants. Obviously, I've had multiple publications and book chapters on this topic. It really comes down to how do we breathe? We all know we breathe based on our prebascular complex or lateral medulla. Most of us don't think about breathing. We know we can use our cerebral cortex to breathe. Then it kind of goes down from that trackways to our lower motor neurons at C3 to 5, the spinal cord. And the phrenic nerves have to be intact, and your diaphragm motor units. If a patient has lost control of their upper motor neurons, that's where diaphragm pacing can overcome. We also have a strong evidence now that diaphragm pacing can help prevent ventilator-induced diaphragm dysfunction, maintaining diaphragm strength, and a lot of data now on recovery from an injured nerve. And I'll share a lot of this with you today. The objectives really is to talk about both the chronic system, which can be used up to 20 years, which is the NeuroRx. It's used in spinal cord injured patients, injured phrenic nerves, central sleep apnea, neuromuscular diseases that we'll talk about. And then the temporary system that got FDA emergency use authorization in April of 2020. It also has European CE mark approval. This is for use for less than 30 days. It can be placed at the time of a laparotomy, a sternotomy, a thoracotomy, laparoscopically or thoracoscopically, and that can be removed when you're done. It's actually a great way to help maintain that diaphragm strength. And really what it shows and what we're trying to show is what can occur is when we're doing this for our chronic system, we check the diaphragms. And you can see here, this is a laparoscopic view of the right diaphragm. Right now you can see nothing's happening. Then we'll go over and look at the left diaphragm. This is a complex patient who had a gunshot wound to the neck where the right phrenic nerve and motor neurons were damaged. And look at the left side. Great movement. And again, that's what can happen. This patient had been on a ventilator for 5 years. That diaphragm can still be stimulated. We've developed a way laparoscopically to identify the motor point, the best spot for contractions. We then place electrodes in the diaphragm. We place 2 electrodes on each side, as you can see in this video here. Then we can stimulate the diaphragm. Again, the anterior diaphragm, you'll see contracting here, and the posterior diaphragm, and the entire diaphragm. We place these electrodes to drive diaphragm contraction. Therefore, that drives ventilation for patients that need the chronic system. And then we program the device. The device is a percutaneous device, even for our chronic patients. And we can maintain that tidal volume, allow the patients to breathe throughout the day and night, 24 hours a day. We program the patients to give the best tidal volume at the best rate for these patients. In pediatric patients, we can go a much higher respiratory rate than adult spinal cord injured patients. Easy enough to program what the patient needs. It's almost like programming that ventilator that you're all so familiar with. This is the new temporary system. This is a video showing how the electrodes can be placed at the time of a median sternotomy. There's one electrode already in the diaphragm, then placing a separate second electrode in the diaphragm. As you can see, it can be done in open fashion. These are new temporary electrodes that work very well to be placed at the time of another operation. And then we bring them out percutaneously, just like you would a temporary cardiac pacing, which is put in just about every open heart operation that's being performed. And so you'll have 2 electrodes on each diaphragm. You'll bring them out just like the temporary cardiac electrodes that are here. Again, identifying a way that we can place these temporary electrodes for high-risk patients. In 2020, obviously, as we all know, throughout the entire world, the COVID pandemic changed what we looked at. And so my experience in diaphragm pacing, both the chronic system and the acute system, kind of changed as we looked at any way to get any patient off the ventilator faster at my institution. And so I implanted 125 patients in my institution last year, 64 patients with the chronic patient system. I'll kind of go over each one of these groups a little bit, but they go from idiopathic frank nerve dysfunction, spinal cord injured patients, bilateral diaphragm dysfunction, just to wean patients, and then the temporary electrodes in 61 patients. Most commonly, this was done through a median sternotomy with cardiac procedures. During our peak of our pandemic, we were only doing emergency cardiac cases, so they're all high-risk cases, lung transplants, heart transplants, and several COVID patients. It really goes back to diaphragm pacing. It really started with my research in spinal cord injured patients. The first patient we ever implanted was in 2000. We all know the problems if you're a high quadriplegic. Many spinal cord injured patients require intubation. We know that the leading cause of death in spinal cord injury, if you're on a ventilator, is pneumonia. We know it's extremely expensive to be on a ventilator. We know it changes everything. And here you have a picture of my second patient I ever implanted, Superman, or Christopher Reeve. We've published a lot of our success, and I'll just share with you some of our most recent articles. This is one from 2018 showing 92 of my chronic patients that we implanted, spinal cord injured patients, showing that we can get many of these patients off the ventilator at least 4 hours. Again, depending on your injury of your spinal cord, it may not work in everybody. And I'll talk a little bit more about that later. But we do know it definitely improves survival in these patients. One of the interesting things we found early on is that we can actually read our implanted electrodes. I can see when a patient recovers breathing. We know that electrical stimulation or physical therapy helps a spinal cord injured patient recover. We know that by stimulating the diaphragm, we can help a patient recover their own breathing. And as you can see, I can see the EKG artifact, and I can see recovery of the patient's own breathing. This is without stimulation. This can occur a while after the injury as they relearn pathways around that spinal cord injury. You'll see a lot of this because reading these implanted electrodes has really become what we do in all of our patients to look for our results in these patients. It's a patient that we can show how early we can do this without a tracheostomy. Patient who had 16-year-old injured in a wrestling accident, 21 days on a ventilator, transferred to my institution. I implanted him, extubated him 2 days later with no tracheostomy. We subsequently, as you can see here, he got recovery, and we pulled these chronic electrodes we can still remove. This is a very happy gentleman who says no scars on my neck, no adverse risks of that tracheostomy. And the patient's in bed for that first 21 days. No rehabilitation is being done on that patient. Getting off the ventilator is everything initially in these patients. This is Dr. Kerwin, who from Florida kind of talked about going from the usual 61 patients to diaphragm pacing. What he showed is that early mortality rate went down. That's significant because the longer you're on a ventilator, the greater chance you get for pneumonia, the greater the risk for death from that pneumonia is. He showed how many ventilator-associated pneumonia days went down once you went diaphragm pacing. Length of hospital stay went down. Again, more data showing that you can decrease mortality and the length of hospital stay. He also showed how, again, the amount of time on the ventilator in another group of patients, 37 diaphragm pacing, and the 34 without, time to ventilator reading 10 days from 30 days. Huge change in the management of a spinal cord injured patient in our acute trauma hospitals. And he actually looked at the cost savings. Again, we know the cost savings can be significant. Every day that you're in the hospital, especially if you're in ICU, is extremely expensive. He showed a cost savings of $150,000 US by using diaphragm pacing early per patient. So we've shown now that, one, we improve survival. We've shown that we can save money, decrease ICU days, decrease ventilator days. All these things are so important in our early trauma patients with spinal cord injury. We've shown other results in the past about decreasing pneumonia rate. This is a study out of Europe showing, on average, if you're a spinal cord injured patient on a ventilator, you get 2 pulmonary infections a year. When you get off the ventilator with diaphragm pacing or phrenic pacing, it goes to 0. This is just an example of this. This is one of my own patients with a elevated right diaphragm, right lower lobe collapse. And actually, he could move one diaphragm and not the other diaphragm. He's a spinal cord injured patient. We added pacing. We can clear out that atelectasis, no longer an elevated diaphragm. Again, all this data that we can show, and actually some of this early data led me to many of our other aspects of our research. One thing that I did publish, many times people think, how do you know if you can implant these patients? Do we need a phrenic nerve study? We've shown now on this study that I published just this year that no, the best thing to do is to go to surgery and look laparoscopically. You can have a false positive where you think you can implant this patient, but more importantly, you have a false negative, or that phrenic nerve study that wasn't positive, but when we go in at surgery, we can stimulate the diaphragm. So again, in a patient on a ventilator doing a diagnostic laparoscopy, it's not that risky. And if you can get that patient off the ventilator, it really changes their life. And this is what I mean by changing life. This is a teenager who was intubated on bed rest for 6 weeks. He was transferred from Kuwait to me in the United States. We implanted him, extubated him. He was an incomplete spinal cord injury patient. Here he is learning to walk again, diaphragm pacing in his pocket. Again, if you can get a patient off the ventilator, the rehabilitation is so much better. And again, this is the critical aspect of early diaphragm pacing. Patient recovers breathing, we can then remove these electrodes. Now, the pediatric applications, you've seen several of my pediatric patients. Initially, the first time I published this was on patients until the FDA allowed me to start working in children. I published a group of 11 spinal cord injured patients who were injured as children, and I implanted them as adults, showing it was worked many years after that. And then this is my first publication of my first 6 patients, pediatric ones that we implanted. And since then, we've done a whole series of other indications, including acute flaccid myelitis. I'll kind of talk about these other indications now. But first, I want to talk about some of our excitement in the NICU. We've been looking a little bit on, can we help patients who've lost diaphragm function? Again, this is my first patient in the neonatal intensive care unit that we implanted. Again, no movement on his diaphragms. You can see his feeding tube, his tracheostomy, our pacing wires coming out. We could read this activity, no activity. Then he started recovering his activity. Then we removed his tracheostomy. So again, helping somebody with some reason with lack of diaphragm control. And again, we'll do a lot of work, and I'll show you on our next patient also. This again, an ultrasound showing no movement on the right diaphragm, some movement on the left. And you can see me checking at surgery. Here's just the right diaphragm. And then all of a sudden you'll see me stimulate. You'll see a nice big contraction. So we can stimulate that diaphragm. If we can see that at surgery on this 8-week-old, 4-kilogram child, we can implant these electrodes and help maintain that ventilation on these very small patients. And what was so exciting on this patient is initially we had very little diaphragm. This is the left diaphragm's activity. This is the right diaphragm. And really a lot of apneas when patients on a ventilator, no diaphragm activity. But on day 10, when we turn off the pacing, we start seeing good burst activity on both sides. We're actually able to wean this patient off the pacer, wean them off the ventilator. Again, that really changes our management in the intensive care unit, where we look at what is one of the problems. Is there a lack of ventilation on these children that we can overcome? We've done a little work with Pompeii's disease. You think it's a primary muscle disease, but as I've said, we started identifying a lack of muscle control. The preboscular complex, the lateral medulla, can be affected. In this study that we published, as patients were getting their enzyme replacement, we added diaphragm pacing, and the patients were able to recover even better and get off the ventilator. Done some work in SMA2 patients. Again, a patient with no activity, had intubated. We put in the diaphragm pacing. We identified, even though SMA2 should be a lower motor neuron disease, the phrenic motor neurons were intact. We weaned this child off the ventilator. It was an 18-year-old. Again, that's usually when they go on the ventilator. And I've done a second patient. So again, there's a central component in many of these pediatric neuromuscular diseases where diaphragm pacing can overcome that lack of control for them. I'm going to talk a little bit more about this idiopathic, or unilateral diaphragm dysfunction, or bilateral, that patients lose control. Again, I showed you a picture of one of my spinal cord injured patients. By 2014, I already was looking at a series of patients. My first publication on this, where in this group of 20 patients, we had 86%. We got recovery of that. We were able to wean some patients off the ventilator that had been on a ventilator for a number of years because of diaphragm dysfunction from a phrenic neuropathy. And again, this is an example, very elevated diaphragm, normal. Patient can move. EMG activity on the right, nothing on the left, recovery. So this goes down to a lot of our research on electrical stimulation, helping nerves recover and controlled recovery of that diaphragm. We presented this last year at the virtual ATS conference. We're up to 62 patients with about 71% recovery of that unilateral diaphragm paralysis. Again, adding something for these patients. Once you plicate a diaphragm, that diaphragm will never work again. So we've really changed what we look at, and we've gone away from diaphragm plication, at least giving a chance for functional recovery of that diaphragm. Now I'm going to talk a little bit and kind of close out talking about temporary diaphragm pacing. Since the New England Journal article in 2008 showing that how rapidly the diaphragm's atrophy, how rapidly it converts to type 2B muscle fiber, numerous studies have repeated that. And we know there's, in the United States, 400,000 patients have mechanical ventilation. We know that this became a problem because our ICUs got filled with COVID, along with our usual patients for that. We know tracheostomies have a significant complication risk. In the United States, it's extremely costly for chronic mechanical ventilation. In every one of your countries, I'm sure you have many chronically ventilated patients during that recovery. Can we help them get off the ventilator faster? And I also looked a lot at cardiac surgery as a good model for that. We know that in cardiac surgery, after an open heart operation, 12% require mechanical ventilation after 24 hours and 4% after 5 days. And it's a good study because that database on them is so well looked at that we know that infection rate goes up. We all know that if you're on mechanical ventilation, the cost goes up. And can we change that? And I started doing a lot of look into that. So I started using our chronic system on patients who had phrenic nerve injuries after open heart surgery. We showed that we could help 9 out of these 10 patients. We presented this in 2018. We know that we can improve the survival. If you're on a ventilator after an open heart operation, your 1-year survival historically has only been 30%, because that's how severe being on a ventilator is for these patients. Our 1-year survival was 80%. And we actually went up to 23 patients in 2019. We presented a much larger group showing with our chronic system, we could help these cardiac patients. In this time frame, we're looking at, again, this is a perfect example of a patient who had the left ventricular assist device, injured phrenic nerves. Again, showing on these diagrams, recovery. So our electrodes can stimulate and read, and we know the patient recovers. Now this patient is a candidate for a heart transplant. Again, we had a lot of this evidence, what we're doing, that led us to, at the same time, start looking, could we put these electrodes in high-risk patients? Temporary electrodes. And this is our publication in 2018 of our initial study, ID, showing that, one, we can implant them. We don't need to do that mapping because we can see where it's at. We can get a tidal volume over 137% predicted of these patients. So we can stimulate enough to ventilate these patients, placing these electrodes at the time of an operation. We showed in this study that we could do it during laparotomies, laparoscopies, median sternotomies. And again, it showed the ease of placement and removal, complete removal of these electrodes. So we now had a way to get to the diaphragm during another operation and actually perhaps put them in at the time period. And really, the COVID pandemic kind of showed that we could do that. So in last year, in April 2020, our temporary electrodes were FDA authorized, and we started placing them. This is a great example of a patient, emergency open heart, waiting for liver transfer. This is a temporary system, typical median sternotomy with 3 chest tubes. Patient was in a hepatic coma while waiting for liver transplant after his emergency heart bypass. We just had him on CPAP with the diaphragm pacing. So we can just manage that diaphragm on a patient that had no activity or because of their coma until they got the ventilator. So we're preserving both the diaphragm and really the lung, ventilating the lung. We actually did a pilot study of this group in an IDE, clinicaltrials.gov. And I'll kind of share with you results, and this paper should be coming out shortly. Our primary endpoint showed we could place them during these high-risk cardiac electrode patients. We could remove these electrodes. We could read EMGs. And then we can actually stimulate them and help them get off the ventilator. So in conclusion, we showed that during these cardiac patients, it's feasible. We can definitely improve diaphragm function and ventilation, increase likelihood of extubation. Now we're doing a randomized trial in 40 patients, randomizing them to immediate use before we're waiting for 24 hours to see if we can shorten that entire time. Patients on a ventilator in our ICU post a high-risk cardiac case. We actually presented another group of patients with known preoperatively elevated diaphragms on a ventilator beforehand. And we showed and presented at the Society of Thoracic Surgeons last year, a group of these patients showing that we could, by adding diaphragm pacing at the time, we could just very rapidly wean these patients. So we're getting this evidence of these temporary electrodes at the time of cardiac operations. Again, this is an example of a patient having an emergency, elevated BMI on BiPAP pre-op, elevated right diaphragm. And we implanted the electrodes at the time of the operation. He was extubated immediately. This just shows how we remove these electrodes. Very simple to remove. Again, we were doing more looking at this. Thoracoabdominal aortic aneurysm repairs with a major thoracoabdominal incision. This has been presented at a series of these patients now. We can now actually measure in these patients how the diaphragm gets stronger with the patients. The power density spectrum shows by pacing them. This is, again, high-risk patients, an infected aorta, a major operation on bypass. And again, we can implant these electrodes at the time of the operation, pace them immediately. We showed in all these patients, we're able to very rapidly wean them off the ventilator, maintain that diaphragm strength for them. And also at the same time period, I've been looking a lot at lung transplants. And again, a group out of Europe showed their work at the time. We know that at the time of a lung transplant, there's a very high incidence of phrenic neuropathies that occur in diaphragm dysfunction. And so we showed at this initial report that we can place them, we can read EMG, we can pace these patients. Led to our initial presentation with our chronic system at ATS 2020, 3 cases out of Oklahoma, where the phrenic nerve was injured, and we can overcome the morbidity of the phrenic nerve injury by adding diaphragm pacing. Kind of our conclusion there, interestingly, was the future may involve placing temporary electrodes at the time of the primary procedure, which we subsequently did. So we now had, with a Transaris now being available, we can place them at the time of lung transplant. It allows us, and we presented this at the heart-lung transplant meeting just this past April on a group of 8 patients, 4 with the temporary and 4 with the chronic system, because that was kind of looking at patients with phrenic nerve injuries and those patients that we implanted. We now have a much larger series of lung transplant patients that we're presenting at a future meeting also. What we showed in this group of patients that we can identify phrenic nerve dysfunction early. 2 patients had normal diaphragm EMG activity, easily extubated. 2 other patients had significant bilateral phrenic nerve dysfunction, and we started pacing them. We could look within that first day, we could predict, and in our next 10 patients, we continue to be able to predict if they're going to be a difficult wean or an easy wean. In COVID-19, it's been very difficult. As we all know, COVID-19 mostly affects oxygenation for these patients, but there is some patients that with the long COVID get a neuropathy. Again, you'll see on this video here, a patient trying to breathe with, I love doing sniff fluoroscopies, can't move his diaphragm at all. We've implanted several patients with this where we can help that neuropathy recover after their acute oxygenation problem's over, trying to get them off the ventilator at that point in time. So it's been a very limited utilization for this because as we all know, when you really get on the ventilator and you have such bad oxygenation, your overall survival is fairly poor. And so, but we have been looking at this on a subgroup of patients. And I know I wish I was in person with all of you, and I kind of go to my conclusions now. I know I talk fast. I think sometimes I talk faster on Zoom than if I was in person with you, because then I could look and see what was going on. But I hope we'll be able to talk and discuss this here a little bit while you're finishing your meal, if that's what's occurring. And really, it's pretty straightforward. All spinal cord injury patients should have an implantation. The data is overwhelming for these patients. The quality of life changes significantly for them. And when I look at pediatric indications, and really in our pediatric care unit, now in our NICU, we start looking, why can't we wean this patient? We'll do ultrasounds. Patient can't control the diaphragm. Why is that? Can we add pacing to help them get over that hump? And so it's really been exciting as we look for these indications. We know in Pompe's, acute flaccid myelitis, SMA2, we have very good data on that now. So it's something to look at on your patients. Why can't, is it lack of that drive for ventilation? And we know in high-risk cardiac patients and lung transplant patients, then temporary electrodes really can change how we manage them perioperatively to identify patients that will be difficult to wean, to help them if we identify that nerve injury early, All the data shows that. And really, what we start looking at is anybody that we're thinking about a tracheostomy. I'm a surgeon, I do tracheostomies. I know there's a risk with tracheostomies. I've seen patients with chronic tracheomalacia, which we have no good therapy for. We know we can have bleeding. We know there's a death rate for tracheostomies when we look at the data. And so, one, can we look at diaphragm pacing to add to these patients? That's something that we're all really looking at now and helping any patient we can get off the ventilator, since we know the difficulty with chronic ventilation that we have, even acute ventilation, the lack of ventilator beds, and what's occurring worldwide now is just heartbreaking. If we can do anything to help get patients off, to open up another ICU bed, that's important to offer to people. And again, it's a fairly simple concept. I mean, if you move the diaphragm, you're going to improve ventilation. It's something we've really been looking at for a great period of time. And again, and all my patients are part of research. And so whenever we all do research, after a year, I have to say, hey, do you want to go back to the ventilator, not do diaphragm pacing? And fortunately, all these patients that I've had for 20 years of doing pacing, nobody says, you know something, I really like the ventilator. Using your own muscle for ventilation really helps and will help significantly. My email is down here, and please feel free to email me at any time, raymond.anders@uhhospitals.org. And it's been great. I wish it'd be in person, maybe 2022. Again, reach out if you have any questions, as we all try to figure out ways and collaborate on working on helping every patient get off the ventilator. Thank you, and I wish you all well and be safe.
Thank you. Thank you. Your amazing talk and a good result, Dr. Owner. And because the time is limited, because the lecture is delayed, so we just open for 3 questions for all the audience. And there are one question about come from Angle. He said the electrode will have the lifespan. How do you monitor? You will need to replace this electrode.
That's an excellent question. And again, thank you for allowing me to speak with all of you today. I wish it could be in person. One is we check the resistance every time we pace the patient for every breath, so we know if the electrode would have a problem. Fortunately, these electrodes designed by my university actually have an incredible lifespan. We've been using them for every minute of every day for up to 20 years now without a problem. When I designed this, I did design 2 electrodes for each diaphragm, so we always have a backup electrode if needed. But so far, the electrodes have been very successful, not having any problems for replacement. But we do measure the resistance electronically, so if the problem would develop or electrode would have a difficulty, we could know that before there's a problem for these patients.
Thank you. Thank you for your answer. Another question is come from Dr. Will Chun. He said, does the utilization of temporal diaphragm pacing is increased during this kind of the COVID-19 pandemic? And I have another question for this one, because you have a good presentation for the last case of the COVID-19 related neuropathy and or myopathy. How this patient is he recover or persistent?
Our data for injured phrenic nerves is very strong, or a neuropathy. So we all know that physical therapy will help a nerve recover. As we all know, it's hard to do physical therapy of the diaphragm if you can't move your diaphragm. Adding the electrodes actually helps that diaphragm recovery, which actually helps the nerve to recover. There's an afferent effect when you do distal muscle stimulation that it'll actually help that nerve recover. So, my biggest experience is an idiopathic diaphragm pacing, because we'll have patients with a unilateral elevated diaphragm, like that NICU patient I showed you earlier in the video. That actually helps the nerve to recover, and then the patient can breathe on their own. Then we just pull these electrodes. It goes back to the concept of everybody undergoing an open heart operation has temporary cardiac pacing just in case. Adding these electrodes at the time of another major operation is easy to do. You kind of have a safety because we can now read it. I like the NAVA where you're reading EMG. We read the EMG with our implanted electrodes. We can tell if the patient has the apneas. If the patient has apneas, we can start pacing to prevent that atrophy of the diaphragm, maintain the entire respiratory system by pacing the diaphragm directly.
Thank you. Thank you, Dr. Olden. Another question come from, it's come from the Dr. Chen. You already presented this question in the video. He said, can spinal muscular atrophy patient use diaphragm pacing? So I saw you show in the video. So I have another question, because we know the iatrogenic injury always induce the unilateral diaphragm paralysis. Is this kind of pacing can use for the rehabilitation for this kind of patient?
Absolutely. As we all know in lung transplant, where I'm doing a lot of research now, when you explant a fibrotic lung, there's a high incidence of temporary diaphragm injuries. What we can do at the time of a lung transplant, we can place these electrodes while we're there. Therefore, we can monitor for that injured nerve. And as we all know, if you can't move your diaphragm, you're not going to ventilate the lung appropriately. Our diaphragm causes ventilation in the posterior lobes of the lung. As we all know, mechanical ventilation doesn't really ventilate the entire lung well. So by driving the diaphragm, even with an injured nerve, we can cause that diaphragm to contract, will help the ventilation of that lung. And that's kind of, we know in redo open heart surgery, we know in difficult pediatric open heart surgery, there's this instance of phrenic nerve dysfunction. Adding the ability to do physical therapy for the diaphragm, that's really what these temporary electrodes is. It's aggressive physical therapy for that diaphragm when it can't contract on its own. That helps the nerve to recover. There's some incredible data now on distal muscle stimulation helping nerves recover after injury. That's the benefit of at least having these electrodes available post-operatively after you've had an injured phrenic nerve.
Thank you. Your excellent answer. Because this is so delayed, so we have a limited time. So I must close this discussion. And thank you again, Dr. Olden. And this is the end of today's conference. So see you guys tomorrow, and good night.
Thank you so much for having me here. It's wonderful to talk with all of you.
Bye-bye.
Thank you, Raymond. Thank you for your goodness, because I see you have already answered the question in the chat room. Okay. Thank you, moderator, Professor Su and Professor Lai. Thank you, my assistant, Dr. Chao Pei. And thank you all staff and colleagues from Taiwan Society of Pediatric Pulmonology and Critical Care Medicine. It's the first day of APPS 2021 Congress. Don't go away. Please enjoy the first day, the wonderful ending show. See you tomorrow. Thank you.
Thank you, our dear audience, including the members of the Asian Pediatric Pulmonology APPS and Taiwan Society of Pediatric Pulmonology and Critical Care Medicine, the TPPCC, and good friends to love to contribute to pediatric pulmonology care, critical care for children. My dear friends, thank you for your joining the first day of APPS 2021 Congress. Today, we have already enjoyed the lecture of distinguished speakers and great performance of moderators. Right now, in Taiwan, it is Yin Festival holiday. Mid-Autumn Festival, we also call Yin Festival or Mooncake Festival. This year, 2021, the Moon Festival falls on September 21st. We are in Moon Festival holiday right now. Moon Festival is also celebrated in many other Asian communities. In Taiwan, in China,
It is a reunion time for family, just like Thanksgiving. So in our today's program of the 2021 Congress, it does mean our professional reunion. The professional reunion to concentrate, to contribute. We are the world. We are the children. We do everything and efforts for our children. For the important purpose, we do professional reunion. That's the meaning of the Moon Festival. So tomorrow, the second day of APPS 2021 Congress, we prepare young investigator presentation, the original research and clinical case report. Finally, we have the award ceremony. More excellent talk and lecture, e-poster. Expect and wish tomorrow morning you could consider take a professional wonderland adventure. Tomorrow, the second day of APPS 2021, AM 8:30, the program waiting for you. See you tomorrow. See you tomorrow morning. Bye-bye. See you.
Colleagues, today I am Professor Zhengong Dai. On behalf of the Faculty Committee of APPS 2020, it gives me the great pleasure to invite you to attend the 6th Annual Scientific Congress of Asian Pediatric Pulmonology Society to be held in Kaohsiung Medical University, Kaohsiung, Taiwan. The meeting includes plenary lectures, satellite symposium, parallel presentation, and exhibition. Experts from different domains will be invited to share their expertise and experience in the field of pediatric pulmonology, the features of world-class scientific program. I would encourage you to attend the APPS 2020 and look forward to seeing you soon. Thank you.
Hello everyone, have a good day. My name is Ko Han Lu. I'm the president of Dongshan Medical University in Taichung, Taiwan. Also the president of Taiwan Pediatric Pulmonology and Critical Care Medicine. Welcome to join the international meeting of APPS. Kaohsiung is a very beautiful city in South Taiwan. Welcome to Kaohsiung and welcome to Formosa, Taiwan.
Children are our hearts, our lungs. In Taiwan, we take very good medical care for children, and we are very happy to share and learn experience from friends all over the world. Come on, Get ready to be here in Kaohsiung, Taiwan. Trust me, you will have a fantastic journey here. Welcome.
Hello, this is from
Ladies and
TPPCC 在高雄 TPPCC， Welcome to Taiwan 高雄。